if you haven't seen the marathon. I mean, nothing can beat marathon. There is no doubt about that in my mind. Right. So we are going to be having a discussion now with respect to the topic of pathology. And as an standard thing, what we are trying to do over here is that we'll try to talk about the questions which are likely to be asked in your exam, both in paper 1 and paper 2. Let's get started off with the discussion, right? So the sequence shall be the same as we have been always following. That would be that we are going to be first talking about the general path component of it. Uh, Let me just share the screen. I'm just so sorry, the screen was not visible. Yeah. So now I believe the screen is pretty much visible. Can you just confirm that to me? All right. So we're going to be having a discussion on the super session of path. I'm starting off with the discussion of general path per se. I'm going to be talking about the first thing, which is going to be a very obvious topic, that is going to be cell injury. And then if I go to be talking about the causes of cell injury, of course, I want you to understand and answer the exam absolutely correctly that ischemia is the most common cause of hypoxia, and hypoxia is the most common cause of cell injury. No doubt about the hypoxia that we see in the epithelial lining happens to be squamous metaplasia in the lungs of smokers. And the other important example of metaplasia in the epithelial lining that they talk about is a patient having reflux esophagitis who's going to be having a development of Barrett's esophagus. Whenever I'm going to be talking about the presence of connective tissue metaplasia, you must remember the history of a vigorous massage of a guy having a fall, and therefore you remember about something called as myositis ossificans. Out of all the adaptations, the other adaptation that they love to ask in the exam happens to be a trophy, which is going to be a decrease in the cell size, and that is going to be an example of a purely benign adaptation. This is very, very uncommonly going to be associated with having a progression into a malignancy. Whenever I'm going to be talking about hyperplasia, one of the most common examples of adaptation, which is going to be progressing to a cancer. And the example of two conditions which they always love to ask you in the exam. The classical examples as we talk about is benign prostatic hyperplasia. So you already have an idea about the physio question, 5-alpha reductase. You already have an idea about the pharmacology question, which is going to be talking about the administration of a drug like finasteride. And you understand the fact that they do not progress to development of prostatic cancer. However, please recall the fact that when I'm talking about something called as endometrial hyperplasia, this is something that is for sure going to be having a progression into endometrial carcinoma, and the association of endometrial hyperplasia with a drug like tamoxifen that you need to keep in mind. Tamoxifen given for treatment of breast cancer, but tamoxifen at the same time is going to increase the risk of development of endometrial carcinoma in the patients. That is what is going to be asked in the exam time and again. The next thing that we talk about over here is going to be the presence of hypertrophy, which is just going to be a fundamental increase in size. It's a standard paper 2 question. You have a patient who's suffering from aortic stenosis, or a patient who's going to be having uncontrolled hypertension, who's going to be having a development of left ventricular hypertrophy that enhances the risk of development of cardiac failure in the patients. The moment I'm going to be making a mention of something called as reversible cell injury. Reversible cell injury, the earliest organelle that is going to be affected is mitochondria. You are going to be having the presence of cellular swelling in these patients as one of the earliest findings. And what you also have in these patients is a small number of amorphous densities can be seen. Amorphous densities simply represent the deposition of calcium in the mitochondria. A larger number of amorphous densities can be seen in case of irreversible injury, particularly in a patient who's going to be suffering from a condition like necrosis. I'm just going to be talking about the different types of necrosis. Recall the fact in case of necrosis, you are going to be having the damage to the cell membrane. There is going to be leakage of enzymes, and therefore enzymatic destruction is a typical feature that you associate in case of necrosis. Whenever I'm going to be talking about necrosis, there are going to be 5 important subtypes of necrosis that we always keep on talking about that fact. And these are the common things which have been mentioned in your notes time and again. So just for a quick recap, perhaps for the last time before your exam, coagulative necrosis, commonest necrosis associated with tombstone appearance. You can easily answer for me a paper 2 dermatology question. Tombstone appearance can be seen in case of which particular skin condition. Tombstone appearance is going to be seen in case of which particular skin condition. Of course, you remember the example of a condition called as pemphigus vulgaris, antibodies against desmoglein 1 and 3. Patients are going to be having a fishnet pattern. Any situation where you have a mention of a word infarct, whether I'm talking about a kidney infarct or I'm talking about a myocardial infarct, is what is going to be associated with the presence of development of coagulative necrosis. All types of organs can show coagulative necrosis with the exception of brain. Your brain is going to be having a liquefaction that's given the name of colliquative necrosis, and that is going to be associated with typically brain infections, brain abscess, and even pancreatic necrosis. Time and again, the same fact, if I'm having a patient having pancreatitis, the pancreas organ per se is going to be having the presence of liquefactive necrosis, but the peripancreatic tissue is the one which is going to be having the presence of, the peripancreatic tissue is the one which is going to be having the presence of fat necrosis. Whenever I'm going to be talking about the presence of cheese-like appearance of the necrotic material, I'm talking about something called as caseous necrosis. Caseous necrosis is because of cheesy appearance of the necrotic material that is classically associated with granulomatous inflammation. You remember about the role of interferon gamma, TNF alpha, interleukin, and interleukin 12 in that order. And you recall the fact that in case of this condition, the most common condition that should be coming to your mind is going to be tuberculosis. The other conditions that you need to remember over here is fungal infections that includes histoplasma and coccidioidomycosis, apart from syphilis. With histoplasma, remember the history of an individual going to the cave expedition and bat droppings and the presence of the word Darling's disease, Ohio fever. Whenever I'm going to be making a mention of fibrinoid necrosis, fibrin-like deposition of pinkish material in the vessel wall that we find over here, that can be seen in case of deposition of injury caused because of immune complexes and if fibrin being deposited. The aim of the मकसद हमें याद ही रखना है अपना एग्जाम के लिए. So aim of this is going to be Ashwas body, malignant hypertension, immune complex disease. Of course, the commonest examples of vascular disorders you remember over here is PAN and hinox-schonlein purpura. PAN is something that you associate with hepatitis B. It's an example of a DNA retrovirus. That's a micro question that you put up to exam. HSP is now called by the name of IgA vascular disorder, the commonest vascular disorder that you have in case of children, right? If I'm making a mention of fat necrosis, lipase or fat is what is required. You have a attachment of calcium with the fatty acids that is being given the name of saponification. Again, with the classical history of a person having gallstones or a history of alcohol intake, person is having a development of acute pancreatitis. There is going to be an increase in the amylase and lipase levels. In the peripancreatic tissue, this guy is going to be having the presence of fat necrosis, and that fat necrosis is going to be having in the presence of an appearance that is the whitish deposits over here, saponification. Out of these images, as I already talked about the fact, that's a classical image given in your FMG exam, PG exam, USMLE step 1, that is liquefactive necrosis, liquefaction of brain. Then they talk about this caseous necrosis, cheese-like appearance of necrotic material, that's seen in case of tuberculosis, as well as the other differential diagnosis that you have to rule out over here is histoplasma. Then they make a question on something like fibrinoid necrosis, this pink color circle that you get over here, deposition of fibrin in the vessel wall is what you need to remember over here. Of course, with these whitish deposits, the presence of these chalk-like deposits, you would think in terms of saponification. Couple of years back, exam question, they asked you about the presence of a gangrenous individual, typically usually having a history of predisposition because of a peripheral vascular disease. Classically in our country, that can be because of diabetes. And if I'm talking about dry gangrene, you would associate it with coagulative necrosis. If I'm making a mention of wet gangrene, you have seen a lot of pus over here that is going to be associated with liquefactive necrosis, right? Clostridium welchii is the organism, or Clostridium perfringens is the organism, which would come to your mind if I'm making a mention of something that is given the name of gas gangrene, right? Then making a mention of, coming back over here with respect to something called as apoptosis, it is an example of a programmed cell death dependent upon the genes you need to recall. P53 is a pro-apoptotic gene. Most important, BCL2 is an example of an anti-apoptotic gene. What you have in this condition is it is an example of a caspase dependent programmed cell death. You have different types of caspases. Initiator caspase in case of initial in the intrinsic pathway happens to be caspase 9. In the extrinsic pathway that happens to be caspase 8 and 10. Both of them are going to be responsible for causing activation of an enzyme called as endonuclease. This endonuclease enzyme is what is going to be associated with the presence of something like the step ladder pattern. Step ladder pattern is what you're going to be getting in case of gel electrophoresis over here. Step ladder fever is a paper 1 micro or a paper 2 question asked in the exam that is associated with enteric fever. If I'm talking about these patients having apoptosis, cells undergoing apoptosis show you classically the presence of chromatin condensation. That's a hallmark feature. You are asked a question in the exam pertaining to the presence of different types of markers for apoptosis. One of the markers that you need to remember over here in these patients happens to be something called as annexin V. That's a very, very important thing again. Then they ask you about the clinical examples or conditions where you find apoptosis. Pathological examples can include retinitis pigmentosa, viral hepatitis, graft versus host disease. Physiological example is what most of you should be remembering on your fingertips, fetal development or embryogenesis. Majority of the anti-cancer drugs also destroy the tumor cells by the process of apoptosis because anti-cancer drugs are going to increase the activity of P53. Please also understand the fact sometimes anti-cancer drugs do not work in case of a cancer because of something called as drug resistance. The gene contributing to drug resistance or chemo resistance is MCL1. This was a NEET PG question, can be asked in your exam as well. Any question in the exam that is making a mention of apoptosis is not to be confused with a question in the exam which is giving you a word as caspase. independent programmed cell death. So read the question carefully. I repeat, caspase dependent programmed cell death is apoptosis. Caspase independent programmed cell death is the name given to necroptosis. The definition has been asked in the exam. And this is an example of a condition that is going to be dependent upon the receptor interacting protein kinase 1 and 3. In this condition, inflammation is present for sure. Please remember the fact that classical example of necroptosis can be a patient who's going to be suffering from a condition which is called as Parkinsonism. Of course, your physiology knowledge teaches you that Parkinsonism means a problem at the level of basal ganglia / substantia nigra. In pharmacology, you are already aware from paper 1 that you are going to be giving two types of drugs to these patients. Either you give a directly acting dopamine agonist to these patients, something like pramipexole, ropinirole, or you give to these patients a combination of drugs that is given the name of levodopa, carbidopa. Even though you are aware that MAO-B inhibitors like selegiline and rasagiline are known to be responsible for reducing progression, one example of a drug which is given for both Parkinsonism as well as influenza virus is amantadine. That is not to be forgotten. Of course, influenza A is what is being treated with amantadine. That is also going to cause ankle edema. That also causes livedo reticularis. That is a fishnet pattern on the skin. That is again asked as a question in the exam. Shifting our focus to the next important thing, that is going to be pigmentation. If I'm talking about iron, iron as a pigmentation is going to be seen in patients who are going to be suffering from hemolytic anemia. Particularly, this is going to be a patient suffering from thalassemia, because this patient is going to be having the presence of iron overload. And the other important thing that we need to talk about this patient is that this iron is going to be deposited in the form of hemosiderin. For detection of hemosiderin, I'm going to be using a special stain, which 99% of you would be able to recall over here. Prussian blue is what I'm talking about over here. Remember, in case of thalassemia, what exactly is going to be happening is there is going to be too much of iron absorption. Something which is going to be interfering with iron absorption is a protein that is given the name of hepcidin. Hepcidin level is going to go down in this patient. That is another important question which was asked in the AIIMS exam as well over here. The next thing that they ask on the exam is with regards to this golden brown pigment which is present around the nucleus of a cell, that is going to be given the name of lipofuscin. Lipofuscin, also called as lipochrome, the wear and tear pigment, or also known by the name of pigment of aging. The process by which this is produced is lipid peroxidation, and this is going to be often given the name of the telltale sign of injury. Telltale sign of injury. The moment I'm thinking in terms of lipofuscin, what comes to my mind happens to be cardiac tissue, hepatic tissue, and skeletal muscles. And of course, this is something which is going to be an indicator for the free radical injury in case of the tissues. Then I'm making a mention of something that is going to be the detection of oil, that is fat or lipids, which can be detected with the help of a special appearance, reddish globule appearance, that is given the name of because of oil redo, or you're going to be having the presence of an appearance that is going to be given the name of Sudan black, that is going to be giving a blackish appearance to the lipid droplets. Classical example would be lipid deposition in case of the liver tissue, which you and me call by the name of fatty liver, also technically called as hepatic steatosis. Whenever we are going to be talking about then calcium, with respect to calcium, two types of calcifications. One is dystrophic calcification, dead or degenerated tissues. Any type of degeneration or death of the cell can be having dystrophic calcification. Dystrophic calcification can also be seen in case of multiple types of tumors, out of which four examples commonly asked in an exam: meningioma, mesothelioma, ovarian serous cystadenoma, papillary thyroid cancer, and papillary cancer of the kidney. With regards to something called as metastatic calcification, the key feature over here is hypercalcemia. This is going to be associated with deposition of calcium in the living tissue as well. Chronic kidney disease, parathyroid adenoma are the commonest conditions that you associate. Granulomatous disorders like sarcoidosis would be a third important example. Not to forget about example of conditions like multiple myeloma, or you can be thinking in terms of a patient suffering from what is given the name of hypercalcemia of infancy, Williams syndrome. The moment I wish to talk about calcium, this calcium is going to be detected with the help of a bluish appearance, that is under the routine staining, or calcium can be picked up with the help of special stains which are going to be given the name of von Cosa and alizarin red. One of the important examples of calcium that is going to be seen in case of a patient suffering from sarcoidosis, which was given as a 2 exams back question, was what is given the name of Schaumann body. So the question can talk about a patient having a difficulty in breathing. He's having cough, dry cough in particular. There is a bilateral hilar lymphadenopathy, elevated calcium levels, elevated ACE enzyme levels, and this patient is having the presence of Schaumann body or asteroid body. What we are thinking in terms of is a patient suffering from sarcoidosis. Needless to say, sarcoidosis patients are going to be having the presence of non-caseating or naked granulomas. That is what we have discussed earlier. Then making a mention of something called as amyloid. In case I'm talking about amyloid, it is going to be having the presence of a pink red appearance and a normal layer. This is an example of an extracellular protein, and this protein is going to be having an appearance that is a shiny appearance under the polarized microscopy. So that is what is given the name of apple green birefringence. Now, the other important thing that we need to talk about would be the different types of amyloid proteins that we're going to be discussing shortly, right? So that takes care of our discussion so far as the pigmentation is concerned. Shifting our attention to the next topic of inflammation, you are going to be having vascular and cellular changes. The first vascular change any day, obviously, most of us are familiar, is vasoconstriction. Then we are talking about vasodilation. The characteristic feature, however, is increase in permeability. Commonest cause of increase in permeability is endothelial cell contraction. This most commonly affects venules. That's an example of a small vessel that is being affected. And this is also known by the second important name of immediate transient response. That is what they ask you in the 2021 exams question. The last change that you find over here is with regards to something that is going to be given the name of stasis. And why that stasis is going to be important is a physio question. Stasis is a part of virtuous triad, and that virtuous triad is going to increase the risk of clot formation. When I'm talking about virtuous triad, what I would like you to remember is the best of you will remember this. Of course, you know the fact you are everybody the best. Obviously, enjoying this through cerebellum. This is endothelial cell injury, blood hypercoagulability. Patient is going to be having stasis/turbulence. So this is what you need to remember. Of course, if I'm going to be talking about virtuous triad, this is going to be associated with thrombus formation or clot formation. Thrombus formation can be seen because of sometimes rare genetic disorders as well. And those genetic disorders are going to be including most commonly an example of a condition that is called as factor 5 or Leigh-Duns mutation. The moment I shift my attention to intracellular changes, that changes can be intravascular or they can be extravascular. That is what we are aware of. So what immediately comes to my mind is Mr. Rat and Mr. AD, and that the extravascular changes is called the COPS. That's what we need to remember. Margination is just going to be asked in the exam just for the purpose of a sequence. So after that comes rolling. Rolling is dependent upon molecules which are going to be given the name of Sil Lewis X. The shorter name or the easier name that I want to remember over here is selectins. That is what we need to talk about. So when we talk about selectins, it is E62 molecule. Any problem with the rolling, it is going to be responsible for causing a transient attachment only. This is what is going to be associated with development of LAD second. Classical history, patients will be having the presence of recurrent infections. They will be having short stature. They are going to be having the presence of Bombay blood group. Bombay blood group, incidentally, is a paper one question hematology. It is the rarest blood group that individuals are going to be having and are presented with a capital O but small h. Whenever I'm going to be talking about the third chain, that happens to be adhesion. Adhesion is going to be firm attachment. Firm attachment is dependent upon molecules that are going to be given the name of integrins. They are going to be interacting with the adhesion molecules. Any problem with integrins going to be causing LAD1. This is going to be causing recurrent infections in the patients. Plus, there is going to be history of delayed separation of the umbilical cord, not to be confused with bleeding from the umbilical cord, which can be seen in case of factor 13 deficiency. Read the question carefully, guys. Don't make a mistake on that one. Diapedesis, also called by the name of transmigration, dependent upon a molecule, which is given the name of CD31. That's also called by the name of a PCAM molecule. Once you're familiar with the MRAD thing, let's shift our focus to the COPS over here. So the bacteria have to be killed, the COPS have to be called in. The COPS over here are the neutrophils. The neutrophils come near the bacteria by the process of chemotaxis. Of course, you remember about the LIC policy. 485 is your LIC policy number. This is an internal matter. So these are example of endogenous chemotactic molecules. I wish you to remember and recall about the fact LTB4. Interleukin 8 and C5a is what you need to be having an idea. External chemotactic molecule would include something called as bacterial products. Opsonization, making the bacteria tastier. You are going to be eating that curry with the rice. Obviously, it's a porcelain session, so we all understanding the fact. This is going to be because of the immunoglobulin. Classically, it is immunoglobulin G that we are making a mention of. Then we make a mention of the complement 3B protein. Of course, we also make a mention of fibrinogen and C-reactive protein over here. The moment I'm going to be talking about immunoglobulin G, it is the most common antibody that we are having an idea about. A patient having Bruton's disease is having A gamma globulinemia. So those patients are going to be having a defect in opsonization. The moment I'm going to be making a mention of phagocytosis, phagocytosis is going to be dependent upon capturing the bacteria. That is going to be dependent upon a process in which you are going to be having the role played by the list protein. List protein is going to be bringing the captured bacteria near the lysosome. And the second thing is then you're going to be eating the bacteria. So you can be using it without the oxygen. You can be using it with the oxygen. Any problem with the list protein is going to be responsible for the patient suffering from a condition that is given the name of Shidia-Higashi syndrome. Multiple times we talked about the same question. This guy is going to be having albinism, recurrent infections. He's going to be having the presence of high chances of hemorrhage. He's having neurological manifestations. And on the peripheral smear of the blood sample of this patient, you would be having the presence of giant granules. Don't make a mistake on that question. Fairly easy. Oxygen independent, there are multiple ones as of now, but I just want you to recall about major basic protein, something that is going to be toxic to the parasite and present in the eosinophils for the purpose of taking care of them. Whenever I'm going to be making a mention of the oxygen dependent process, of course, I have a role that is being played by NADPH oxidase enzyme. And the second important enzyme which is going to be playing a role over here is myeloperoxidase. Combined action of both of them is going to be responsible for the formation of HOCl. HOCl is hypochlorous radical, which is going to destroy the bacteria as well as the fungi. What you need to remember over here, this enzyme NADPH oxidase can sometimes be problematic in patients suffering from a condition called as chronic granulomatous disease, and the defect is therefore called as a defect in respiratory burst oxidase. These patients are bound to have repeated infections, and these patients are also going to be having the presence of the infections that is going to be caused because of the microlink over here, catalase positive organisms. When I talk about catalase positive organisms, I hope what comes to your mind is Staph aureus. You remember about Candida, you remember about Burkholderia cepacia. So those will be causing infections time and again. And of course, the patients are having repeated attacks of granulomatous lesions in different organs in the body. If you have such a patient, you would be like to screen and then confirm a diagnosis. Screening is being done with the help of a test that is given the name of nitroblue tetrazolium test. So you remember the granule picture that we talked about. And the confirmatory information is going to be done with the help of DHR flow cytometry. Once you have a confirmation, you treat the patient with broad spectrum antibiotics and antifungal drugs. And finally, what you're going to be doing for these patients is going to be a bone marrow transplant. With respect to the broad spectrum antifungal drug, of course, what will be coming to your mind over here is an example of a fungicidal drug that is given the name of amphotericin B. This particular drug is notorious for causing a development of infusion-related reactions, and the drug can be responsible for causing nephrotoxicity. That is a paper one pharma question. You do not want your patient to have nephrotoxicity, so before giving amphotericin B, what you must always do in this patient is something called as saline loading. The alternative that you have as a paper two question, you change the form of amphotericin B. You have to give what is given the name of LAMB form, that is a liposomal amphotericin B. The other place where you heard about liposomal amphotericin B, apart from fungal infections, is it is also given for the treatment of an infection that is very commonly seen in Jharkhand and Bihar, and that infection is given the name of Kala Azar. Of course, PSM and pharmacology knowledge already tells you that we have a wonder drug in case of Kala Azar that is given the name of uh, miltefosine, which is an example of an orally effective wonder drug. That is what you need to keep in mind over here, right? When we are talking about the example of the broad spectrum antibiotics, of course, what will be coming to your mind would be a drug like tetracycline and a drug like chloramphenicol. Both of these are example of protein synthesis inhibitors. Of course, the common questions asked in your exam, chloramphenicol is the same drug, which with your knowledge of hematology, you know, can be responsible for causing development of aplastic anemia, and in babies it is responsible for causing the development of gray baby syndrome. When I talk about a drug like tetracyclines are example of drugs which are broad spectrum, but because these are examples of static drugs, so they are less commonly used now. Of course, the example of tetracyclines that are asked in your exam pretty commonly is going to be a drug like doxycycline, right? Unfortunately, a lot of the data to be covered, doc. So I mean, the only humble request I can make on the reverse is you just bear with me. You already attended this particular thing in the mission class, in the live sessions, in the marathon, in the lab as well. This is just our day for just finishing it. When I'm talking about something called as neutrophil extracellular trap, this is the simplest diagram that I have always made a mention of. You have the bacteria or the neutrophils, and whenever you're going to be having the presence of an infection, the important thing that you have over here is that the nuclear chromatin is going to undergo a decondensation. So the nuclear chromatin material is going to come out. It is going to trap the bacteria. The bacteria is then going to be trapped. It is going to be killed. Two troubles that you're going to be having over here. Trouble number one, this neutrophil is also not going to survive. So remember the buzzword for your exam, beneficial suicide. It's not suicide only, guys. It's beneficial suicide. Fact number two that you need to remember over here, that we are going to be talking about an increased risk of development of a problem in these patients that is given the name of autoimmune disorders. So these patients are going to be having the presence of SLE, right? That's what you need to keep an idea over here. Once we're clear with this, that takes care of the vascular and the cellular events. Then just having a recap about the inflammatory mediators. Of course, if I'm talking about the amino acid required for nitric oxide, that happens to be L-arginine. And the moment I'm thinking in terms of nitric oxide, what comes to my mind is it is going to be having a very wonderful action. It has a dual action. One is vasodilation, and the second is it is going to be responsible for the formation of free radicals. These free radicals are going to be responsible for damage to the bacteria. This vasodilatory property of nitric oxide is very much useful because when we are thinking in terms of drugs which are going to be causing release of nitric oxide, they are responsible for causing vasodilators. Of course, the first drug which comes to your mind is going to be an example of drug of choice for acute angina. That is going to be nitroglycerin. That is going to be responsible for causing reduction in the preload. So that is going to be helpful for your patient. The nitrates also are the drug of choice for a patient having vasospastic angina, in which they are going to be responsible for the dilatation of the arteriolar vessels. That is what you need to remember. You also have a source of nitric oxide, which is going to be responsible for causing dilation of both arterial and venous circulation. It is a drug which is going to be given for reduction in the blood pressure of a patient having malignant hypertension. The drug I'm talking about over here is nitroglycerin. Nitroglycerin to be given in the form of continuous IV infusion drip. It has to be covered with a black color, right? So as to prevent degradation, and nitroglycerin has got a problem that it can be responsible for causing cyanide poisoning. Forensics have already told you cyanide poisoning, the drug that we are going to be giving over here is vitamin B12, an example of a vitamin which is going to be containing cobalt, right? Then we are talking about enzyme for prostaglandin synthesis. So we are going to be having a role that is going to be played by two types of enzymes. One that is going to be given the name of phospholipase A2, which is an example of a rate limiting enzyme. And the second one is what you're talking about, the name of COX enzyme. Phospholipase is an enzyme which is going to be having an importance, and COX enzyme in the sequential order, they are going to be causing the formation of prostaglandins. Most important prostaglandin causing pain and fever is prostaglandin E2. The prostaglandin which is going to be given the name of prostacyclin is PGI2. Yes, you're welcome to Cerebellum Airlines. Sit back, relax, and enjoy, ladies and gentlemen. We are at cruising at a very, very comfortable speed of around 31,000 feet. That is almost 11 hours as of now. Phospholipase is an enzyme which is going to be inhibited by the drugs which are given the name of steroids. And when we are talking about the COX is going to be inhibited by drugs which are going to be given the name of NSAIDs. Whenever I'm going to be talking about NSAIDs, the preferential NSAIDs or the preferential COX inhibitors would include drugs like nimesulide and ketorolac. You need to remember about them. The COX inhibitors, which are non-preferential in nature, are going to be associated with high chances of gastritis. Selective COX inhibitors are selective COX-2 inhibitors. They are celecoxib, rofecoxib, high degree of myocardial infarction, lesser chances of causing gastritis. That's the important thing that we need to keep in mind. With respect to SRS formation, you are having a role played by phospholipase. You are then having a role played by 5-LOX enzyme. 5-LOX enzyme is going to be inhibited by the example of a drug called as xylitol. It's an anti-asthmatic drug which is not used now because of high degree of hepatotoxicity. When I'm talking about SRSA, that includes leukotrienes C4, D4, and E4. And whenever we're going to be talking about leukotriene B4, that is, please remember, associated with chemotaxis. So we talked about the LIC policy. Don't confuse the action of the leukotrienes for your exam. With regards to the cytokines for fever, of course, the important cytokines would be including interleukin 1, interleukin 6, and 6 is going to be having a higher systemic effects of inflammation. 1 is going to be contributing more to the fever. Why is it going to be contributing more to the fever? Because interleukin 1 increases the activity of COX enzyme in the hypothalamus. That's a physio question. Hypothalamus controls the temperature of your body, so it is called as a temperature regulating center. Multiple myeloma is going to be having the presence of increased activity of interleukin 6. That increases the activity of osteoclast, which explains why these patients are going to be having multiple lytic lesions in different bones in the body. Of course, needless to say, fairly easy point, paper 2 question. The commonest bone affected in these patients is vertebral column. Then you have involvement of the ribs. Then you have involvement of the skull. X-ray of skull of these patients are going to be associated with multiple lytic lesions, punched out appearance of the X-ray skull in these patients. Don't confuse it with a question exam where they talk about a 3-year-old child having punched out lytic lesions in the skull. That would be a case of Langerhans cell histiocytosis. Elderly patient with lytic lesions is a case of multiple myeloma. Having said that, recall the fact that there are certain cytokines which are having anti-inflammatory action. That includes interleukin 10 and TGF-beta, not a problem at all. Talking about complement proteins, which are going to be defective in a patient, which is going to be increasing the risk of SLE, are C1, C2, C4. These are called by the name of early complement proteins. The complement proteins, which are going to be increasing the risk of development of meningococcal infections, are what are being termed as the late complement proteins, 5, 6, 7, 8. And of course, C9, everything is fine. C9 deficiency, no problem in the patient. Recall the fact that if I'm talking about hereditary angioedema, the fundamental problem in a patient happens to be C1 esterase inhibitor problem. Of course, if I'm talking about CD55, CD59 problem, what would be coming to your mind is going to be a patient who's going to be suffering from paroxysmal nocturnal hemoglobinuria, right? My full support to the people watching this through the YouTube. My apologies to them as well. Guys, in case you attended any of the lab sessions, in case you attended any of the mission classes of Cerebellum, things are going to be fairly comfortable and easy for you. In case it is not, then just bear with us because those people who watch those sessions definitely are having an upper advantage. I just hope and pray that this session does find some meaning with you as well, right? Talking about then chronic inflammation, tissue destruction is a characteristic feature of chronic inflammation. We are going to be having the presence of the characteristic finding that is going to be tissue damage or tissue destruction. One of the special types of chronic inflammation is going to be granulomatous inflammation, and that is going to be having the collection of macrophages surrounded by lymphocytes. Cytokines involved over here, of course, you are aware about the fact interferon gamma. We are thinking in terms of TNF alpha. I'm thinking in terms of interleukins 2 and 12. Why that becomes very, very important is all these cytokines are important for the formation of a granuloma, particularly in a patient suffering from tubercular infection. Granulomatous inflammation, granuloma formation is a good thing. So whenever your patient is being given anti-TNF alpha drug, say for example infliximab, then there is a high risk of development of tuberculosis. Watch out for that question in exam. Rheumatoid arthritis patient, you want to start infliximab, please, please, please rule out the presence of tubercular infection in the patient. You then talk about modified macrophages. Modified macrophage in the liver is given the name of Kupffer cell. In the kidney, it is given the name of something that is going to be associated with the presence of mesangial cell. If we are going to be talking about the brain, it is going to be associated with something that is going to be given the name of a microglia. If they're talking about the bone, it is going to be given the name of an osteoclast. Different types of granulomatous inflammation. The one which is going to be having the presence of a caseous granuloma, you are going to be having the presence of those cells over there. You are having the presence of a tubercular granuloma, which is a classical example of a caseating granuloma. Non-caseating granuloma is what we find in a patient suffering from sarcoidosis. Read the question in the exam. TB sarcoidosis can have overlapping manifestations, but sarcoidosis patients will be having Schaumann body, asteroid body, increased ACE levels, increased calcium levels, and they would be having the presence of a non-caseating or a naked granuloma. Cerebral malaria is what is going to be associated with dark granuloma. That is an example of a vascular granuloma. This is what is going to be associated with, of course, the treatment of this kind of a condition. When you talk about cerebral malaria, it is Plasmodium falciparum. The drug that is going to be given to these patients is going to be ACT. The moment I think in terms of ACT, what comes to my mind is a patient of malaria coming from Northeast or a patient coming from Rajasthan, endemic areas of Plasmodium falciparum. I would be thinking in terms of a patient who has been given a drug like artemether, artesunate, lumefantrine, sulfadoxine, pyrimethamine combination. And as soon as the patient is going to improve, the patient is being shifted on oral therapy as well. Then I'm thinking in terms of cat scratch disease, something that comes to my mind with stellate granuloma. Of course, the organism over here is micro question, Bartonella hensii. Q fever means I don't know what the question is about. What is the causative, the transmitting that vector is concerned? So donut granuloma, or what I call by the name of the Meduvada granuloma, is what is going to be seen in case of Q fever. Coxella burnetii is what I'm talking about over here. Then of gamma, which is an example of a condition that I'm associating with syphilis, that is Treponema pallidum, and the incubation period, as most of you are familiar, 9 to 90 days, right? Painless or painful? Of course, you know the fact it is painless. The next thing that I recollect over here is going to be thromboembolism. I already made a mention. Thromboembolism is because of the presence of usually secondary factors. Typically, that is going to be immobilization, having a history of OCPs, previous surgery, and all those stuff. But one of the common genetic risk factors for development of thrombus formation is Leydens mutation. That's a factor 5 mutation. So we are not going to be having the proper action caused by protein C and protein S in this situation. One of the commonest conditions that we talk about is pulmonary embolism, that is seen because of patients suffering from deep venous thrombosis. This is what is going to be responsible for causing a development of a clot formation in the pulmonary circulation. The patients are going to be having the classical sign of a sinus tachycardia, or they're going to be having the ECG sign, as most of you are familiar at this point of time, S1Q3 D3 on the ECG. And of course, you are going to be talking about the fact that in order to prevent this kind of a condition, either you are going to be using medical therapy or surgery. Medical therapy would include drugs like heparin, warfarin, or you're going to be using the presence of the inferior vena cava filters, depending upon what they ask you in the question. Air embolism, something that you're going to be seeing in case of a sea diver individual when he is going to be taken out too quickly, or embolism is going to be seen when you're going to be inserting a central line in case of an ICU patient. That is what is going to be causing the problem. Fat embolism will classically be a patient who is going to be driving a bike. Youngsters do that very, very commonly, but then this guy suffers from a fracture, and then this patient is going to be coming to the hospital within the 72 hours with the development of a skin rash, confusion, and there is a presence of a trouble in the patients. So anemia, thrombocytopenia, there is a skin rash, and there is a presence of CNS manifestations. The other thing beyond fracture that is going to be seen in these patients can be a patient suffering from burn injury. That is what you need to remember. All right. Amniotic fluid embolism, of course, is going to be a patient who's going to be a female patient having come to the hospital for a delivery purpose. Unfortunately, there is a rupture at the level of the amniotic membranes. The fluid enters into the systemic circulation. The female collapses just like that. And therefore, the amniotic fluid enters into the pulmonary circulation of the mother. This is what I want you to remember. Exam question will make a mention. On autopsy, this lady is having the presence of fetal squams. Fetal squams means the fetal tissue is going to be present in case of the pulmonary circulation of the mother. That is what is going to be seen as a feature of amniotic fluid embolism. Amniotic fluid embolism, unfortunately, is majority of the patients are going to die. The surviving patients are going to be having some kind of a complication as well. The moment I'm going to be thinking in terms of image-based questions, of course, I can give you an image-based question on something which is appearing as empty area over here. This is a classical image of a fat embolism because the fat is going to get washed off, and that is going to be seen in case of fracture or in case of burn injury. Don't forget that particular point, right? The next important thing that you need to remember over here is going to be the classical appearance given the name of nutmeg liver, chronic venous congestion of the liver seen in a patient suffering from right-sided heart failure. Of course, what you're going to be having over here is the dark colored areas, which are going to be representative of the dead cells, light areas, which are going to be representative of the living cells. And of course, the living cells are going to be periportal cells, whereas the dead cells are going to be the centilobular cells. That's what you need to just remember over here. Right. So that is about the thromboembolism stuff that they can ask you in the exam. Then they ask you questions on immunity, the defensive power. Of course, innate immunity has got no memory. Adaptive immunity has got memory. The classical examples of antigen-presenting cells would include dendritic cells. And the example of a dendritic cell, apart from that, we talk about the B cells. We talk about the third cells, which are going to be given the name of macrophages. With respect to the dendritic cells, the classical example is going to be of a cell which is going to be having the presence of the classical tennis racket appearance or the Burbeck granules. The Burbeck granules is what is going to be associated with the presence of Langerhans cells. So those are the examples of physiologically the most important antigen presenting cells. How do I identify Langerhans cells? That is with the help of markers like CD1A, S100, and a marker called as Langerine. B cell markers are going to be in association with something like CD19, 2021, 22, 23. Of course, I can be talking about co-stimulatory molecules like CD80, 86 as well. But when I'm going to be talking about T cell markers are primarily going to be including from CD1 to CD8 with the exception of CD6. I'm going to be having the presence of co-stimulatory molecules like CD28. That's what is to be remembered over here. When I'm talking about the example of a pan B cell marker, that is going to be CD19. B cell molecule responsible for entry of the virus, Epstein-Barr virus is CD21. And when I'm talking about the pan T cell marker, I would like you to recall about CD3. Normally, there are multiple types of T cells, but the important examples include helper T cells and cytotoxic T cells. Helper T cells typically are going to be more than cytotoxic T cells, but the ratio is having a reversal in case of a patient suffering from HIV. In severe phase of HIV, that is also given the name of Slim's disease, the patients are going to be having a reversal. The other thing that we talk about over here is whenever antigen comes in contact with T cells, this will always require the help of APCs. But when antigen comes in contact with B cells, they do not require APCs. Any antigen coming in contact with B cells is what is going to be associated with conversion of the B cell into a plasma cell, and that plasma cell is now going to secrete antibodies. The moment I talk about antibodies, this comes as an image on your mind. Majority of these antibodies are examples of structures which are Y-shaped molecules. They would be having the presence of the FC and the FAB portion. There is going to be a presence of two heavy chains and two light chains. These antibodies are going to be existing in the form of a monomer, that is IgG, IgD, and IgE. The only antibody which is existing in the form of a pentamer, remember the millionaire's molecule IgM, that's what you need to remember over here. Very good, मैगMD. वो जो आप 3:1 बोलो डॉक्टर साहब, वो टी सेल बी सेल रेशो है जिसकी हमने बात करी. क्वेश्चन को ध्यान से बात को आराम से सुन लो प्लीज. IgA can be existing in the form monomer as well as in the form of a dimer. This came as a question in exam in 2023. This one is what is asked in your exam as a previous exam question. Of course, a monomeric form is a question that is it talking about. Whenever they talk about the first antibody that is going to be produced at the time of infections, that means acute infections, you're going to be having the role that is going to be played by IgM. Whenever the question in the exam is going to be talking about the first line of defense, that is going to be IgA. Whenever they talk about an antibody required for making a diagnosis of chronic infection, you have to remember about IgG. Beyond that, of course, the antibody present in the lowest concentration is IgE. The antibody that is heat labile is IgE. The antibody that is present in type 1 hypersensitivity is IgE. All those easy informations are the question that you would be able to tackle pretty comfortably in the exam. Don't goof up on this one in the exam, for God's sake. The next thing that we can talk about over here is with regards to a topic of hypersensitivity reactions. The moment I talk about hypersensitivity reactions, I'm making a mention of something like the 4 different types of hypersensitivity reactions. Before talking about the points individually, I just talk about the fact that the clinical examples are very, very, very high. I said that 3 times. Remember the importance. This is IgE antibody, which is going to be involved in type 1 hypersensitivity. The IgE receptors are going to be present on the surface of mast cells. Mast cells, as you know from paper 1 histology knowledge, are the richer source of histamine. The inflammation causing receptor of histamine is going to be the H1 receptor. The gastritis causing receptor of histamine is the H2 receptor. Remember ranitidine, famotidine, cimetidine, and the drug interactions, of course. When I'm talking about the first time exposure, no symptoms, second time exposure causes mast cell degranulation. There is going to be a clinical example of conditions like allergy, atopy. Classical history that you need to remember, somebody goes to Goa. Of course, you would all go after a party. Of course, when you're going to be getting good marks, 200 plus, that's a the mission class. You're going to be getting, some of you may be getting, or the patients are getting some kind of a food allergy because of sea allergy. Or you can be having a patient who is going to be having an unknown insect bite or a bee sting. You can be having patients suffering from bronchial asthma who are going to be having a spasm or a bronchospastic attack. Patients could be having the development of a Kisoni's test, like condition provocative test. That is not being done now, but then you just need to remember about something called as echinococcal. Don't get personal, dog. When you're going to be getting echinococcal antigen testing with regards to hydrated cyst disease, then they are going to be making a mention of something called as drugs, especially penicillin, which is going to be associated with the development of a type 1 hypersensitivity reaction, right? So what we need to talk about over here is that these are all examples of type 1 hypersensitivity. The clinical symptoms in the patients are going to be developing within a span of few minutes. So it's an example of an immediate type of hypersensitivity reaction. Of course, if I'm talking about drug-induced hypersensitivity hypersensitivity reaction. This is what you and me are going to be associating with the word anaphylaxis, also known by the second important name of anaphylactic shock. The drug of choice for which happens to be a drug that is given the name of epinephrine. So carry your EpiPen at all times, at all places. You never know when you can save the life of your patient. This is what is going to be requiring 0.5 milligram of the drug in a concentration of 1:1000 intramuscular injection, acting on the alpha 1, beta 1, beta 2 receptors for saving the life of your patient. I want you to recall as a paper 2 question, alpha 2 receptors do not play a role in reversal of anaphylactic symptoms. Whenever I'm going to be talking about type 2 hypersensitivity, patients are going to be having a role played by IgG and IgM. There is going to be an activation of the complement system, therefore responsible for causing cell death. My blood group is Rh positive, is what is classical acronym. Myasthenia gravis, of course, you remember about the MuSK antibodies, you remember about the nicotinic receptor, the NM type. You're going to be talking about something that is going to be given the name of neostigmine plus atropine for your exams. Blood transfusion reactions, clerical error is the commonest cause. Mismatched blood transfusions, patients will be having the development of pain. High grade fever, there is an infusion site itching as well in the patients. Good-Pasteur syndrome is going to be a hemoptosis in hematuria patient. That is going to be type 2 hypersensitivity, antibodies against collagen type 4. Graves' disease is going to be a patient having the presence of hyperthyroidism, pretibial mixed edema, and there is a presence of ophthalmopathy in the patients because of the presence of thyroid stimulatory antibodies. Of course, T3, T4s are going to be increased in these patients, and the TSH levels because of the feedback inhibition mechanism is going to be less. If I'm talking about immune hemolytic anemia, immune thrombocytopenia, can be seen in isolation or can be seen as a component of SLE. So the patients can be having antibodies against RBC or platelet antigens. Rheumatic fever is group A beta hemolytic streptococcal infection followed by the development of antibodies, and therefore there is going to be a development of cross sensitivity or molecular mimicry, which is going to be seen in case of children 5 to 15 years. Jones criteria is what is being used. RH incompatibility is going to be the presence of erythroblastosis fetalis, whereas the mother is going to be RH negative, the fetus is going to be RH positive, and that is what is going to be causing the trouble in the patient. Hyperacute transplant injection on table, kidney turning black. That's what you need to remember over here. Pernicious anemia is B12 deficiency because of autoantibodies. आप आंसर कर चुके हो डॉक ऑलरेडी 4-5 बार कर चुके हो, अभी तो सिर्फ मेरा ही टाइम है इसको खत्म करने का. देन वी आर टॉकिंग अबाउट समथिंग कॉल्ड एज पेम्फिगस वल्गारिस, एंटीबॉडीज अगेंस्ट डेस्मोग्लिन 1 and 3. ठीक है, तुमको सिर्फ रिकॉल करना है और तुम्हें रिकॉल करके खुश होना है, कॉन्फिडेंट होना है कि हम ऑलरेडी कर चुके हैं ये सब. जो नहीं सुना उसको नोट कर लेना दिमाग के कोने में या किताब के कोने में, ताकि वो एग्जाम में काम आ जाए. बाकी सब तो यार ऑब्वियसली हम कर ही चुके हैं ना. तो हमारा तो प्रश्न यहाँ पे यही है कि हम इसको एंजॉय करने के लिए करें. जैसे मैंने बोला, पायलट तो सिर्फ मैं ही हूँ, आप सिर्फ पैसेंजर हैं, आप बिजनेस क्लास में एंजॉय करिए. Talking about IgG, IgM, this is going to be antigen antibody complexes. Symptoms take place typically 2 to 3 weeks before development, and that is going to be causing typically a local damage or selected sites. So patients are going to be having the presence of sharp is what I want you to remember. Majority of the people will be comfortable remembering about serum sickness, passive immunization. SLE, that's an autoimmune disorder. Just photosensitivity, skin rash. There can be a presence of something like lupus nephritis. There can be development of patients having CNS manifestations, cardiac pulmonary involvement as well. Remember about all those things. Say, for example, HSP, which is IgA vascular disorder, Arthus reaction, that is a small vessel inflammatory condition. Reactive arthritis is type 3, no doubt about that. Rheumatoid arthritis is type 4, without a doubt. PSGN is going to be type 3. Polyarthritis nodosa is an example of a type 3 hypersensitivity reaction. ठीक, that's important. नहीं नहीं यार, उनको बिठा रखे हमने हमने पूरे इज्जत सम्मान के साथ, लेकिन obviously note antibodies are involved in case of patients who are going to be having the presence of. This is an example of antibody. This is an example of non-antibody mediated. This is an example of a cell-mediated hypersensitivity reaction. The cell that is involved in pathogenesis is Th1. You remember about a condition called as contact dermatitis, artificial jewelry, nickel cadmium, detergents, and the lady applying a bindi. Then you're talking about something called as type 1 diabetes mellitus. टाइप 1 डायबिटीज मेलाइटस के ड्रग ऑफ चॉइस, जिसका नाम होता है इंसुलिन. इसको आप देते हैं बेजल बोलस रेजीम के साथ. इसमें आप शॉर्ट एक्टिंग दवाइयां देते हैं जिसमें लैग नहीं होता, लिस्प्रोएस्पार्टग्लूलाइसिन. इसमें आप एक दवाई देते हैं which is going to be a long acting drug, D-gludac, Detamar, Icodec. And then we can be thinking in terms of any other drug apart from insulin which is approved in case of type 1 diabetes. Any other drug apart from insulin which is approved in type 1 diabetes. इसको आई होप ठीक से आंसर कर ही दोगे, इस टाइम पे तो गलती नहीं करोगे. इंसुलिन के अलावा कौन सी दवाई है जो टाइप 1 टाइप 2 डायबिटीज के लिए अप्रूव्ड है, जो कि पैंक्रेटिक बीटा सेल से निकलने वाले हार्मोन के एनालॉग होती है? दवाई का नाम है प्रेमलिनटाइड. आपने गलती नहीं करनी है. प्रेमलिनटाइड का साइड इफेक्ट आपको पता ही होना चाहिए. इट्स एन एग्जांपल ऑफ अ ड्रग रिस्पांसिबल फॉर कॉजिंग नॉजिया. लिंटाइड नहीं भाई, प्रेमलिनटाइड. Multiple sclerosis, example of a condition in which the patients are going to be having the presence of nystagmus. There is a presence of scanning speech. There is a presence of intention tremors. Rheumatoid arthritis, patients are going to be having the presence of stiffness, morning stiffness. And of course, the patients are being given drugs like the DMARDs over here. Remember about methotrexate, the gold salts, penicillamine, etc. Inflammatory bowel disease, again an example of a condition over here. Psoriasis and Mantoux test are examples of again conditions which are examples of type 4 hypersensitivity reactions. I reiterate for the nth time, the clinical examples are very important and the scenarios are very important for cracking the questions in the latest pattern of FMG. Pathophysiology based questions are important, no doubt, but they are asked less often in the exam now. So be very, very confident and clear about these subtypes, right? Then talking about immunodeficiency disorders, when I'm talking about the primary and the secondary disorders, of course, these are the example of primary disorders. Acquired disorders में the commonest disorder happens to be unfortunately poor nutrition. The second important example of an acquired disorder that we talk about is AIDS. Of course, the most efficacious way of AIDS is sexual transmission. The least efficacious way also is going to be sexual transmission. Most efficacious is infected blood transfusion. That is what you just need to keep an idea over here. So you're going to be doing a screening of the blood. When you're doing the screening of the blood for these patients, what you're looking at over here is the presence or absence of the P24 antigen, right? When I'm talking about the B cell defect, I want you to remember about a condition that is going to be remembered about the Bruton's disease. Bruton's loves boys. Remember BBB, boys, bacterial infections, B cells are affected, B cell tyrosine kinase, recurrent infections, and the patients are going to be having hypogammaglobulinemia. The moment I think in terms of T cell defect, what comes to mind is D. George syndrome. That's going to be 22q11 trouble. The patients are going to be having the problem of thymus problem. So T cell defect plus hypocalcemia is what you need to remember classically in these patients. Of course, abnormal faces, cleft lip, cleft palate, and the patients are going to be having the presence of congenital cardiac defects as well. Cash 22, of course, you are aware about that. Wonderful. Both B and T cell defect is going to be a very severe and a combined problem that's given the name of SCID. This can be an example of an X-linked condition or an autosomal recessive condition. As you told me, SCID ki ada hi alag hai. So that can be seen because of adenosine deaminase deficiency, or that can be caused because of interleukin 2 receptor defect. Either of them can be present in the patient, because of which both B and T cells are going to be defective and the patients are going to be having the trouble over here, right? Having said that, we just have a quick recap about the concept of amyloid. That's a classical picture of amyloid that you always must remember. It's an example of a proteinaceous molecule that is going to be associated with the presence of extracellular deposition of the material. The pink red appearance of the Congo red material is going to be seen under normal light, but the same material in the polarized light is going to be giving you the presence of classical apple green birefringence, right? The moment I'm thinking in terms of amyloidosis, of course, the chemical natures is what I would like you to recall. AL associated with primary amyloidosis, also associated with plasma cell dyscrasia or multiple myeloma. When I'm talking about double A, it is going to be chronic inflammation, tuberculosis, and rheumatoid arthritis are the first conditions which will come to my mind. The moment I'm thinking in terms of A beta, 1B, 1 brain Alzheimer's will come to my mind. Of course, the drug of choice for which happens to be a drug like donepezil. Mechanism of action of donepezil is an example of a centrally acting acetylcholinesterase inhibitor. The drug which is not being given over here is tacrine, that is hepatotoxic. Of course, the drug which is going to be given in Alzheimer's but not acting through the acetylcholine pathway is a drug given the name of memantine. Please remember those questions for your exam. A beta 2 is what is going to be remembered. Two kidneys, kidney problem, that is CKD patients. That is a patient undergoing hemodialysis. The number one cause of hemodialysis or CKD in our country happens to be diabetic nephropathy. For diabetic nephropathy, you have to give to this patient the drugs which are going to be controlling the glucose, that means the anti-diabetic drugs, and other drug happening in this patient responsible for decreasing the risk of diabetic nephropathy is going to be a drug that is given the name of the AC inhibitors or the ARBs. Then thinking in terms of these patients quite commonly are going to be having joint involvement that is going to be associated with carpal tunnel syndrome. Having said that, of course, you are aware about an example of an amyloid that is going to be associated with CAL, that is calcitonin, that is going to be a patient suffering from medullary thyroid cancer. That is the only example of a thyroid cancer arising from the parafollicular cells, and that is going to be having calcitonin as a tumor marker. The moment I'm thinking in terms of ATTR, if it is a question making a mention of wild or normal ATTR, it's a patient suffering from senile cardiac amyloidosis. If it is a question that is talking about mutated ATR, I'm thinking in terms of a patient suffering from familial amyloid polyneuropathy, right? Having said that, some questions asked in the exam pertains to certain organs. The kidneys are the commonest organ affected in these patients. They are going to be having nephrotic range proteinuria, and the mesangium area of the kidney is typically going to be the first area affected. So far as the cardiac tissue is concerned, the clinical manifestation is arrhythmia, but the important complication that can be seen in the patients can be restrictive cardiomyopathy. In the involvement of the skin, patients can be having the pararesidence of what is given the name of pinch purpura. In the involvement of the spleen, patients can be having the involvement of white pulp resembling the white grains or sabudana, and that is going to be given the name of a sago spleen. If there is involvement of the red pulp of the spleen, spleen becomes enlarged. That becomes a fatty spleen. That's given the name of lardaceous spleen. Right? The moment I'm thinking in terms of the presence of the other important organs, the important organ that comes to my mind happens to be the GI tract. With regards to the GI tract, I would like to talk about the presence of an important manifestation like macroglossia, and I would like to talk about the involvement of the skin in terms of abdominal skin aspiration. Abdominal fat aspiration is what is going to be currently the best way for making a diagnosis of systemic amyloidosis. Even though, please read the question carefully, localized amyloidosis is best treated with the help of the affected organs biopsy for the purpose of histopathological examination. If I'm doing the examination of the amyloid under electron microscopy, what I would be expecting to find over here is the presence of non-branching fibrils. So that is likely to take care of majority of the questions on exam pertaining to amyloidosis. That's what they ask you as question. This takes care of our discussion of immunity as well. Then we next jump into the topic of hematology. The moment I'm thinking in terms of something like hematology, of course, RBC, WBC, platelet disorders. And the moment I'm thinking in terms of these disorders, of course, what I would be talking about over here would be anemias first. So microcytic anemias, of course, you know about the different causes of microcytic hypochromic anemia. That is going to be an example of an acronym often being used in the exam. That is going to be SITA. Of course, if I'm talking about anemia, I'm thinking in terms of an RBC. Normal RBC, please recall, is a biconcave cell, which is going to be having the presence of zero nucleus. It is having the presence of the space for the purpose of hemoglobin. There is no mitochondria as well over here. And this RBC typically is going to be having the size that is between 180 to 100 microns. Remember, the shape of the RBC is because of a presence of a protein that is going to be given the name of spectrin. Whenever the RBC is going to be having a size less than 80, it becomes a small RBC, and that is going to be having the cause as a CETA, out of which the commonest cause, number one cause of small size RBC is iron deficiency anemia. Patients who are going to be having iron deficiency anemia are most commonly having this condition because of nutritional deficiency. That can be because of a problem at the level of absorption of iron, non-availability of iron as well. And the site of iron absorption typically is the duodenum. So we talk about the story of iron. We know about the ferrous form. We know about the DMT1 transporter. We know about ferroportin. We know about hephaestine and ceruloplasmin. For the transport of iron in the blood, we are having a molecule that is given the name of transferrin. And storage of iron is in the form of hemostasis. In case of the other conditions which are going to be associated with microcytic hypochromic anemia, we have to think in terms of sideroblastic anemia, thalassemia, and anemia of chronic disease. So first thing first, let us just have a look at the table describing the important features of each of these conditions. If I'm going to be talking about something that is going to be given the name of the first important feature I can talk about over here is going to be something like maybe serum iron. I can be talking about percentage transferrin saturation. I can be talking about what is going to be given the name of TIBC. And I can be talking about something that is going to be given the name of serum ferritin. For the purpose of ease, just in case you do not get confused in the exam, I'll keep serum iron and serum ferritin over there in that sequence so that you just remember. Iron deficiency anemia, all parameters are going to be going down. Only one parameter goes up. This is the last time we are going to be talking about this. That is going to be TIBC. In case of anemia of chronic disease, I would like you to recall the fact that serum ferritin is what is going to increase, the TIBC is what is going to decrease, and the other parameters are also going to become less. So read the questions very, very carefully in the exam, my friends. You need to remember about chronic inflammatory conditions, whether inflammatory bowel disease, tuberculosis, rheumatoid arthritis. Majority of them are going to be having only one parameter increasing, that is ferritin levels will increase. In thalassemia, everything usually, this is thalassemia minor we are talking about over here. Majority of these parameters happen to be perfectly normal. The moment I'm thinking in terms of sideroblastic anemia, this can be a pharma question because it will talk about a patient who is taking a drug like isoniazid. This can be a forensic question because he's talking about a person who's going to be suffering from lead poisoning. It could be a general question. The commonest cause of sideroblastic anemia is alcohol intake, and the patients are going to be having what finding? All findings opposite of iron deficiency anemia. So ferritin levels are going to go up, iron levels are going to go up, transferrin saturation goes up, but the only parameter which is going to go down in these patients is going to be TIBC. Just remember that table. All books, everybody would have taught you the same thing. We have talked about that with a lot of logic. The only thing I would like you to recall over here is that these three types of anemias, if you give iron, nothing will work. But this is the first and the most common type of microcytic hypochromic anemia. This is the only example of an iron responsive anemia. For paper 2 question of your exam, of course, you remember about the Anemia Mukt Bharat program. You remember about the pink, blue, and the tablets, which are going to be having the different types of iron concentrations along with folic acid. For differentiating between ID and thalassemia, we are using an index that is going to be given the name of Menzer index. The moment I'm thinking in terms of Menzer index, which will come to my mind is MC value divided by the RBC count. Any value less than 13 is an indicator of thalassemia. Any value more than 13 is an indicator of iron deficiency anemia. Right? For iron deficiency anemia for the treatment, what we are going to be offering to this patient is going to be a salt of iron that is going to be given the name of ferrous sulfate. Of course, the best salt to be given to the patients can be in the form of ferrous ascorbate. And we are having parental forms of iron that most of you are familiar with, iron dextran and stuff. coming back to the discussion, whenever I'm thinking in terms of normocytic normochromic anemia, the common conditions which will come to my mind over here are going to be including a patient who's going to be suffering from renal failure. I would be thinking in terms of a patient suffering from anemia of chronic disease. I would be thinking in terms of a patient who's going to be having bone marrow involvement in the form of infiltration of the bone marrow in the form of myelophthisis. That is what I would like you to keep in mind, right? Why I want you to remember about that particular point is particularly AOCD is going to be more strongly associated with normocytic normochromic anemia in comparison to something like mycocytic anemia. Another common example of a condition which is normocytic normochromic anemia, commonly asked on the exam, as rightly made a mention, is a patient who's going to be suffering from a condition given the name of multiple myeloma. Macrocytic anemia, you can be having two types of conditions. One can be megaloblast are present. The second can be megaloblast are not present. If I'm saying megaloblast are present, this can be because of B12 or folic acid deficiency. If I'm saying megaloblast are not present, it could be seen because of a patient suffering from liver disease or a patient suffering from hypothyroidism. That is what you just need to have an idea. Now, with regards to something like B12 and folic acid deficiency, these are the things that have to be remembered over here, that we are going to be talking about a patient who's going to be having the presence of macrocytic anemia. Macrocytic anemia, size of RBCs is going to be big, and the patients are going to be having hypersegmented neutrophils. So if it is with neurological manifestations, it is going to be a case of B12 deficiency. If it is without neurological manifestations, it is a case of folic acid deficiency. Absolute basic facts that you just need to keep in mind. A person who's going to be eating junk food is going to be an office goer, is not consuming fresh fruits and vegetables. He is going to be a folic acid deficiency patient. A patient who's going to be having a history of being a pure vegan, not eating any food from animal source, is likely to be suffering from B12 deficiency. Absolutely clear on that one. B12, the site of absorption is ileum. Folic acid, the site of absorption is jejunum. That's what you're all clear with. Commonest type of anemia, of course, we understand is going to be iron deficiency anemia without a doubt. When we are talking about cholionicia, those are spoon-shaped nails. Again, they are very commonly seen in patients who are going to be suffering from iron deficiency anemia. No doubt about that. When I'm talking about strict vegan, of course, I'm thinking in terms of B12 deficiency. When I'm talking about raw seafood, I'm again thinking in terms of B12 deficiency. Why? Because of the presence of somebody eating something, a food like a sushi or a raw seafood. So that causes a high risk of development of D-latam infection, and that causes B12 deficiency. There can be another cause of B12 deficiency, which can be an autoimmune condition, and that autoimmune condition is going to be given the name of pernicious anemia. So when I'm talking about all these conditions, of course, what I would like to do in these patients would be, I would have to give these patients supplementation with B12. For majority of these patients, B12 has to be given in the oral form, but for pernicious anemia, it has to be given in the parenteral form. When I'm talking about folic acid and B12, the first thing that you do is you first give folic acid, then you are going to be first give B12, then you are going to be giving folic acid. If you give it in the reverse order, you are going to be causing a worsening of neurological manifestations. That's another thing that you need to keep in mind. Folic acid deficiency is likely to be more common in comparison to B12 deficiency. So therefore, folic acid deficiency is more likely to also be associated with a patient who is having a nutritional deficiency. That's why in the Anemia Mukt Bharat program, you are going to be giving not only iron, but you are also going to be giving folic acid as a supplementation. The quantity, of course, is what is known to you. That 200 milligram tablet, 60 milligram elemental iron, plus there is folic acid that is going to be given for the purpose of, those microgram quantities that we talk about, the 500 microgram and the 100 microgram thing that you're all aware of. So no need for me to touch upon that particular thing. Then we are going to be talking about the concept of hemolytic anemias. Hemolytic anemias are characterized by the fact patients will be having anemia, they will be having jaundice. There is no doubt about that. There is increase in LDS levels. And then majority of these patients, if there is extravascular hemolysis, there is presence of splenomegaly. If there is intravascular hemolysis, there is a complaint of altered color of urine. Now, there can be different conditions. For example, the first condition, I hope you will be able to remember. I will talk about that in the exact sequence. Autosomal dominant condition. The condition is given the name of hereditary spherocytosis. The important feature is it is a problem of encarine defect. Patients are having anemia, they are having jaundice, they are having splenomegaly. Peripheral smear you see in these patients, they will be showing you the presence of spherical cells. Spherical cells are example of cells which do not contain central pallor. So you will be doing a screening test. Screening test will show you presence of increase in osmotic fragility. You do the confirmation with the help of flow cytometry. You confirm the diagnosis. It is a chronic cause of hemolytic anemia, so patients can be having cholelithiasis also. You do in these patients elective splenectomy that improves the severity of anemia, but that doesn't treat the condition. Whenever I'm going to be talking about, therefore, the next condition, that's an example of a condition which loves boys. Condition which loves boys, at least all boys should remember. X-linked recessive condition, G6PD deficiency. G6PD deficiency condition means any cause of oxidative stress. there is a damage at the level of RBCs. So that can be because of infections, that can be because of fava beans, that can be because of something like the drugs like anti-malarial drugs, primaquine. This will cause development of two important findings. One, the patients are going to be having the presence of Heinz body. Second, the patients can be having the presence of the altered appearance of the cell. That particular cell is what is going to be given the name of a bite cell. Usually, these patients are going to be having intravascular as well as extravascular hemolysis. If I want to do a screening of these patients, then am having this history, and then I will proceed with the patients being further investigation. The further investigation of these patients is going to be done with the help of G6PD levels. That can be done with the help of something like a G6PD assay. So you have a card test, gel test. That is what can be done for these patients. Then I'm thinking in terms of a patient who is suffering from a condition that is autosomal recessive. This is an example of a hemoglobinopathy. One condition that I can think in terms of over here is going to be sickle cell anemia. Of course, the long story cut short, beta 6 position, there is a replacement of glutamic acid by valine. So whenever there is hypoxemia, there is going to be a decrease in the stability of the hemoglobin. So that is going to be responsible for causing development or presence of crescent shaped RBCs. These patients are going to be having the presence of vaso-occlusive crisis. There is an African boy who is going to be having the presence of a non-healing ulcer. There can be a male person who is going to be having the presence of priapism. Patients can be having the development of acute chest syndrome, or they are going to be having the presence of hand-foot syndrome. I can be doing a screening test. Screening test can be done with the help of dithionite test or metabisulfite test. The confirmatory test for these patients, of course, is going to be done with the help of the presence of hemoglobin detection, and the hemoglobin detection is going to be best done with the help of or the gene analysis. If gene analysis is not given as an exam option, the next best thing that you have to do for these patients happens to be HPLC. Right. There are different drugs which are available for decreasing the severity. So one drug which can be given over here is hydroxyurea. The other drug which can be given for these patients is azacitidine. A third drug which can be given to these patients is for decreasing the episodes, voxelotor, which came in the last exam as a question. Then I'm thinking in terms of autosomal recessive condition. This is a condition that is given the name of thalassemia. Beta thalassemia, of course, more common than alpha thalassemia because beta thalassemia is caused because of gene mutation. Alpha thalassemia is caused because of gene deletion. In beta thalassemia, if the condition is going to be a major condition, this child is going to be dependent upon blood transfusion. So, right from 6 months of age, multiple history of blood transfusions, he is having the presence of chimpanzee-like facies. He is having hepatosplenomegaly. He is having the presence of ineffective erythropoiesis. He is going to be having a mortality which is going to be caused because of iron overload. If I'm talking about a patient who's going to be suffering from minor beta thalassemia, then this patient is not going to be having any history of blood transfusion. These patients are clinically going to be asymptomatic. Whether it is beta thalassemia major or beta thalassemia minor, ideally the best investigation for both of them is gene sequencing. However, the other thing that can be done for these patients can be HPLC. In case of beta thalassemia major, the most important hemoglobin that you're looking out over here is going to be HbF. But if I'm asking you a question, the hemoglobin that you're looking out for in beta thalassemia minor, that is going to be something called as HbA2, right? So if the HbA2 level is more than 3.5 gram percent, you will be thinking in terms of beta thalassemia minor. That is a simple story cut short. If I'm talking about an example of a thalassemia in which the patient is going to be having the development of hydrops fetalis, this is what is going to be given the name of alpha thalassemia. So alpha thalassemia is one of the important causes of non-immune hydrops fetalis. That is what you need to remember over here. Then we are talking about a special example of a condition that is going to be given the name of PNH. PNH is a problem of PIGA gene. PIGA gene means regulatory proteins are defective. That means CD55, CD59 problem. If there is a CD55, CD59 problem, patients are going to be having sleeping episodes, episodes of bleeding after they are going to be sleeping at night properly. So early morning when they get up, there is an altered color of urine. That is what is given the name of tea-colored urine. These patients are at high risk of development of hepatic venous thrombosis, Budd-Chiari syndrome, which is going to be causing death in these patients. These patients are going to be having dysfunctional platelets. The other important thing, you want to screen these patients, you can do with the help of HAMS test or acidified sucrose lysis test, right? The other thing for the confirmation for these patients, you are going to be doing what is given the name of flow cytometry. You want to treat PNH, you give a drug like eculizumab. Eculizumab not given in the exam, give revelizumab. If revelizumab not given in the exam, give a drug like pegcetacoplan. So you crack a paper 2 question of your exam. If I'm giving eculizumab or revelizumab, there is increased risk of development of meningococcal infection. So that is a micropharma correlation of paper 2. That becomes a good medicine question. That is about hemolytic anemia. Then these are the examples of the image-based questions that can be given to you in the exam. So first can be an example of a cell. That's an example of a bite cell. This in combination with the presence of Heinz body. What is the condition I'm dealing with? I'm dealing with a patient suffering from G6PD deficiency. G6PD deficiency means my patient is having history of fava beans, or he's having infection, or he's having intake of a drug like primaquine. The other question I can talk about is a patient who is going to be having the presence of these kind of spherical RBCs. Now, depending upon what is the age of the patient, if my patient happens to be a child, I will think in terms of hereditary spherocytosis, autosomal dominant condition, and in this condition, patients are going to be having the presence of the increased osmotic fragility. They will be having the presence of an important finding that the confirmation can be done with the help of flow cytometry. Important thing to be remembered in this condition, Coombs test will come out to be negative. Read the question carefully. Most common cause of spherocytosis is what is seen in case of adults. In case of adults, there is a presence of antibody against the RBC antigens. So this condition is given the name of autoimmune hemolytic anemia. In these patients, therefore, there is going to be a presence of DCD test coming out to be positive. In these patients, however, there is no family history which is going to be seen. So pediatric spherocytosis, positive family history, Coombs test negative is hereditary spherocytosis. Adult spherocytosis, family history is negative, but Coombs test is positive. It is a case of autoimmune hemolytic anemia. That is what you need to remember over here. Then we can be talking about an example of a condition in which RBCs are going to be having a crescent shape. This is a patient suffering from sickle cell anemia. Beta 6, as we talked about, hand-foot syndrome, dactylitis, presence of male individual with priapism, acute chest syndrome, all those manifestations. If I'm thinking in terms of a patient having this paper 2 question, this is the presence of the classical X-ray scallop, which is going to be showing you the presence of crew cut appearance, which is seen in case of hemoglobinopathy. Thal major is the number one cause that you need to remember over here. If that is not given, then you can go for the answer as sickle cell anemia. This is an example of an image-based question. It's an example of a test that is given the name of the Nestrov test. This is a single tube osmotic fragility test. With this particular test, you detect the presence of something that is going to be a patient who's going to be suffering from Thal major. Thal patients, the black line is not visible, so there is something abnormal. Normal people, you and me, the black line is visible. So black is good that ways, right? So black is back, that is going to be normal, but black line not visible, that is going to be problem of thalassemia. Now, what is going to be done for these patients? Then other condition, then you are having situations with RBCs are going to be having this appearance. These fragmented RBCs are going to be given the name of schistocytes. Schistocytes means what kind of condition are we talking about? We are dealing with a patient suffering from microangiopathic hemolytic anemia. That can be a patient suffering from DIC. That can be a patient suffering from HUS. That can be a patient suffering from TTP. ये तो आपको पता ही है कि इसमें सबसे common cause जो होता है, that is going to be a patient who's going to be suffering from DIC, right? So those are the things that you need to remember for exam. Now the hint in the exam question can be 50% of case of DIC can be because of an obstetric cause. If I'm talking about a patient suffering from HUS, this is likely to be a patient who's going to be a pediatric patient suffering from diarrhea, and the patient was then having an infection caused by E. coli H0157 H7. So Shiga-like toxin is what is going to be seen. So child who was having the presence of diarrhea, and this child is then going to be having the presence of kidney dysfunction, and this child is also going to be having the presence of thrombocytopenia. That is what is going to be seen as a feature in HUS. On top of this, suppose the age of the patient is changing from child to adult, and apart from kidney dysfunction, he is also having the presence of neurological manifestations. He is also having the presence of fever. Then I'm thinking in terms of something called as TTP, right? So those are the things that will be keeping you in good confidence in the exam with respect to the questions that they are putting up. Then we are going to be talking about something which is going to be given the name of leukemia. With leukemias and lymphomas, these are going to be given the name of WBC cancers. Of course, if my patient is going to be having a short history, I will call it by the name of acute leukemia. If he is having a longish history, I will call it by the name of a chronic leukemia. Acute leukemia, short history. My patient is going to be having the presence of features of decrease in RBC, WBC platelets. He is having hepatosplenomegaly, lymphadenopathy. If it is a child and there is a presence of a cancer, the commonest cancer I would think in terms of over here is going to be acute lymphoblastic leukemia. The cell that I'm going to be getting over here is a lymphoblast. How are I am going to be looking at a lymphoblast? The lymphoblast is going to be having the presence of TDT, pass positivity. If I'm looking at the morphology, a granular cytoplasm and the cytoplasm quantity is very less. This is what is going to be can be of two types. It can be B cell ALL or it can be T cell ALL. B cell ALL means that there is an involvement of the bone marrow. So patients is going to be having the presence of pancytopenia. There is a marker that is given. Then CD10 positive हो जाएगा. ये ठीक है बात. Then we are going to be talking about we have the presence of thymus involvement, mediastinal mass is there. The patient is going to be a teenager and he is going to be having the presence of notch mutation. Then good and bad prognostic factors are concerned. So female patient L1 type, blast count is less. All that is going to be associated with good prognosis. If I'm going to be talking about the presence of testicular involvement in age less than 1, all that means bad prognosis. Kaani khatam. Then I'm talking about acute cancer. I'm looking at a cell that is given the name of a myeloblast, that is given the name of AML. The AML that you associate with something like translocation 1517, this would be requiring a high degree of ATRA therapy because this can be responsible for development of DIC. So the patients can die because there can be aor rods. There can be a development of DIC and the patients can die. So differentiation therapy. Another one can be the patients who are going to be having the presence of translocation 821. These are the patients who are going to be suffering from a condition that is going to be given the name of chloroma. So patients can be having a development of apoptosis. AML can also be associated with development of gum hypertrophy. You can be having a patient who is having a history of suffering from Down syndrome. He is going to be having the presence of AML M7. This is a patient who is going to be having a high risk of development of bone marrow fibrosis. So that is about AML. How do I identify AML? Morphology. Large quantity of cytoplasm, lots of granules. Granules are going to be given the name of aor rods. Or I can be doing a staining, myeloperoxidase, Sudan black B, and there can be an example of non-specific esterase. Or what I'm going to be looking out over here is going to be CD molecular markers. Then I'm thinking in terms of chronic leukemia. Chronic leukemia, if the cell which is involved over here is a lymphocytic cell, I will call it by the name of CLL. CLL. So this is a cancer of elderly patients. It is a cancer arising from naive B cell. Patients are going to be having too many lymphocytes. These patients are going to be having repeated attacks of infections. These patients are going to be having a high risk of development of autoimmune things like autoimmune hemolytic anemia and autoimmune thrombocytopenia. Peripheral smear of these patients that will be showing you smudge cells. How will I confirm my diagnosis? Flow cytometry. Flow cytometry will show you presence of cells which are CD5 and CD23 positive. I want to treat these patients. I will give them anti-cancer drugs. Another cancer can be chronic myeloid leukemia. This is again a patient middle age. He is going to be having the presence of splenomegaly. On top of splenomegaly, he is having leukocytosis. When I do the differential, I find eosinophilia and basophilia. Then I find in these patients that there is a presence of pseudo-Gaucher cell. What is going to be seen in these patients is going to be the presence of decreased NAP score. And the other important thing that I find in these patients, I want to confirm my diagnosis. So I will go in for an investigation. The investigation is given the name of FISH. FISH investigation shows me BCR-ABL fusion gene. That is what is going to be given the other important name of course, I am you and you are aware that is going to be given the name of the presence of Philadelphia chromosome. Not talking about the cancer treatment. If I'm talking about ALL, I will be giving multiple cancer drugs to these patients, but intrathecal methotrexate. If I'm talking about AML, cytarabine is what is given. CLL treated with the help of fludarabine. CML treated with the help of imatinib. So that will take care of the pharma questions paper 2. Then I'm thinking in terms of lymphomas. Lymphomas can be of two types. One can be Hodgkin's, the second can be non-Hodgkin's. Hodgkin's can be further of two types, classical and non-classical. In the classical one, I'm thinking in terms of the most common one that is seen in our country, that is mixed cellularity. The most common one that is going to be seen in the world, that is going to be nodular sclerosis. The one that is going to be seen in case of HIV, that is lymphocyte depleted. The one that is seen in case of elderly individuals, that is given the name of lymphocyte predominant. So four different types. Which one is going to be having mediastinal involvement, nodular sclerosis? Which one is going to be having eosinophilia, mixed cellularity? Which one is going to be having the presence of lacunar cell? That is going to be nodular sclerosis. Which one is going to be having the presence of popcorn cell, non-classical? Non-classical is also called as nodular lymphocyte predominant Hodgkin's lymphoma. So this one is going to be having the presence of Reed-Sternberg cells, which are CD20 positive. They are going to be example of cells which are going to be associated with an important finding. This is what is going to be given the name of popcorn cell. Five subtypes of Hodgkin's. This is going to be having the presence of painless cervical lymphadenopathy. There is a presence of pain on consuming alcohol. There is a presence of amyloidosis. There is a presence of Pell-Epstein fever. Whenever I'm going to be thinking in terms of what exactly is to be done for these patients, treatment of these patients done with the help of ABVD regime. Whenever I'm going to be talking about non-Hodgkin lymphoma, commonest subtype of non-Hodgkin lymphoma is DLBCL. Marker is BCL6. Most aggressive that I talk about is Burkitt's lymphoma. You are going to be associating Burkitt's lymphoma with a gene that is called as MYC gene. Chromosome 8 is what will come into your mind. So 822. And then I'm thinking in terms of 814. Then I'm thinking in terms of 28. Several times we talked about the fact you do not associate with something called as 821. When we are talking about something called as Burkitt's lymphoma, lymph node biopsy shows you the presence of starry sky pattern. Whenever I'm going to be talking about the presence of follicular lymphoma, you think in terms of what is going to be given the name of translocation 1418. This is going to be having the presence of a marker BCL2. That's what is to be remembered. Then I'm thinking in terms of non-Hodgkin lymphoma, which is going to be also given the name of moltoma. Moltoma means infection has been caused by H. pylori for a long duration of time, and these patients are going to be having the presence of a translocation that is going to be given the name of 1118. Then I'm thinking in terms of a translocation that is going to be given the name of 1114. And what is coming to my mind is 11 and 14. This is going to be associated with mantle zone lymphoma. This is going to be associated with the mantle zone lymphoma. So depending upon what exactly is the question asked in your exam, you will be able to tackle each of these questions. Hodgkin's, the anti-cancer drug regimen is ABVD. Non-Hodgkin's, what we are talking about over here is R-CHOP. So not a problem at all. So that is what is going to take care of discussion of leukemias and lymphomas. These are the example of the image-based questions asked in the exam. So I can be thinking in terms of a question in the exam, which is a granular cytoplasm, which is a presence of EOR rods. This is going to be a patient suffering from AML, can be a patient suffering from AML-M3 or a patient suffering from APML. Very, very important question. What's the treatment for this condition? Of course, you know the answer. This is going to be translocation 1517. This is going to be a translocation 1517. That is what you need to remember. If I'm talking about a peripheral smear, elderly patient, leukocytosis, lymphocytosis, having the presence of smudge cells, this is a patient suffering from CLL. How do I confirm the diagnosis? Smudge cells are not confirmatory, so I will have to go in for flow cytometry, CD5, CD23 positive cells. Then I'm thinking in terms of pseudo-Gaucher cells. I'm thinking in terms of fish technique that shows me a fusion gene. So I'm thinking in terms of CML. The moment I think in terms of CML, Philadelphia chromosome, I'm thinking in terms of the treatment. Imatinib is what is to be given to the patient. Then this poor chap, African child, having the presence of a jaw mark, mixed gene is involved. Chromosome 8 is what is going to be associated. This is what is going to be associated with the presence of the Burkitt's lymphoma. Lymph node biopsy showing you the presence of starry sky appearance. Treatment is going to be done with the help of R-CHOP associated with 28, 822, and there is going to be 814 that is going to be involved. Remember, 821 is not going to be seen in this patient. Then I'm thinking in terms of the poor guy having a lymphoma. He is having the presence of this classical owl-eye appearance. This is what is going to be given the name of the classical Reed-Sternberg cell. Classical Reed-Sternberg cell means we are talking about CD15 and CD30 positive. So that is what is going to be seen in case of the classical Hodgkin lymphoma, right? If I'm talking about a Reed-Sternberg cell in which 15, 30 are negative, 20 is positive, that is the non-classical Hodgkin lymphoma. Then I'm thinking in terms of a patient having a serum protein electrophoresis, which is going to be showing me albumin, alpha 1, alpha 2, beta, and gamma globulins are going to be showing me the presence of what is going to be given the name of M spike. The moment I'm thinking in terms of M spike, this is monoclonal spike. I will think in terms of a patient having multiple myeloma. What will come to my mind is cells having the presence of Russell body, or I'm having the presence of cells which are given the name of Mott cells. So this is going to be a case patient suffering from plasma cell cancer. If I'm thinking in plasma cell cancer, patients are having multiple lytic lesions in the skull. So they are going to be having the role played by interleukin 6. Then in terms of these patients, how do I decide the prognosis? So prognosis is going to be decided upon by the serum albumin and the serum beta 2 globulin levels. So that is what is going to be told to the patient, that this is going to be useful for the prognosis. Once I made a diagnosis, I will treat this patient. So lenalidomide, dexamethasone is what is going to be given to the patient. So this patient is going to be treated now. Patient goes back healthy and happy, just like you and me. Then we are going to be talking about quiz time with respect to hemostatic disorders, platelet disorders, no history of trauma. Platelet and PTK is what is going to be seen over here, right? And if talking about clotting factor trouble, patient is having a history of fall. So there is a bleeding in the muscle, there is a bleeding in the joint that is going to be causing the trouble. With respect to hemophilia, that's the commonest type of hemophilia. Factor 8 is trouble. Only problem is increase in APTT. That is what is going to be seen in the patient. Now, if I'm talking about increase in APTT can be seen because of two reasons. Either the patient is going to be having hemophilia or the patient is going to be having the presence of autoantibodies. For differentiating between these two things, you are going to be doing a mixing study. Mixing study is going to correct the problem in a patient with hemophilia. Mixing study is going to, the problem remains in case of a patient having the presence of autoantibodies. Hemophilia factor 8 problem, X-linked recessive. Hemophilia B factor 9 problem, X-linked recessive. With factor 9, it is less common. Again, the same problem, that there is a presence of something that is given the name of increase in APTT. Then I'm thinking in terms of a condition that is going to be given the name of von Willebrand disease. Von Willebrand disease is interesting because bleeding time is increased, APTT is increased. But what is fundamentally normal in this patient is platelet count is normal, PT is normal. Von Willebrand disease can be of two types. There can be an example of a functional problem or there can be an example of an actual problem. Type 1 von Willebrand disease is the most common type, that is autosomal dominant. Type 2 von Willebrand disease is functional problem. In your exam, type 1 is asked in the exam. So remember about autosomal dominant and the type 1, which is going to be associated with the development of the mild disease. Then we are thinking in terms of a patient having liver failure. All these parameters are going to become abnormal, but the differentiation is FDP is absent. Read the question carefully. If he is making a mention of DIC patient, the patient will be having the presence of majority of them. Platelet count going down, bleeding time increasing, PT increasing, APTT increasing, but the patient is also having presence of FDP. The FDP is fibrin degradation product, and the patient can also be having a mention of the fact that this patient is going to be having the presence of what is going to be given the name of D dimers. So D-dimer is what you read in surgery also, pulmonary thromboembolism. That can be seen in a patient who's going to be suffering from DIC as well. So that will take care of your question in the exam pertaining to the hemostatic disorders. That's important, right? If I have to treat a patient suffering from hemophilia A and B, I will give him respectively factor 8 or factor 9 concentrates. Which type of blood will be given to patient having hemophilia A? That is cryoprecipitate. Which type of blood will be given to patient having hemophilia B? That is fresh frozen plasma. After the persistent demand, just 2 sips of water. Then I'm talking about von Willebrand disease. I'm again giving to this patient something that is going to be given the name of cryoprecipitate. For DIC patients, the only thing that is going to be working in this patient is going to be maybe a small degree of administration of heparin or treat the primary cause. That's what is important, right? We wind up our discussion of hematology by talking about something that is given the name of vacutainers. With regards to vacutainers, of course, you have an idea about blue vacutainer. First, let us revise what are the chemicals or the anticoagulants present in them. In blue, there is a presence of trisodium citrate. In red, nothing is present. In lavender color, there is a presence of EDTA. In case of gray one, there are two chemicals present. One which is going to be given the name of potassium oxalate, and the second one that is going to be given the name of sodium fluoride. Sodium fluoride. So that is what you need to have an idea. Agreed. Now, what are they going to be used for? If I have to do a routine investigation, I give you the same questions which are likely to be asked in an exam on a practical basis. You have to carry out a routine investigation. Routine investigation मतलब आपने पेशेंट के अंदर हीमोग्लोबिन आपने चेक करना है या पेशेंट के अंदर आपने स्मीयर बनाना है. So for routine investigations like blood investigations, you are going to be talking about lavender colored. Right, routine investigations, the easiest example I can talk about over here is HB. Then I'm talking about a special situation in which I have to do the LFT KFT of the patient. LFT KFT of the patient has to be done with the help of the red one. Then I have to suspect a patient who's suffering from hemophilia. I have to carry out a special study in which I have to carry out PT APTT study. So PT APTT study, PT and APTT study is what is to be carried out in the blue vacuum, blue top vacuum. And then I'm talking about a patient in who happens to be a diabetic patient. If the question says in the patient having diabetes, I have to measure HbA1c, then I will go in for lavender color. HbA1c is something which is going to be for long-term glycemic control. But if the question says I have to measure the routine hemoglobin, routine glucose in this patient, for routine glucose monitoring in this patient, blood glucose monitoring in this patient, what I would be going in for is a gray colored vacuum thinner. Gray colored vacuum thinner. Why are we using gray colored vacuum thinner for glucose? Is for the simple reason because you want to estimate glucose correctly. Sodium fluoride is an example of an inhibitor of an enzyme that is going to be given the name of enolase. That's a biochemistry link. Sodium fluoride inhibits the metabolism of glucose because it inhibits the enzyme enolase. So you are going to be getting a correct value. Then if the purpose of sodium fluoride is going to be inhibition of enolase, why are we adding potassium oxalate? Potassium oxalate is an example of an anticoagulant. This is an example of an anticoagulant. That's what we just need to have an idea so far as this particular vacutainer is concerned. Now, there can be a special situation in which, let us say, your patient is suffering from metabolic alkalosis or metabolic acidosis. In that condition, what you have to do for these patients is ABG. For ABG purpose, what you are going to be doing for these patients is you are going to be taking an insulin syringe. And in the insulin syringe, you are going to be pre-filling the syringe with the help of something called as heparin. So heparin is useful very much for the purpose of carrying out ABG analysis, arterial blood gas analysis, particularly in the insulin syringe in the patient. Before putting any sample in any of the vacutainers, usually as a clinical dictum, please remember the first sample that is being taken is only and only for the purpose of blood culture. The first sample is for the purpose of blood culture. After that, the other important vacutainers are going to be filled in this order. Right? So that is what you just need to have an idea over here. And that is what is going to take care of a discussion of hemat as well. Right? Time for us to perhaps take in a 10-minute break and then we'll continue with the discussion of the systemic path component. Right? Thank you so much for joining at this point of time. Stay tuned. Take a break, water break, loo break, coffee break, whatever break you plan, or just stretch yourselves, ladies and gentlemen. We are cruising at an absolutely, absolutely comfortable speed. Let's just continue with our discussion. Right. Thank you. Transit में All right, yeah. Welcome back to our discussion, wherein we talk about the second component of our discussion over here, which is going to be with respect to the topic of systemic path. And as usual, we are going to be talking about the important things. I hope the audio and the video is pretty much visible. Just let me just check. Right. Okay. All good? All right. Good to go. Good to cruise again. Let's see the altitude again. Let's see the skies again. Sky's the limit. So taking off its cerebellum once again, starting with the system of GIT. Now, when I talk about GIT, I'm going to be talking about something which is going to be given the name of Meckel's diverticulum. Meckel's diverticulum, as we understand, is a true diverticulum. It follows the rule of two. So male-female ratio is going to be 2:1. It's going to be 2 inches in length. It's 2 feet proximal to the ileocecal valve. And this is going to be having an appearance like this, which can be an example of an image-based question. Why would they ask you this question? आपको exam में पता होना चाहिए. It is going to be having the presence of two types of mucosas. One that is going to be the gastric mucosa. The second one, that's going to be an example of a pancreatic mucosa. Meckel's diverticulitis is going to be mimicking very closely in case, especially in case of a child. You could be having the presence of a right lower quadrant pain along with nausea and vomiting. So therefore, it can mimic the pain of acute appendicitis. Of course, you also need to talk about the presence of the pertechnetate scan that you're going to be doing for these patients, right? The technician scan. Then we are talking about something called as Hirschsprung disease. Hirschsprung disease is going to be also given the name of aganglionosis. The fundamental problem in these patients, that's a paper 2 question, is a failure of migration of the neural crest cells. What is going to be seen in these patients is this can be seen with red gene mutation. That's a PG question. Very importantly asked as an image-based question is these patients are typically going to be male patients who is going to be having a problem in the passage of meconium. If I'm going to be doing an X-ray of these patients, they is going to be showing me the presence of a proximal part of the colon that is going to be dilated and the distal part of the colon that is going to be constricted. And there is a very, very important typical junction that is going to be seen in which I can make out that there is a fundamental problem present over here. Right. So this is what is going to be done, seen as a finding in these patients. What you're going to be doing for these patients is going to be a suction biopsy. And that suction biopsy can be not only diagnostic, it can be therapeutic for this patient. Surgery for this patient is going to be given the name of the Dohlmann procedure. Then we talk about esophageal disorders in which endoscopy is going to be showing me the presence of a red velvety mucosa. The microscopic appearance in the tissue over here taken from this position is going to be showing me the presence of the intestinal columnar epithelial metaplasia. And I can confirm the presence of the intestinal columnar epithelial metaplasia by the presence of these kind of special cells, which are going to be given the name of goblet cells. Goblet cells require the presence of a special staining. That's going to be given the name of the Alcian blue staining, and the Alcian blue staining is going to be associated with the detection of the acidic mucin. Why should we be concerned with the Barrett's esophagus? If this condition is not being taken care of, it can have a progression into a malignancy. And because of the presence of the columnar epithelium, the chidocancer the patient is going to be having over here is an adenocarcinoma in the lower part of the esophagus. The next one that we talk about over here is going to be achalasia cardia. Very first question is a fact-based question. It's the commonest motility disorder that is going to be seen in the esophagus. The patients are going to be having a selective loss of inhibitory neurons, and therefore the patients are going to be having a development of dysphagia, which is going to be more for the liquid food in comparison to the solid food. The patients are going to be having a classical triad because of which there's going to be having the presence of a high tone of the lower esophageal sphincter, and that's why the patients are going to be having the dysphagia. The patients are going to be having the complication wherein they are going to be having the high risk of development of an aspiration, which can be because of accumulation of the esophageal contents. And this increases the risk of development of the squamous cell carcinoma of the esophagus. That's a classical couple of years back asked question asked in the exam. There is a gradual tapering in the lower part of the esophagus, which is also being associated with the name the bird beak appearance. However, this is not a diagnostic feature of achalasia cardia. What is going to be required for the investigation choice for this kind of a condition is going to be manometry, and that is going to be showing you the high tone. Medical management of this patient can be done with the help of two types of drugs. One can be calcium channel blockers, especially a drug that is going to be given the name of nifedipine, and the second can be an example of a drug that is going to be given the name of botulinum toxin, which is going to be responsible for having its mechanism of action as presynaptic inhibition of release of acetylcholine. So injections have to be given. Of course, the definitive treatment for these patients happens to be an example of a surgery that is going to be given the name of myotomy, and this kind of a myotomy is going to be given the name of Heller's myotomy. The problem with Heller's myotomy is a commonest complication that is going to be a development of the gastroesophageal reflux. Having taken care of those 10 questions, then we talk about esophageal cancer in the Western world, it is going to be present in the lower one to the third of the esophagus. And that's going to be an example of an adenocarcinoma in the developing countries, including India and Southeast Asia. It is going to be the middle one third, which is going to be associated with the development of the cancer. And the type of cancer that is going to be seen over here is going to be squamous cell carcinoma. The number one risk factor for development of squamous cell carcinoma still remains smoking, even though alcohol, plus minus books make a mention, you can put it under the reserve category of the contributing factors for esophageal cancer. But you can definitely be talking about the concept of Barrett's esophagus for adenocarcinoma. You can be thinking in terms of something called as Plummer-Vinson syndrome, in which there is a female who's going to be having iron deficiency anemia. She's having the presence of esophageal webs, and there is a presence of the development of atrophic glossitis in the patients. These patients are going to be having the presence of dysphagia. The dysphagia in these patients is going to be more for the solid food in comparison to the liquid. Patients are going to be having the presence of weight loss. There is going to be presence of hoarseness of the voice because of involvement of the recurrent laryngeal nerve. What exactly is going to be done for making a diagnosis of these patients is going to be the endoscopy with biopsy. If there is a presence of keratin, then that is what is going to be showing you the presence of the squamous cell carcinoma. If you're going to be having no keratin, but you're going to be having the presence of a glandular differentiation, then this is what is going to be an indicator for adenocarcinoma in the patients. Of course, if I'm going to be doing a barium swallow, what I can be showing in these patients can be a rat tail filling defects. That is because of the irregular growth of the cancer, because of which you're going to be having a rat tail kind of an appearance. For treatment of these patients, you can be doing administration of anti-cancer drugs, the platinum-based therapies, and you can be giving a partial or total esophagectomy. And then you are going to be doing the other transplantation with regards to maybe the bowel or the other things which are going to be replacing the esophageal tube. Please recall the fact esophagus is an example of an organ which is going to be having the presence of mucosa, submucosa, muscle layer. There is no serosa. Therefore, there is a higher chance of the cancer spreading along the adjacent anatomical structures. That is what you need to remember over here. One extremely rare risk factor for development of cancer over here is going to be Tylosis at palmaris. Less commonly asked on the exam questions, but please be familiar with the fact that in this condition, there is a presence of thickness of the skin of palms and soles, which is given the name of congenital hyperkeratosis, and there is a high risk of development of cancer in these patients. With respect to the other risk factors, one of the most important risk factors for development of cancer of the stomach nowadays in the patients happens to be what is going to be given the name of H. pylori. H. pylori, which is an example of a bacteria which is going to be requiring the presence of special staining, the silver staining, and the silver stain that is being used over here is a Warthin starry stain. This is a classical image that they put up to you in the exam in which there is a presence of prominent gastric rugal folds. And this kind of a condition is going to be having a special name. It is going to be given the name of Meniere's disease. Meniere's disease is going to be an example of a condition in which the affected individual is going to be having the presence of increased concentration of a particular cytokine or a chemical. And that cytokine or a chemical is what is going to be given the name of, as rightly pointed out, it is going to be given the name of TGF alpha. So TNF alpha is what you're going to be associating with cachexia. TGF beta is what you associate with wound healing and fibrosis. TGF alpha is what we are talking about over here. And these patients quite commonly are going to be having the presence of hypoproteinemia because of the development of diarrhea. At the same time, the patients are going to be having a higher risk for development of cancer of the stomach as well. Right. The other thing that we need to talk about over here is going to be the ulcerative lesions over here. Of course, I can be thinking in terms of intestinal tuberculosis because of Mycobacterium tuberculosis secondary to pulmonary TB. The patients are going to be having the presence of an ulcer that is going to be given the name of a tuberculosis ulcer. Is classically going to be an example of a transverse ulcer. And this is what is going to be present at the level of the ileum in these patients because of involvement of the damage at the level of the ileal lymph nodes as well. The patients are going to be having the presence of tabes mesenterica. The problem with tuberculosis is patients are going to be having too much of fibrosis over here. And because of development of too much of fibrosis, patients are going to be having a development of subacute intestinal obstruction. The moment I'm thinking in terms of the other important cause of the trouble over here in the patients, that can be because of enteric fever or typhoid, salmonella typhi, fecal transmission. The patients are again going to be having the presence of an ulcers which are going to be located in the ileum. But the shape of the ulcer is going to be different over here. It is going to be an example of an ulcer that is going to be longitudinal over here. Right. What is going to be classically seen in these patients is RBCs present inside macrophages or erythrophagocytosis. And these are an example of ulcers which are going to be having an important trouble that they may actually bleed in the patient. Whenever we're going to be talking about the presence of the easiest ones, that is going to be a flask-shaped ulcer. Flask-shaped ulcer is what is going to be seen in patients who are going to be suffering from entamoeba histolytica infection, again a fecal transmission, because of which there is going to be entry of cyst inside the water. The cyst get converted into trophozoite from the intestine, particularly from the sigmoid colon. It is going to be causing involvement of the portal vein, then the liver, and there is a development of hepatic amoebiasis. As a result of which, the patients can be having a development of Anchovy sauce pus in the liver. The next thing that we talk about over here is patients having the presence of gut involvement. They would be having the presence of Crohn's disease, and that is what is going to be having the presence of snake-like ulcers, which is also going to be associated with the term serpentine ulcers in the patients. So whenever you are thinking in terms of fibrosis and stricture formation, you must always think in terms of tuberculosis. The other important cause of fibrosis and stricture can be inflammatory bowel disease, which can be a condition like Crohn's disease in the patients. Longitudinal ulcers are going to be seen as a feature of a patient suffering from typhoid. Flask-shaped ulcers are going to be seen in a patient suffering from amoebiasis. Of course, for each of them, the drug of choice is going to be absolutely different. For this one, of course, you are aware about the story that has been told to you so many times, and metronidazole is a drug of choice for this condition. Having said that, we talk about an example of a condition that is associated with malabsorption disorder. The malabsorption disorder, which is going to be associated or talking about over here, is going to be the DQ2, DQ8 condition. And the problem that we have in these patients is anytime the patient is going to be eating something which is going to be containing gluten, there is an autoimmune attack at the level of the cells. So when I'm talking about barley, rye, oat, and wheat, there is a gluten sensitive enteropathy, as a result of which the patients are going to be having the development of villus atrophy. There is a presence of crypt hyperplasia that is going to be seen in the patients, and the patients are going to be having the development of the surrogate markers like the different antibodies which are going to be present. The antibodies which are going to be present in these patients, I hope the diagnosis is what is clear to you. That is going to be celiac flu or gluten sensitive enteropathy, are anti-endomycin antibodies and anti-tissue transglutaminase antibodies apart from anti-gliadin antibodies. The best way of making a confirmatory diagnosis, mark my words, confirmatory diagnosis, is that these patients will be undergoing a biopsy at the level of the duodenum, and that is what is going to be showing you a finding like this. Skin complication in these patients can be dermatitis herpetiformis. Long-term complication can be development of intestinal lymphoma. You do not want your patient to have all those complications. So the simplest thing is that for this patient, you are going to be just doing a dietary substitution. Give him maize, give him rice, and let his life be peaceful, and your life also become healthy as well. In case of a patient who's going to be having dermatitis herpetiformis, you are going to be having an immunomodulatory action of a drug which is going to be given the name of Dapsone. Of course, you know the fact that Dapsone is an example of a drug which is going to be belonging to the class of sulfonamides. Sulfonamides are going to be example of drugs which are going to be interfering with the metabolism of folic acid. So they belong to the category of anti-metabolites. The problem with the sulfonamides is that these drugs are going to be getting the sulfa unit. Sulfa unit drugs all are responsible for causing a development of an important side effect, that is allergy. And one of the manifestations of that allergy is the patients are going to be having a development of a skin rash. So most of you are familiar with an example of a drug which is given the name of glibenclamide, glimepiride, gliclazide. These are example of drugs which are sulfur drugs. They are given for the treatment of diabetes mellitus type 2 particularly. So these are all examples of sulfonylureas. Again, they are responsible for causing sulfur related allergic reactions in the patients as well. I do hope and remember that most of you are familiar with an example of the target site for the action of sulfonylurea. So sulfonylureas are going to be exerting their site of action, which is going to be seen in which part, which organ in the body. सल्फोनाल्यूरियाज बॉडी में कौन सी जगह पे काम करते हैं? फैट टिश्यू में करते हैं, लीवर में करते हैं, पैंक्रियाज में करते हैं, किडनी में करते हैं, और दे आर गोइंग टू बी एक्टिंग इन द गट. That's an easy question. I thought you already had an idea, but considering your answers, I would just like you to recall that sulfonylureas increase insulin secretion, ladies and gentlemen. So they will be acting in the pancreatic beta cells. Please don't have a problem in that. Metformin acts in the liver. Incretin drugs, the glucagon-like peptide-like drugs are the ones which are going to be associated with their action in the intestine. The drugs which are going to be the glyphosins are going to be acting in the kidney. Don't make a mistake on those questions. They're fairly easy questions. We are supposed to not make a mistake over here. The next one that we talk about over here is going to be an example of a polyp that is going to be given the name of a neoplastic polyp. That's a dangerous kind of a polyp that is going to be seen in the patients, which is an adenomatous polyp. Adenomatous polyp can be of multiple types. We can be having the example of a tubular polyp, villus polyp, or a tubulovillus polyp. Basic easy questions for your exam. The tubular polyp is the most common type of polyp that is going to be seen in the patient. However, please remember the chances of cancer is maximum with the villus polyp. Villus polyp is also going to be having a problem that the patients are going to be having a loss of potassium and loss of proteins in the stools of these patients. And therefore, this is an important feature so far as this polyp is concerned. The third polyp is an example of what is going to be given the name of a tubulovillus polyp. So most common is tubular, most dangerous is villus. That is what we remember. Why would you talk about this condition is because usually normal people like you and me will not be having too many adenomatous polyps, but the risk of development of the polyps increases tremendously if the patient is going to be having the presence of a mutation in a gene that is going to be given the name of APC gene. Such a condition is what is going to be given the name of familial adenomatous polyposis. For making a diagnosis of this condition, you require minimum 100 number of polyps in the patient, and the gene that is going to be present in what kind of a location it is present on chromosome 5q. The other thing is that when we're talking about familial adenomatous polyposis, it can be having multiple variants. One of the variants that can be seen in the patients can be classical variant, Turcot syndrome, and Gardner syndrome. Turcot syndrome is the one which is going to be associated with CNS tumors. And when you are going to be talking about this particular thing, you are going to be associating this with a patient who's going to be having the presence of a soft tissue tumor. He could be having the presence of a dermoid cyst, he could be having a fibroid tumor, desmoid tumor, that is going to be seen in a patient suffering from Gardner syndrome. Only polyp plus the patient is going to be having the presence of an eye problem is going to be seen as a classical feature of the patient. The other important example of an autosomal dominant syndrome that the patients could be having is because what is given the name of Lynch syndrome. Lynch syndrome patients, it's an example of an autosomal dominant. So CEOs dominate the industry of any type. CEOs are autosomal dominant in nature. There is a high risk of development of colon cancer, endometrial cancer, and ovarian cancer in these patients without a doubt. Such patients are going to be having a high risk of development of colon cancer, particularly right-sided colon cancer is what is going to be seen in these patients. So CEOs think, and that's the way the things are, that they always think that they're right. So right side of the colon is going to be seen in these patients. However, when we are talking about a patient who's going to be suffering from the other important risk factors with regards to colon cancer, consumption of dietary lipids, consumption of alcohol has been shown to be increasing the risk. Of course, patients having a presence of inflammatory bowel disease, patients having the presence of inflammatory bowel disease and an infection caused by Streptococcus bovis enterocolitis are also at high risk of development of colon cancer. The commonest clinical presentation of a patient having colon cancer is rectal bleeding. Elderly patient with rectal bleed, elderly patient with iron deficiency anemia, you must rule out the presence of iron, the presence of colon cancer. Then the patients can be having the presence of spurious diarrhea, that means passage of blood and mucus, and these patients have a feeling that they have to go to the washroom time and again. That is what is going to be given the name of tenesmus. If at all you're going to be doing a colonoscopy in these patients, what you're going to be getting in these patients is the presence of a napkining appearance in the gross examination, and of course you are going to be doing a biopsy for these patients. So the biopsy is what is going to be showing you the presence of a glandular pattern. If I do a barium meal study in these patients, a barium enema in these patients, what that is going to be showing me over here is the patients are going to be having the presence of a paper 2 question for exam, the classical apple core appearance. You are not supposed to miss this question. That's a very standard question in the last 16 to 17 years for which I've been taking this test sessions. And then I'm talking about the presence of a tumor marker over here. The classical tumor marker that we talk about over here is going to be given the name of carcinoembryonic antigen. The second important tumor marker that we have over here is CA19-9. Now, the same type of tumor markers can also be seen in a patient suffering from pancreatic cancer. So please be very, very careful. In case of pancreatic cancer, the more important marker is CA19-9. That's easy for you to remember when you talk about 19-9. 9 is the opposite of P. So 19-9 is more for pancreas. CEA is more common for colon cancer. That's how we remember it. But nonetheless, both of them can be used interchangeably in case the other option is not available in the exam. Finally, when you're talking about a patient who's going to be suffering from colon cancer, what we can be doing for these patients is an ileoileal pouch anastomosis, and the patients are going to be having the presence of a surgery that is going to be given the name of total prophylactic proctocolectomy. Please be familiar with the fact that if I'm talking about a squamous cell carcinoma, that is what is going to be seen at the level of so far as the anal carcinoma is concerned. And the anal carcinoma is going to be associated with the exposure to a virus that is going to be given the name of the human papilloma virus. Human papilloma virus is responsible for causing oropharyngeal cancer. It can cause rectal cancer. It can cause penile cancer. It is also responsible for causing a development of the anal carcinoma. That is what is cervical cancer. That's what we are aware of, right? Out of all the subtypes, of course, we are all aware HPV-16. That's a dangerous sweet 16 age. 16 is the most dangerous. That's having the maximum chances of causing the trouble in the patients. So with respect to the image-based questions, I think the most classical image that you have to remember for the exam purpose is this one. That's apple core birefringence. That's what is important. And of course, with regards to the question asked in the exam pertaining to the syndromes component over here, you can talk about a question suffering of a patient suffering from adenomatous polyps, right? Then talking about the concept of the involvement of the cardiovascular system. So we talk about something that is going to be given the name of vasculature disorders. As per the vascular disorders, of course, we divide them or we have a segregation for them into large vessel, medium vessel, and small vessel vascular disorder. The large vessel vascular disorder are going to be including a disorder that is going to be given the name of temporal arteritis. It is the commonest vascular disorder that we have in patients who are having age more than 50 years. Headache is the commonest complaint. Jaw claudication is the most specific symptom. These patients can have a dangerous complication, sudden onset of blindness. The patients are going to be having a diagnosis which is going to be done with the help of a temporal artery biopsy. Multiple points of biopsy has to be taken in the patient. These patients are going to be showing you the presence of a granulomatous inflammation, and there is going to be a presence of giant cells which can be seen over here. So therefore, the patients are going to be having the second important name for this condition, giant cell arteritis. Be familiar that the actual damage to the vessel can be seen in the form of fragmentation or damage at the level of internal elastic lamina. That's a PG question, however, and that is seen only with the help of special silver staining. For your purpose, temporal arteritis, headache, increased value of ESR, jaw claudication, the presence of polymyalgia rheumatica, sudden onset of blindness are standard questions. Please remember that for this condition, the patient is, you don't want the patient to have a loss of his vision, so you have to give this patient as early administration of steroids as possible. The second important example of a large vessel vascularity disorder is what is going to be given the name of Takayasu arthritis. It's an example of a condition that is also going to be having a second important name of non-specific aortic arthritis. This is a similar condition, but the age of the patient is a younger patient. This condition is the most common cause of renovascular hypertension in young adults in India or Southeast Asia for that matter. In this condition, the patients are having different other names as well. It is also called as aortic arch syndrome. It's also known by the name of pulseless disease in the patients. Whenever we are going to be talking about Takayasu arthritis, of course, the clinical manifestations are similar, and therefore these patients are also at high risk of development of a complication like sudden onset of blindness. Having said that, we talk about the medium vessel vascularity disorder. The first condition that we talk about over here is polyarthritis nodosa. This is associated with hepatitis B infection in 30% of the patients. Multiple vessels are affected in these patients. Kidneys are affected in these patients, but that is in the form of renal microaneurysms. What you need to remember over here is glomerulonephritis is not seen in these patients. Pulmonary vessels are not involved in a patient suffering from polyarthritis nodosa. In patients having polyarthritis nodosa, you are going to be having the presence of fibrinoid necrosis. And from the name itself, you are clear it's an example of a type 3 hypersensitivity reaction. Why do we need to talk about polyarthritis nodosa? This condition, paper 2 question, is the most common cause of mononeuritis multiplex. I have said this multiple times again, perhaps for the last time before your exam. Commonest cause of mononeuritis multiplex about 10, 15, 20 years back was leprosy. But nowadays, the commonest cause of mononeuritis multiplex is polyarthritis nodosa. The other example of a condition that we talk about is what is going to be given the name of Burgess disease. Burgess disease is an example of a condition which is also having the second name of thromboembolism obliterans. It's a classical problem of a young male smoker who is having a hypersensitivity reaction. So there is an involvement of the arteries, particularly tibial artery, then veins, and there is involvement of nerves. Patients are having the presence of an intermittent claudication. They are going to be having a development of a vasospasm or Raynaud's phenomena. If not being taken care of, these patients are at high risk of development of gangrene, and they have to undergo an amputation to save their lives. So the best thing that is required for these patients is that they have to quit smoking, and they are going to be responding to the administration of vasodilator therapy. Then we talk about a problem in whether it is going to be seen in case of kids, that is going to be given the name of Kawasaki's disease. In this kind of a condition, the fundamental problem that you need to understand is the fever plus cream criteria. So fever is a sine qua non, that means fever तो होना ही चाहिए. Cream criteria का expansion आपसे exam में पूछा गया था. There is a presence of non-purulent or non-infectious conjunctivitis in the patients. There is a presence of rash in the patients, edema of hands and feet. Cervical lymphadenopathy on one side is seen in these patients, and mucosal involvement in the form of development of the strawberry tongues is what is going to be seen in these patients. Of course, strawberry tongue is also seen as a feature of scarlet fever. You are all intelligent to know that. These patients are also having the increased platelet count, and therefore the problem that we have in these patients is it can cause myocardial infarction or heart attack in case of children. IVIG aspirin is what is going to be useful for the management of these patients. Then we are going to be talking about an example of a condition that is going to be a small vessel vascularity disorder. Small vessel vascularity disorder. The first condition that we talk about over here is a condition that is going to be given the name of granulomatosis with polyangiitis. Even though granulomatosis with polyangiitis is an example of a condition classified under small vessel vascularity disorder, but some of these patients sometimes can also have involvement of medial vessels also. Medium-sized vessels also can be involved in these patients. Now, in this condition, it is also known by the other important name of Wegener's granulomatosis. So this condition is characterized by the development of involvement of the rule of organ involvement. I hope you remember about the kidney involvement. You know about the involvement of lungs in these patients. You know about the involvement of the upper respiratory tract in these patients. Kidney involvement is in the form of crescentic glomerulonephritis. Lung involvement is in the form of pneumonia. Cavitary pneumonias is particularly common for this condition, and the patients can have otitis media. They can have subglottic stenosis. They can have a development of septal perforation as well. These patients are classically going to be having the presence of an antibody, and that antibody is what is going to be given the name of PR3 ANCA. That is what is going to be diagnostic. Of course, cyclophosphamide is what is helpful in this patient. An example of a pure small vessel vascularity disorder is what is going to be given the name of microscopic polyangiitis. Microscopic polyangiitis is what is also having a second important name of leukocytoclastic meningitis, leukocytoclastic meningitis. This is an example of a condition in which only and only small vessels are affected. There is no involvement of medium vessels over here in this condition. That was the basis of one of the recent exam questions. Microscopic polyangiitis is an example of a condition which is going to be most commonly affecting venules. Post-capillary venules are affected in these patients, and these patients can be having the presence of an antibody that is going to be given the name of MPO ANCA. That is what you need to remember. Multiple vessels can be affected in these patients. Another example of a condition is what you associate with oculo-orogenital syndrome. This is a condition that is going to be given the name of Behçet syndrome. This is oculo-orogenital syndrome. HLA-B51 is what is going to be affected in these patients. And of course, these patients are going to be having the presence of genital ulcers. They're going to be having the presence of oral ulcers. And these patients are also going to be having the presence of uveitis in them. It is a genital ulcers, which are going to, that is the oral ulcer that is going to be the typical feature so far as these patients are concerned. So that's about the vascular disorders about which we need to have an idea. Then we are talking about an example of a condition in which different vessels are going to be having an involvement. The first condition is in which the vessels are going to be having an onion skin appearance of the blood vessel. This is what is going to be seen as a feature of a patient suffering from malignant hypertension. This condition is going to be given the name of hyperplastic arteriolosclerosis. Hyperplastic arteriolosclerosis is what is going to be seen as in this condition. In this kind of a condition, I repeat the fact, there is an onion skin appearance of the blood vessel of the kidney. We have said it so many times earlier. Onion skin appearance of the spleen is a feature of SLE, whereas onion skin appearance of the X-ray is going to be seen in feature of patient suffering from Ewing sarcoma. If I'm going to be talking about a patient who is going to be having a pinkish appearance of the blood vessel over here, this is what is going to be seen as a feature of a patient who's going to be suffering from Hyalin-like appearance. Hyalin arteriolosclerosis is what is going to be seen in patients who are going to be suffering from either diabetes mellitus. It can be seen in routine hypertension, or it can also be seen in a patient who's going to be an elderly patient. So that is what you need to remember. And these patients are going to be having a gross appearance of the kidney. That is what is going to be associated with the term leather grain kidney. So malignant hypertension has flea-bitten kidney. Malignant hypertension has flea-bitten kidney, whereas benign nephrosclerosis is going to be having the presence of leather grain appearance of the kidney. That is what you just need to remember over here. Having said that, we just need to talk about the presence of myocardial infarction. The important things which are going to be asked in the exam is with regards to the microscopic findings. In the earliest microscopic finding, what you need to remember categorically is the presence of intercellular edema, and the patients are going to be having the presence of waviness of the fibers. In the first 72 hours, patients are going to be having the presence of neutrophilic infiltration. That is to be kept in mind. Please remember the fact, in the first 24 hours, the number of neutrophils are very, very limited. So this is what is going to be given the name of early neutrophilic infiltration. Early neutrophilic infiltration. After 24 hours, large number of neutrophils come over here. So you will be using the term massive or brisk neutrophilic infiltration. Massive or brisk neutrophilic infiltration. After 3 days, the neutrophils get replaced by macrophages, which is just asked as one time asked question. But we need to remember, however, here is as soon as macrophages come, gradually it is going to be followed by the deposition of the granulation tissue. This is of a practical significance because once macrophages come and there is a deposition of the granulation tissue, the cardiac tissue per se becomes very weak. When it becomes very weak, there is a high chance of cardiac rupture. Now, please remember the questions that are going to be put up to you in the exam. When we are talking about the enzymes which are going to be useful for making a diagnosis of myocardial infarction, there are certain novel biomarkers which are now being used for heart attack. One is heart fatty acid binding protein, and the second is going to be ischemia modified albumin. Clinically, as on date, in today's time also, the best enzyme for making a diagnosis of myocardial infarction is cardiac troponin T and cardiac troponin I because of high sensitivity, specificity, and they are also going to be required for making a diagnosis of reinfarction. We have a special stain or a chemical by which we make a diagnosis of heart attack on the gross examination that is given the name of triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride is going to be reacting with LDH enzyme or the lactate dehydrogenase. Normal people like you and me are going to be having LDH2 more than LDH1 in our blood. But in heart attack patients, you are going to be having LDH1 increasing the blood massively. So that is what is going to be associated with the word flipping of the LDH ratio. In case of normal tissues, when triphenyl tetrazolium chloride is going to be acting with the lactate dehydrogenase, you are going to be getting a brick red color. So the brick red color means a living tissue, and we said it multiple times, Geo mere lal. So lal color means living tissue. But the moment you're going to be talking about the dead tissue is white or yellowish appearance. This is suggestive of the infarcted area in the patients. The other important thing that we need to talk about over here is going to be the fact that these patients are going to be having at times the presence of a special situation wherein the patients came to the hospital at the right time and these patients were given thrombolytic drugs. Example of these drugs include streptokinase, LTplase, urokinase, reteplase, tenecteplase. But instead of improvement of the patient's condition actually worsened. That is because of free radical injury. This mechanism of free radical injury is given the name of reperfusion injury. Now, what is going to be seen as a microscopic finding of these patients, because you are thrombolizing the clot, there is a lot of blood coming, a lot of blood brings a lot of calcium. A lot of calcium is responsible for causing contraction, and that is responsible for causing contraction bands in the patient. So contraction bands is going to be seen as a feature of a patient suffering from reperfusion injury because of administration of the thrombolytic therapy, right? That's what is to be remembered so far as the question is concerned. Of course, your last year's exam question, if I'm going to be talking about chemical like TTC, it requires a minimum of 3 hours for before you are able to make a diagnosis of myocardial infarction on the gross examination. So we talk about that TTC, 3 alphabets hain. 3 hours is what is the minimum time required before you are able to make a diagnosis of myocardial infarction using this particular stain or this particular enzyme. That is what you need to remember over here, right? The next thing that we talk about over here is with regards to a patient who's going to be suffering from rheumatic heart disease. With regards to rheumatic heart disease, half of the story is already over. It's a group A beta hemolytic streptococcus induced type 2 hypersensitivity reaction showing the phenomena of molecular mimicry or cross antigenicity. What we are going to be having in these patients is these patients are going to be requiring the modified Jones criteria or the WHO criteria for making a diagnosis. Classical feature that we have in these patients is going to be given the name of pancarditis. And one of the important histological findings of these patients is they are going to be having the presence of a structure that is going to be given the name of Ashev's body. Now, Ashev's body means that you're going to be having the presence of fibrin or necrosis. You're going to be having the presence of lymphocytic infiltration, and you will be having the presence of modified macrophages, which are going to be given the name of NHCOW cell in these patients. In rheumatic heart disease, patients are going to be having the presence of small, sterile, tight vegetations, firmly attached vegetations along the line of closure. That's an important feature. So these vegetations do not embolize. Of course, everybody knows the fact in rheumatic heart disease, the commonest valve affected in the patients happens to be the mitral valve. Then there is involvement of the aortic valve. Then there is tricuspid valve. And in the last, you have involvement of the pulmonary valve. In the mitral valve involvement, what you find in these patients is that there is initially a development of mitral regurgitation, and after some time, because of fibrosis and calcium deposition, there is going to be a development of mitral stenosis. Right? For mitral regurgitation, you are going to be either doing a repair of the valve or going to be doing a replacement. For mitral stenosis as well, either you are going to be doing a valvulotomy or you're going to be doing a replacement. That is what is to be kept in mind. When you're doing a valvular replacement, there are two types of valves which are available, metallic and non-metallic. Metallic valves have got longer life, but they have a problem. They are responsible for causing fragmentation of RBCs. So they are responsible for causing the development of angiopathic hemolytic anemia. Non-metallic valves, the life is lesser, but the good point about non-metallic valves is they do not require anticoagulation and they do not cause damage to the RBCs per se. With regards to cardiomyopathy, the first cardiomyopathy that we talk about is dilated cardiomyopathy. Three important risk factors to be kept in mind. One is alcohol, holiday heart syndrome, binge drinking in the patients. Second can be a condition like pregnancy, peripartum cardiomyopathy. And third could be an example of a condition in which the patients are going to be having the development of severe anemia, or there is a presence of nutritional deficiency because of which the patients are going to be having thiamine deficiency or beriberi. Of course, cardiac involvement is seen. So that is what is going to be given the name of wet beriberi. If you relate it with pharmacology, you have multiple cardiotoxic drugs like doxorubicin, anthracycline drugs. We have drugs like pertuzumab, trastuzumab, which can be causing damage to the heart and that can be causing a trouble. Rare but genetic cause of this can be titin gene mutation because of TTN trouble. Dilated cardiomyopathy is an example of a systolic failure. The heart becomes dilated. It's a flabby chamber and it is not going to be able to, contract properly. That is what you need to remember over here. Of course, you all are going to be pretty much fascinated with that ninja star appearance with regards to the titin mutation. I mean, not has never been asked as a question, but in case you can remember, very good. Most importantly, from your exams perspective, I would be interested in knowing about something that is given the name of hypertrophic cardiomyopathy, in which the patients are going to be having a problem at the level of the beta myosin heavy chain. This is what is going to be responsible for causing a development of the banana-like ventricular cavity. The patients are going to be having the presence of echocardiography finding, that is asymmetrical ventricular septal hypertrophy. Patients are going to be having a dynamic outflow obstruction. So whenever the heart rate is going to increase, that is something which is going to be troublesome for this patient. Why will the heart rate increase? When this is a young athlete who is going to be playing on the field, so let him be playing a game like hockey or soccer, or he's running, he's a basketball player or he's an athlete just like that. The heart rate shoots up. Obstruction becomes more, the patient collapses suddenly and he dies. When he dies, this is a patient who's going to be having a family history. So multiple people in the family have had a history of dying prematurely. If I look at the cardiac biopsy, it is showing me the presence of cardiac fibers, which are going to be having a haphazard arrangement. And the haphazard arrangement of the cardiac fibers is what is going to be associated with the term helter-skelter arrangement, or it is also called as myocyte disarray. Myocyte disarray. Now, important thing for me to be understanding over here is that only when the heart rate of the patient is going to increase, he can die, and therefore I would like to control the heart rate of this patient. Therefore, one of the important drugs which is going to be, life-saving for this patient is going to be propranolol, which is an example of a non-selective beta blocker, right? That's it, which is to be remembered over here. So, multiple questions: banana-like ventricular cavity, the genes over here, the myocyte disarray, propranolol, echocardiography finding, all that features associated with HOCM. The other important example of a condition that is to be talked about over here is given the name of restrictive cardiomyopathy. Most common cause of restrictive cardiomyopathy is going to be amyloidosis, and the problem that is going to be seen in these patients is going to be the fact that there is a restriction to the filling of ventricular cavity, and therefore the heart cannot have an output properly. Whenever I'm going to be talking about the next important type, this could be again an example of a condition in which the patients are going to be having a development of extreme emotional stress. After extreme emotional stress, patients are going to be having what is given the name of the broken heart syndrome. Broken heart syndrome is what is going to be given the name of Takotsubo cardiomyopathy. So these patients are going to be having what is going to be given the name of the contraction band necrosis, extreme emotional stress, caught up in a lift. There is a presence of claustrophobia, any of those features mentioned, and that is what is going to be associated with Takotsubo cardiomyopathy. Apart from HOCM, which is going to be a very important cause of development of death, sudden cardiac death in case of a young athlete, another condition which can be causing death in case of young patients can be an example of a condition that is going to be given the name of ARVC, that is arrhythmogenic right ventricular cardiomyopathy. In this condition, the problem is the cardiac fibers are being replaced by fatty tissue in the patients. Therefore, the heart becomes weak. When the heart becomes weak, it is not able to contract properly, and therefore the patient dies. Right? That's what you need to remember over here. Finally, as and when we are making a mention of the cardiac tumors, the commonest cardiac tumors undoubtedly happens to be metastasis coming from the lung. Primary cardiac tumors can be seen in case of adults. In case of adult, the primary cardiac tumor happens to be a myxoma that is going to be associated with fever, malaise, and auscultatory finding called as tumor plop. This myxoma is going to be arising most of the times from the left atrium, and the site of origin of this myxoma is going to be near the fossa ovalis. However, if I'm going to be talking about the tumor that is going to be seen in case of children, in children, you're going to be having a tumor that is going to be given the name of a rhabdomyoma. Rhabdomyoma is an example of a tumor. You remember the rubbery story in the Spider-Man theory. So this is what is going to be associated with the presence of cells, which are going to be given the name of spider cells. That is what you need to keep in mind. Right? This tumor rhabdomyoma is going to be associated with the presence of a condition that is going to be given the name of tuberous sclerosis. That is what is to be remembered over here. And then when I talk about tuberous sclerosis, of course, what will be coming to your mind would be the skin question, shagreen patch. Remember the neurology question, high risk of development of epilepsy. Remember the kidney question, the patient is going to be having angiomyolipoma. And remember the cardiac question, the patient is having rhabdomyoma. So that is what is going to be seen in this patient, and therefore the patient can be having these multiple related conditions. So that will take care of a lot of these questions asked in the exam. Of course, if I'm going to be talking about an example of a simple question pertaining to the broad spectrum anti-epileptic drug, what is the drug that you would answer for me, guys? ब्रॉड स्पेक्ट्रम एंटी एपिलेप्टिक ड्रग्स के तीन एग्जाम्पल बता दीजिए, दो बता दीजिए, एक तो बोल दो भाई. ब्रॉड स्पेक्ट्रम एंटी एपिलेप्टिक ड्रग, एक ऐसी दवाई किसी भी टाइप के एपिलेप्सी में आप दे सकते हो, मरीज को कुछ तो दे दोगे. मतलब लगे तो सही कि लड़के हमारे पढ़े लिखे हैं, शाबाश, एक दवाई तो बता दी, चलो एक पे खुश हो जाते हो, है ना, वाइवा वाले काम करते हो. वैल्पोरेट. So valproate is sodium valproate is one important example of a drug which is going to be given as an example of a broad spectrum anti-epileptic drug. What is the drug that is to be given to a patient who's going to be suffering from absence seizures? Absence seizures. Drug that is going to be given for absence seizures. सब एज ग्रुप में सबको ही तो सक्सीमेट दे दोगे क्या भाई? सबको ही तो सक्सीमेट दे देंगे क्या? है ना? That is not to be given to patients who are having an age less than 3 years ना, because of high chances of development of liver toxicity. So that is what is going to be then substituted with the other important drug that is going to be something like valproate. है ना? That's important thing. Of course, then you want to be talking about example of drugs which are going to be working on the sodium channels. So that would be coming to your mind that you're going to be talking about drugs which are going to be drug like carbamazepine or phenytoin. Then you can be talking about an example of a drug that is going to be acting on the potassium channels, which is an anti-epileptic drug acting on the potassium channel, by the way. Anti-epileptic drug acting on the potassium channel. He is not asking you questions, na. He is not going to be giving you an option. The examiner is an examiner. He can make a question any which way. So that is a drug that is going to be given the name of retigabine. It's also called by the name of it, izogabine. इथोसक्सेमाइड नहीं भाई, कैल्शियम चैनल्स की बात हो रही है। कैल्शियम चैनल्स की बात, पोटेशियम चैनल्स की बात हो रही थी। कैल्शियम चैनल्स की बात होती है तो टी टाइप कैल्शियम चैनल्स में इथोसक्सेमाइड। वी आर टॉकिंग अबाउट इजोगाबीन और एटिगाबीन, दैट्स गोइंग टू बी एक्टिंग ऑन द पोटेशियम चैनल्स। गाबा वाले तो सारे बता ही दोगे ना यार, गाबा में तो प्रॉब्लम है ही नहीं, वो तो प्री गाबालिन, गाबा पेंटेन, टियागाबीन, बेंजोडाइजापीन, बारबिचुरेट्स, उसमें तो चैंपियन बन ही चुके हो ना। तभी तो सेरिबेलम में हो भाई। चलो, then we are talking about something called as the respiratory system. So we're going to be talking about example of obstructive, restrictive, neoplastic, and infectious disorders. So these are going to be an example of obstructive lung disorders. Of course, there is a fifth one that is a new entity given in medicine. Asthma, which is an example of a type 1 hypersensitivity reaction characterized by the presence of worsening of difficulty of breathing at night. And typically the patients are going to be having different types of allergens. It is house dust, or it is going to be the presence of exposure to pollen grains, which is going to be causing a trouble. With respect to the pharma question, you obviously need to remember about the concept of aspirin sensitivity that is going to be seen in the patient. Even though it is an example of a type 1 hypersensitivity reaction, eosinophilic infiltration is what is going to be seen in these patients. But these patients can be having an important histological finding that is given the name of airway remodeling. Of course, asthma is an example of a reversible airway inflammatory disorder. So patients can be given SABA, LABA, Ultra LABA. And I don't want to trouble you asking the name of the drugs because I presume you already have an idea about the same. Emphysema is an example of a condition in which acinus is a destruction over here. Acinus being destroyed, and therefore the patients are going to be having the name as pink puffers. Commonest type of emphysema that is seen clinically is central acinar emphysema. Smoking is the commonest cause. Upper lobes are what are being affected in the patient. Distal part of the acinus is spared. Proximal acinus is involved. And in this kind of a condition, of course, apart from smoking, the other important cause can be anthracosis. With regards to pan-acinar emphysema, your examiner's favorite these days, autosomal recessive condition. Chromosome 14 is what is going to be affected in these patients. Patients are having alpha-1 antitrypsin problem. The pizza story that we talked about, instead of papa, mummy, and there is involvement of the lower lobes of the lung. There's involvement of the base of the lung, and the patients are going to be having micronodular cirrhosis. The moment I'm thinking in terms of emphysema, my patient is going to be having dyspnea, dry cough. He's going to be having weight loss and pursed lip breathing. He's going to be having the presence of a barrel chest. Guidelines that are being followed over here for something like emphysema is going to be given the name of the gold guidelines, right? That's what you need to remember over here. Chronic bronchitis is an infectious condition in case of a smoker because of which lot of mucus production, high degree of development of chances of cyanosis, therefore the name is blue bloaters, and the patients are going to be having a development of secondary polycythemia. Of course, it is a productive cough for at least 3 months in 2 consecutive years. More mucus production means high thickness of the mucous gland layer that would be associated with the high development of Reed's index. Of course, the patients are going to be having a chronic bronchitis. Therefore, over a period of time, this is an example of a condition which may have a progression to malignancy. This condition is not associated with amyloidosis. For these kind of a condition, emphysema and chronic bronchitis, your patients are going to be requiring mucolytic therapy. That is, and along with that, you will be requiring antibiotic administration. Bronchiectasis is an example of a condition which can be seen in patients who are going to be having the presence of early morning lots and lots and lots of sputum coming out with change in the posture. There are usually common causes in our country, maybe something like a tubercular infection, maybe something like an extension of pneumonia, cancer, or foreign body. But for the MCQ exam, you need to remember about these conditions. Carter-Jenner syndrome, there is going to be a problem so far as a dynein arm of the cilia is concerned. Patients are going to be having bronchiectasis, they are going to be having sinusitis, and there is going to be presence of situs inversus. The second one I can talk about is cystic fibrosis, CFTR, chloride channel defect. There is a problem at the level of delta 508 in this patient. There is a trouble in the secretion of chloride channel as well as the sodium, there cause of which the patient is going to be a child. He is going to be having the presence of too much of a salt on his sweat. Therefore, the baby is given the name of a salty baby syndrome. This condition is also associated with high degree of infections caused by the bacteria. That's a microlink. Pseudomonas aeruginosa causes infections. Repeated infections causes permanent dilatation of the airways. And therefore, the patient is going to be having cough with foul smelling sputum, and there is going to be a presence of clubbing as well. In this condition, you're going to be having the presence of secondary amyloidosis in the patients as well. Once you wish to make a diagnosis, all that you rely upon is HRCT, which can show you the presence of tram track appearance or the presence of signet ring appearance in the patients. Give antibiotics, give mucolytics, give bronchodilators to these patients to improve their condition. Then we're talking about something that is going to be associated with the development of alveolar exudates, and that is what is going to be seen in a patient who's going to be suffering from typical pneumonia. Strep pneumoniae is one of the commonest causes of community-acquired pneumonia. Staph aureus is one of the common causes of hospital-acquired pneumonia. Ventilator-associated pneumonia is something that you would be associating again with Staph aureus as well as Pseudomonas. Burn injury again is going to be associated with Pseudomonas infection. The second type of pneumonia that we talk about over here is a patient who is going to be having atypical pneumonia. In this patient, there is what is also called as walking pneumonia. There is a fever, low-grade fever, myalgia, dry cough, and the patient is going to be having the infection caused by mycoplasma, chlamydia, pneumocystis cerevisiae, and the other organisms like, say, for example, Legionella causing a trouble over here. Bacteria, along with the property, along with the clinical presentation, very, very high stuff for the exam. Classical feature of typical pneumonia is presence of alveolar exudate. Classical feature of atypical pneumonia is going to be interstitial tissue inflammation. That is what you need to remember over here. Of course, once it is a question of fever, weight loss, night sweats, patient is having the presence of a caseous lymph node. Patient is going to be having a subpleural Gons focus, showing you the presence of cheese-like appearance of the necrotic material, and you are going to be having the presence of the acid-fast bacilli being shown in the sputum examination of this patient. I would be thinking absolutely confidently in terms of a bacteria that is going to be given the name of the tubercular bacteria. That is going to be something like Mycobacterium tuberculosis over here. Mycobacterium tuberculosis over here, right? So that is what we need to remember over here. So far as this particular question has to be understood. The next thing that we need to have an idea over here would be with regards to the development of a pneumoconical disorder. Of course, the commonest one is silicosis because of people working in the silica industry, glass factory, or there is going to be a patient who is going to be working in the construction site. Upper lobes are what are affected, and they would be having the presence of eggshell calcification. That's what they'll have to ask you as a question in the exam. So far as the people who are going to be working in a coal mine is concerned, they can be having anthracosis. That is going to be causing a black discoloration of the lung. It can be responsible for causing a development of initially zero symptoms. Over a period of time, patients can be having a development of progressive massive fibrosis. And if it is associated with rheumatoid arthritis, patients are going to be having Kaplan syndrome. That's a picture of a black lung, pretty much, which is likely to be seen in majority of the people who are going to be residing in the big cities with the bad air quality index. Then we talk about asbestosis, another favorite of your examiners because of exposure to asbestos. Any kind of a construction or a industry in which there is a use of an insulation material. So people who are going to be working in the waterproofing industry, let us say shipbuilding or fireproofing material, that is what is going to be using this. This can be responsible for causing the commonest problem. That is going to be the thickening of the pleura. It is going to be given the name of pleural plaque. Patients can then be having a development of interstitial fibrosis that can be in the form of a structure that is going to be given the name of asbestos body. Patients can also be having a high risk of development of cancers over here. Now that can be an example of a cancer that is going to be given the name of a bronchogenic carcinoma. That's the commonest cancer that is going to be seen in this patient. Or the patients would be having a specific cancer associated with asbestos that's going to be given the name of a mesothelioma. Right? What they asked you in the exam a couple of years back as a question, last exam as a question, this appearance of the ferruginous body is also going to be given the second important name of a shish kebab appearance. If you have to perform at the best of your ability, your basics have to be clear. That is what I've been talking about time and again. So asbestosis is going to be responsible for causing involvement of base of the lung, practically because of the fact it's an example of a heavy dust particle. That's what you need to keep in mind. Having said that, we just talk about the lung cancer associated with something like smoking. You're going to be associating it with the exposure to certain types of radioactive gases. The most common type of lung cancer that is going to be seen in the patient is going to be something that is going to be given the name of an adenocarcinoma. This is an example of a cancer which is going to be having the presence of a glandular pattern. There is a presence of migratory thrombophlebitis as well as clubbing in these patients. Some of these patients are going to be having a development of the paraneoplastic syndromes as well. And the examples of clubbing as well as the migratory thrombophlebitis is what they'll have to ask you in the exam. We do not expect that markers are going to be asked in your exam, but just for the sake of an understanding, if you can think in terms of a peripheral cancer, in case of a female non-smoker, and you associate it with something like the presence of thyroid transcription factor 1, napsin A, mucinex A, that is going to be adenocarcinoma. One of the commonest ones which is being asked in the exam is classically what is going to be given the name of a squamous cell cancer. This individual is going to be a male individual having a history of smoking multi-pack years. He is going to be having the presence of a cavity formation in the lungs. He is having the presence of a cancer which is a central cancer. And this cancer is going to be associated with the development of hypercalcemia because of the secretion of the PTH related peptide. This kind of a cancer on the microscope examination can be showing you the presence of a classical feature of the squamous cells. That means the presence of keratin. Keratin, that is what they expect you as a question in the exam. Of course, if I talk about the other markers, he can always give you a question on something called SP63, P40, CK56. That is what can be always given. But these are the basics that you need to have an idea. The good point about squamous cell carcinoma, prognosis happens to be really most of the times wonderful. When we are talking about, no cancer is good, as I always say, but out of the given cancers, this is a better one. Small cell cancer, very similar. It is a male, it's a smoker who's going to be having a cancer, but this is an example of a highly, highly aggressive cancer. It's an example of a cancer which is going to be having multiple properties. Neuroendocrine origin, having the presence of oat cell carcinoma as the second name. It's an example of a cancer, extremely chemosensitive, radiosensitive, but very, very poor prognosis because of high degree of metastasis to all organs. Particularly, brain is an organ which is going to be affected. Surgery is not possible in this kind of a cancer because of the high degree of hormone granules present over here. These patients are at high risk of suffering from manifestations like SIADH. These patients can also have a manifestation like Cushing syndrome developing in them, because of which the patients are going to be identified relatively easily. Now, if I'm going to be talking about the small cell cancer, I can be having special markers for identifying this cancer. And those classical markers can include markers like chromogranin, synaptophysin, and TTF can also be seen in these patients. However, if I'm talking about a cancer in which I find no glands, no keratin, no neuroendocrine markers, the only cancer I'm left out with over here is a large cell cancer. Large cell cancer patients are going to be patients who are going to be non-smokers having a peripheral cancer. They're also going to be having a presence of a very atypical, strange kind of a finding. Because of secretion of an estrogen-like substance, they're going to be having a development of gynecomastia, right? So we talk about the large things in these patients, and therefore that gives you a hint. Everything becomes large in these patients, bad. That's a cancer plus a gynecomastia. Of course, we understand that fact. Of course, one of the example of tumors that is going to be asked on the patient is going to be an example of a condition that is going to be given the name of pulmonary hematoma. Pulmonary hematoma is an example of a condition in which the patients are going to be having the popcorn calcification on the radiological examination, can be seen on the X-ray, can be seen on the CT as well. That's what we can talk about over here. So that's about the lung cancer. Of course, mesothelioma is the one that is going to be associated with something which is going to be seen in a patient having a history of asbestos exposure. That takes care of lungs. Starting and wrapping up the discussion of the kidneys, so we talk about something called as nephrotic syndrome. Nephritic syndrome, you're going to be having hypertension, hematuria, oliguria, and the patient is going to be having a development of what kind of a break? ब्रेक तो ले ही लिया ना, कितना ब्रेक लेंगे? हर घंटे में थोड़ी ना ब्रेक लेंगे, ऐसा नहीं होता है दोस्त. Right? So it is going to be a mental conditioning for you people as well. Now you're going to be having an exam, you're going to be having two sessions, 1 and 2. You cannot afford to have a break after 30 minutes or so, or after every 1 hour or so. Na? It is also kind of a conditioning that we have done earlier as well, which means what I want you to understand is exam is a stressful situation, and you have to ensure, you have to get conditioned to the fact that your brain is working at the maximum capacity, even though the conditions are not very conducive. लाइट नहीं आ रही हो, वहां पे पानी ना दे रहे हो वो लोग, तब भी आपका दिमाग फुल उसमें कंसंट्रेशन में काम करना चाहिए, ताकि आपका पूरा का पूरा सिस्टम जो है वो इस दिशा में काम करे कि आपके एग्जाम के अंदर 200 प्लस नंबर लेके आए, राइट? उसके रीजंस है कुछ, जिसको हम बाद में सब्सिक्वेंटली डिस्कस करेंगे. देन वी आर गोइंग टू बी टॉकिंग अबाउट नेफ्राइटिक सिंड्रोम, हाइपरटेंशन, हेमेचूरिया, एंड द पेशेंट्स आर गोइंग टू बी हैविंग द प्रेजेंस ऑफ oliguria, and these patients are going to be having proteinuria as well. So the commonest cause of nephritic syndrome or glomerulonephritis is in children is PSGN. That's what we understand. The child will be having a history of upper respiratory tract infection, and after about 2 weeks or so, the patient is going to be having a history of cola colored urine. Right? In these patients, there is going to be formation of immune complexes, because of which the patients are going to be having the presence of what is going to be given the name of the subepithelial immune complexes. And whenever I'm going to be talking about the subepithelial immune complexes, they are going to be having an appearance under immunofluorescence. They will be appearing as starry sky appearance. Under electron microscopy, they are going to be having the presence of subepithelial humps. Subepithelial humps. So child having a history of pharyngitis, खांसी जुकाम की history, उसके बाद उसको hematuria हो गया, cola colored urine, subepithelial humps, that is going to be associated with nephritic syndrome. PSG is a common cause. 95% of the children recover without any complication. 5% of them will progress to RPGN. When I'm talking about the commonest cause of nephritic syndrome in case of adults, big people's disease, Burgess disease, you would remember, it's the commonest cause of nephritic syndrome in adults. Patients again have a history of pharyngitis, cough, cold, but the hematuria in these patients or the symptoms in these patients develop within a short span of time, typically within 2 to 3 days. So when there is a 2 to 3 week gap in children, it is PSGN. When there's a 2 to 3 day gap in adults, it is a case of Burgess disease. The problem is, in case of upper respiratory tract infection, there is abnormal IgA in these patients, and these abnormal IgA antibodies are going to get deposited at the level of the mesangium in the patients, which is going to be causing the trouble in the patients per se. Right? That's what you need to remember over here. Now, when I'm talking about a condition in which the patient is having a pre-existing kidney disease and suddenly there is a renal failure or renal shutdown, this condition is going to be given the name of RPGN. RPGN means rapid development of renal failure within a span of few weeks to months. And this is a condition in which patients are going to be having crescent-like formation of structures in the kidney. Those crescents are going to be having a composition. They are going to be made up of parietal cells, fibrin, and WBCs. Classically, patients can be having either of the three existing clinical conditions, type 1 RPGN, type 2 RPGN, type 3 RPGN. Type 1 RPGN is those patients who are suffering from a condition in which anti-GBM antibodies are present. So that condition is going to be given the name of, that condition is what is going to be given the name of something like Good-Pasteur syndrome. Good-Pasteur syndrome is an example of a condition in which my patient is going to be having the presence of anti-GBM antibodies. They can be exhibiting the presence of something that is going to be given the name of linear immunofluorescence. The second one that we talk about is going to be a patient suffering from type 2 RPGN. These are the patients who are going to be having immune complexes. Say, for example, patients suffering from hinox-Schönlein purpura. Say, for example, patients who are going to be having a history of something like post-infectious glomerulonephritis. Right? So these patients are typically going to be having the presence of immune complexes. They are going to be having the presence of an irregular appearance on the immunofluorescence as well. Type 3 RPGN is an example of a condition. My patients are having the presence of ANCA. Now that's again revision we are doing in the day. The condition in which we are having the presence of PR3 ANCA, that condition is going to be given the name of GPA, vaginal granulomatosis. The condition in which I'm having the presence of MPU ANCA, that condition is going to be given the name of microscopic polyangiitis. So these are the common conditions which are commonly going to be asked in the exams. Usually, if I'm talking about now 1, 2, 3, which of them is going to be an example of a condition or RPGN in which the patients are going to be suffering from SLE? That's easy. Daniel, you answered your question yourself, my friend. Is patient having SLE having ANCA? No. So this is ruled out. Is patient having SLE having anti-GBM antibodies? The answer is no. But the patients having SLE are having the presence of immune complexes. Remember, it is a type 3 hypersensitivity reaction. So SLE is a cause of type 2 RPGN. That is what you need to remember over here. You answered your question yourself. Unfortunate or bad point about this condition, it's a condition in which the patients are progressing or deteriorating very, very fast. So the patients are going to be having a rapid renal shutdown. However, if I just talk about an example of a condition that is going to be given the name of Alport syndrome, that's a path ENT opthal question. Patients can be having all modes of inheritance, particularly X-linked dominant is what you need to remember over here. There can be an involvement of the kidney in these patients. There can be an involvement of the ears in these patients. There can be an involvement of the eyes in these patients. So far as the kidney involvement in these patients is concerned, patients are going to be having a development of glomerulonephritis. Ear involvement means sensory neural hearing loss in these patients. Of course, you are familiar with the sensory neural and the conductive hearing loss differentiation. You need to remember about the Weber's test, the Rennie's test, and the differentiation. You need to remember about the graphs that we talk about, the tympanogram. That's the AD, AS, and the other graphs. Of course, paper 2 question. Then we need to talk about the eye problem in the patient. These patients are going to be having corneal dystrophy. They are also going to be having lenticonus. This is an example of an anterior lenticonus seen in this patient. And that is what you need to remember. Now, if you have to poke a needle in the eye, ear, or in the kidney, it's easiest to poke the needle in the kidney. Therefore, electron microscopic biopsy of the kidney is what is going to be diagnostic in this condition. And that is what is going to be showing you the presence of an important feature. This important feature of the electron microscopic biopsy of the kidney tissue is what is going to be associated with the term basket weave appearance. Basket weave appearance. So kidney biopsy is what is going to be showing you the basket weave appearance, even though it is asked in the exam in general as an example of a question that is going to be asked in a PG exam. But you just need to remember it is electron microscopy which is doing the diagnosis over here, not the light microscopy, not the immunofluorescence microscopy, for the simple reason there are no antibodies involved. It is just an example of a problem at the level of collagen type 4. So it's a collagen type 4 problem which is going to be responsible for the basket weave appearance, right? That's what is to be remembered. And therefore, kidney transplant is what is to be done to save the life of this patient. This was about nephritic syndrome. Of course, I want you to remember and recall such patients are going to be having the presence of RBC cast in their urine. RBC cast can also be associated with the term as dysmorphic RBCs. That is what you need to keep in mind. The example of a cast which is going to be seen physiologically is an example of a hyaline cast, and that's an example of a cast that is going to be made up of the TAM horsewall protein. The condition where you have WBC cast is a condition of infection that is given the name of pyelonephritis. The condition where I'm having the presence of lipid cast is a feature of nephrotic syndrome. The condition in which I'm having the brown color, dirty looking cast is a feature of acute kidney injury. And the condition in which I'm having the presence of broad, waxy, pale looking cast, they are a feature of chronic kidney disease. So all those are absolutely easy questions. Please don't goof up on those questions in the exam. That's a humble request. This is a situation of a table suffering from a patient suffering from nephrotic syndrome. That's to be kept in mind. Nephrotic syndrome means my patient is going to be having the presence of massive proteinuria. This patient is going to be having the presence of hypoalbuminemia. These patients are going to be having a development of edema. And these patients are going to be having lipids increasing in their blood as well as appearing in their urine. So it is massive proteinuria, hypoalbuminemia, presence of edema, and the presence of hyperlipidemia plus lipiduria that is going to be seen in the patients. Now, when lipids appear in the urine, that is going to be in the form of lipid cast. That can also be given the second important name of oval fat bodies in the patients. Multiple reasons for having this condition. The commonest reason of this condition in children is minimal chain disease. Patients are diagnosed with the help of kidney biopsy. It's a path pediatrics question. You cannot use light microscopy for this diagnosis. You cannot use immunofluorescence for this diagnosis. The only technique useful for diagnosis over here is kidney examination of the patient using electron microscopy. And what is the electron microscopy going to show you? That shows you a feature over here which is mentioned beautifully. That is the effacement of the podocyte. Now, this condition, please remember, as a clinical paper 2 question, shows selective proteinuria. So these patients are going to be having a fantastic response to steroid administration. However, please also remember the fact any patient having nephrotic syndrome, lot of proteins go down. Watch this graph to understand what I'm talking about. Lot of proteins go down. Lot of proteins go down in these patients. But the protein which is going to be increasing in a patient suffering from nephrotic syndrome is alpha 2 protein. That is going to be given the name of fibrinogen. So alpha 2 proteins or fibrinogen is what is going to be increasing in these patients. The rest of the proteins are going to be going down in this patient who's going to be suffering from nephrotic syndrome. If I'm going to be talking about the commonest cause of nephrotic syndrome in case of elderly patients or patients suffering from colon cancer or patients having a history of painkiller intake, that is membranous glomerulopathy. Majority of these patients are having an autoimmune problem. That means they are going to be having the presence of an antibody that is given the name of PLAR antibody. Of course, for your exams perspective, colon cancer, history of drug intake, history of infections like hepatitis B or malaria, they all increase the risk of development of membranous glomerulopathy. Why? Because in all these conditions, ultimately what will happen is there is formation of immune complexes. And whenever there is formation of immune complexes, what will happen? The immune complexes are going to be present on subepithelial side. Now you can see the immune complexes with the help of special staining as well, but that special staining requires the use of silver stain. And this came as a standardly FMG question, but it was asked as a NEET PG question as well. This is what is going to be given the name of a spike and dome appearance. So silver staining of the kidney tissue showing you the presence of a spike and dome appearance is a feature of membranous glomerulopathy. We need to remember the fact clinically these patients are going to be having the presence of not only the loss of albumin but loss of other proteins as well. Why that is important is these patients are at high risk of development of thrombotic complications, including deep vein thrombosis. Right? So the example of a question that is being asked in the exam over here could be perhaps related with something like an image like this. If I can show you more images, I think none of these images is going to be asked in the exam except for the special staining of the silver, which you may be able to appreciate. I don't know how much is that clear to you, but then that is going to be having the presence of that bristle-like appearance over here. That is what is going to be seen in a patient who's going to be suffering from membranous glomerulopathy. Finally, if I'm going to be talking about the other causes, I just need to learn about one about MPGN. MPGN is going to be associated with, remember the buzzword over here, hepatitis C association. Remember the keyword over here, tram track appearance. That's the important thing that we just need to remember over here. The final one is overall the commonest cause of nephropathy in case of human beings happens to be diabetic nephropathy. Diabetic nephropathy means person is having diabetes which is uncontrolled. In kidney involvement, which is a microvascular complication of diabetes. I hope you understand the fact. Thickening of the glomerular base membrane is the first change, earliest change. It is the earliest change, it is the commonest change. The second change in the patient is going to be nodular glomerulosclerosis. It is also called by the name of Kimmel-Steen-Wilson lesion. This is a characteristic feature of diabetes mellitus, Kimmel-Steen-Wilson lesion. If a person is still having uncontrolled diabetes over the next 10, 15, 20 years, it's unfortunate to know that the patient is then going to be having a development of the third problem, which is going to be diffuse glomerulosclerosis. And finally, this patient is going to be having a development of chronic kidney disease. That means practically the patient is going to be having the presence of renal failure. So what I wanted to tell you over here is the number one cause of kidney failure in India, in Southeast Asia, across the world globally is uncontrolled diabetes, diabetic nephropathy. Please also understand the fact that in patients who are going to be having diabetic nephropathy, you can be having a situation that if you look at the cells in the proximal tubule, cells of the proximal tubule are going to be containing glycogen. When cells in the proximal tubule contain glycogen, that is what is going to be given the name of Armani-Epstein cells. So patients who are having uncontrolled diabetes, they are going to be having lots and lots of glucose coming in their urine. When glucose enters in their urine, the glucose gets converted into glycogen in the proximal tubular cells, and that is what is going to be given the name of Armani-Epstein cells. Of course, you are intelligent for me to answer, which is an example of a transporter that is going to be present over here, which is going to be responsible for reabsorption of glucose from the proximal tubular cells. That's given the name of a sodium glucose transporter. You have two types of sodium glucose transporters, SGLT1 and SGLT2. SGLT1 is present where? SGLT2 is what we are talking about in the kidney. Where do we have SGLT1? That is present in the intestine. That is known to you. And the drug acting over here is ORS. SGLT2 is present in the kidney. And the drug acting on SGLT2 happens to be a drug that is given the name of glyphosins. So you heard about a drug called as canagliflozins, empagliflozin, dapagliflozins. Flozins are example of drugs in because of which more glucose is appearing in the urine. So the dangerous side effect of these drugs is they enhance the risk of development of urinary tract infection. This urinary tract infection can become complicated in the patients and therefore they increase the risk of development of Fournier's gangrene. Perineal gangrene is going to be seen with these drugs. Now, because there is glucose coming out in the urine of this patient, so this glucose will attract a lot of water as well. So when there is water which is going to be taken over here, overall the patient is going to lose water. Overall, the patient is going to be having a weight loss. So this is an example of a drug which is going to be causing water loss as well as weight loss, and therefore beyond diabetes के अलावा these drugs are also going to be useful for treatment of which kind of a condition in the patient. They are also being used for the treatment of a patient suffering from congestive heart failure. So glyphosins are not only useful for diabetes mellitus, they are also useful for patients who are going to be suffering from congestive heart failure. That is what you need to remember. So that can be useful for answering a question in the exam. Which anti-diabetic drug is going to be acting in the kidney? The answer is going to be empagliflozin, canagliflozin, or a drug like dapagliflozin. Which anti-diabetic drug is going to be acting in the liver? Which anti-diabetic drug is going to be acting in the liver? And that's an easy question I'm asking you. You already made an example of a drug which is going to be acting in the pancreatic beta cells, that is going to sulfonylurea. Which one is acting in the liver? That is given the name of metformin, which is an example of a anti-diabetic drug which is known to be having an important property. It decreases macrovascular complications of diabetes. It decreases macrovascular complications of diabetes. Macrovascular complications of diabetes are decreased with the help of which drug? The answer is again what you need to remember over here, metformin. Which anti-diabetic drug is responsible for causing a side effect, megaloblastic anemia? Macrovascular complications are decreased by metformin. Which antidiabetic drug causes megaloblastic anemia? The answer is again metformin. Which is an example of an antidiabetic drug which is going to be not causing hypoglycemia? Not causing hypoglycemia. बहुत सारी दवाई हैं, but this is again another example of a drug that you need to remember. So metformin is, I hope you understand the fact, the first line drug for the treatment of a patient suffering from type 2 diabetes mellitus. First line drug for the treatment of a patient suffering from type 2 diabetes mellitus, which is an example of an insulin which can be given once every week, which is an example of an insulin which can be given once every week. So obviously it is going to be an example of a long-acting insulin, and that is an example of an insulin that is going to be Najina. भाई डिग्लूडेक डेटेमर ग्लार्जिन दिन में एक बार देनी पड़ती है, मैंने बोला वंस अ वीक, एक हफ्ते में एक बार देने वाली इंसुलिन है ना, एक हफ्ते में देने वाली एक इंसुलिन, उसका नाम होता है आइकोडेक। नई दवाई हो सकता है लगे, लेकिन आपको पता होनी चाहिए। हाँ, न्यू वाली, अगर ये वाली याद हो तो याद रहेगी, आइकोडेक। आइकोडेक इज वंस अ वीक, राइट। बाकी जो आप इंसुलिन के नाम पढ़ रहे थे, लेस्प्रोस्पाट, ग्लूलाइसिन, वो थी अल्ट्रा शॉर्ट एक्टिंग या फिर रैपिडली एक्टिंग। डायबिटिक कीटोएसिडोसिस में रेगुलर इंसुलिन, वंस अ डे वाली आपकी दवाइयां हैं इंसुलिन में, लिस्प ग्लार्जिन, यू आर गोइंग टू बी हैविंग डेटेमर एंड डिग्लूडेक। वंस अ वीक वाली दवाई का नाम है आइकोडेक, राइट। सो अदरवाइज इफ आई एम टॉकिंग अबाउट डायबिटिक नेफ्रोपैथी, अपार्ट फ्रॉम, मतलब पहली एडवाइस तो मरीज को दोगे ना कि इसको अपना डायबिटीज कंट्रोल करना है, लेकिन दूसरी दवाई जो हमने मिशन क्लास में भी डिस्कस करी थी, विच इज गोइंग टू डिक्रीज और इसको डेवलपमेंट ऑफ डायबिटिक नेफ्रोपैथी, इज विच कैटेगरी ऑफ ड्रग? दे आर गोइंग टू बी गिवन द नेम ऑफ ड्रग लाइक एआरबीज एंड एसी इनहिबिटर्स। एआरबीज एंड एसी इनहिबिटर्स, ठीक है। ड्रग्स रिकॉल हो जाते हैं मेरे भाई, ऐसा मत बोलिए। भाई 200 लाने हैं तुझे, फोटो भेजनी है तुझे पेरेंट्स के साथ, कैसे ऐसे बातें कर रहा है, याद नहीं हो रहे? हारने वाली बातें मत करो यार, निराशा की बातें मत करो, ऐसे दिल मत तोड़ो। अब ये तीसरा रिकैप चल रहा है भाई, मेन क्लास हुई, उसके बाद हमने एक लैब किया, और उसके बाद हम ये वाली क्लास कर रहे हैं, मतलब ऐसे मत करो, ये जस्टिफाइड नहीं होगा। हो जाएगा यार, हो जाएगा, हम हिम्मत करेंगे, हो जाएगा। देन वी आर टॉकिंग अबाउट एन एग्जांपल ऑफ अ कंडीशन in which my patients are going to be suffering from nephrolithiasis, or my patients are going to be having the presence of kidney stones. So different types of kidney stones are there. From the perspective of a path question, if I have to make it easy, which is an example of the kind of crystals that a patient is going to be having. So these are the first one are going to be given the name of envelope-shaped crystals. They are going to be seen in a patient suffering from calcium oxalate. So this is calcium oxalate dihydrate crystals. That is the most common type of crystals that can be seen because of the commonest type of stone in the patient. The reason for this calcium or the oxalate coming in the urine of this patient is the patients are going to be having the presence of idiopathic hypercalciuria. The other important reason for development special condition is patients having Crohn's disease. Calcium oxalate stones can be seen in patients suffering from Crohn's disease. They can be seen in patients because of some unknown reasons, and that is given the name of idiopathic hypercalciuria. The second one that I can talk about over here is a patient who is going to be suffering from too much of uric acid coming in the urine. So that is going to be responsible for the formation of uric acid crystals, urate crystals, right? This is an example of the only kidney stone which cannot be picked up with the help of X-ray KUB region. It is radiolucent. I hope you remember that. The third one that we talk about over here is the one that is going to be seen in case of children. C for children, cystine stone. C for children, cystine stone. C for remember, six-sided. C becomes six easily, six-sided or benzene-shaped crystals. They are very, very hard. Children can become stubborn at times. मतलब वो बचपन में आपने भी किया होगा ना कि लौट गए हमें तो पापा आइसक्रीम दिलाओ दिलाओ आज आज दोबारा लेके ही जाऊंगा समथिंग ऑफ दैट सॉर्ट extremely hard stone and therefore it is not going to be broken down easily with the help of lithotripsy. That's how we remember it over here. And of course, this is an example of a cystine stone. The next 10 one that we are talking about over there, हाँ कुट तो जाती थी यार वो तो नॉर्मल चीज़ थी उस टाइम को ट्रॉमा नाम की चीज़ नहीं होती थी मेंटल हेल्थ पता ही नहीं थी बच्चों की भी मेंटल हेल्थ होती है चौथी चीज इज व्हाट इज गोइंग टू बी रिमेंबर्ड ओवर हियर इज गोइंग टू बी गिवन द नेम ऑफ कॉफिन लिड क्रिस्टल्स एंड कॉफिन लिड क्रिस्टल्स इज व्हाट यू आर गोइंग टू बी एसोसिएटेड विद द प्रेजेंस ऑफ द ट्रिपल स्टोन इट इज आल्सो कॉल्ड बाय द नेम ऑफ कैल्शियम मैग्नीशियम अमोनियम calcium magnesium sorry not calcium magnesium ammonium phosphate calcium behaves just like magnesium over here so even this is something which can be picked up on the x-ray KUB. However, the property of the stone is this is an example of a stone that is going to be seen in the alkaline pH. So classical history, the guy is going to be having a history of a urinary tract infection caused by Proteus, right? So which one of them is going to be produced in the alkaline urine? That's the answer to the question. That's the fourth one. Which of them is an example of a radiolucent stone? This is the answer that I want you to be familiar with. Which is an example of a stone which is going to be produced in the acidic urine. So बाकी सारे acidic urine वाले हैं 1, 2, 3 वाले ये आपको चीज याद रखनी है. Which of them is going to be seen in case of children? That is what you need to remember over here. Which of them is going to be most commonly seen in case of an adult? The answer is calcium oxalate. That is what you need to remember. Depending upon struvite वाला ये 4 नंबर वाला ट्रिपल स्टोन मैग्नीशियम अमोनियम फॉस्फेट अल्कलाइन यूरिन वाला राइट इसमें कॉफिन लिड ट्रिपल स्टोन है ना ट्रिपल ट्रिपल सो ट्रिपल के साथ में आपको याद रखना है कॉफिन लिड क्रिस्टल्स ट्रिपल स्टोन ठीक है दिस इज एग्जांपल ऑफ अ स्लो ग्रोइंग स्टोन दिस इज व्हाट यू आर गोइंग टू बी एसोसिएटिंग विद द कॉफिन लिड क्रिस्टल्स right this is also having another important name because it grows slowly so it is going to be associated with the name staghorn calculus staghorn calculus Staghorn calculus, Proteus infection. Yes, that is what you need to remember. Of course, you will ask this patient to drink lots and lots of waters after their biochemical analysis as well. Depending upon the kind of stone, you can alkaline and acidify the urine. And therefore, of course, the primary treatment is going to be lithotripsy. But for preventing the chances of a recurrence of the stone, that is what you are going to be telling this patient. Please drink lots and lots of water. Try to avoid any kind of an infection. That's the simplest thing which is going to be done, right? Then we are making a mention of something that is going to be given the name of cancers, the commonest cancers, as we understand. In context of children with regards to tumors, is going to be given the name of Wilms tumor. What will come to my mind over here is going to be an example of a triphasic tumor. That's an example of a blastemal eminent epithelial element, and there is a stromal element that is present. Wilms tumor, WT1, WT2 gene, chromosomal 11p is what is affected. I'm having multiple types of syndromes over here, but Vagar syndrome is what I would like you to be familiar with over here. Wilms tumor, aniridia, gonadal anomalies, and mental retardation is going to be seen in these patients. In case you are able to recall more, of course, I will be more than happy to talk about the Danish-Drash syndrome. And the third one that we talk about over here is going to be the Beckwith-Wiedemann syndrome, right? Wilms tumor patients, they are going to be having the presence of an abdominal mass. Typically, the patients are going to be having a fever. Typically, the patients are going to be having a hematuria. So typically, when the mother is going to be giving a bath to the baby, that's the time when she notices the baby is having some abnormality. The baby is going to be having a lump. Because the mother notices the tumor, and mothers are half pediatricians, as we say. In fact, I mean, itna to hote hai unka knowledge ki something is wrong. They will take it to the doctor as early as possible, and therefore the tumor is in most of the cases detected early. Therefore, it is going to be having a relatively good prognosis. So far as the adults are concerned, multiple tumors which are asked in the exam. One tumor that we talked about over here is going to be given the name of angiomyolipoma. This is an example of a tumor that you see in a patient suffering from tuberous sclerosis. The other example of a tumor that we talk about is what is going to be given the name of renal cell carcinoma. Renal cell carcinoma is an example of a tumor which is going to be associated with smoking. It is also associated with the development of a syndrome that is a VHL syndrome. Can be associated with other risk factors like petroleum exposure, obesity, estrogen exposure, and another other genetic factors. The important example of the renal carcinoma that we talk about over here is the patients are going to be having painless hematuria. If you are going to be making a diagnosis of this cancer, you have to perform a CT scan to see the extent of the cancer. And then what you have to do for these patients is obviously a biopsy. In biopsy, you have to remember about certain special types. One is a clear cell cancer. This is having the tumor cells are having a clear appearance because lots of glycogen and lots of fats are there. And this is an example of a tumor which is going to be rising from cells of the proximal tubule associated with VHL syndrome. The second one is what you're associating with something that is given the name of papillary cancer of the kidney. This one is going to be having calcium deposition. When calcium deposition is going to be seen over here, it is going to be associated with the term Samoma bodies. That is what you need to remember. The third one that we talk about over here is the one in which you're going to be having the presence of plant cell-like appearance. There is a presence of perinuclear halo. There is a presence of raisin-like nucleus. And that is what is going to be having the presence of a chromophobe cancer. Chromophobe cancer is an example of a cancer which is going to be relatively slower growing, so it is going to be having the best prognosis. Last one is going to be the one in which you're going to be having the maximum chances of aggression. That is going to be an example of what is given the name of Bellini duct cancer. It's the most aggressive subtype of kidney cancer and is going to be having a sarcomatoid histology. It is going to be having the presence of the poorest prognosis. So depending upon what they are going to be giving you as a question in the exam, you'll be able to handle it correctly. Renal cell carcinoma is an example of a question that is going to be associated with the fact patients are going to be having lots and lots of paraneoplastic syndromes. So sometimes it is very difficult to diagnose this cancer in the initial stages. So that is why this cancer is going to be having multiple names. Internist tumor, hypernephroma, gravid cell tumor, all are names associated with renal cell carcinoma. Whenever you're going to be talking about renal cell carcinoma, one of the classical manifestations asked as a UPSC exam question, elderly male patient who is going to be having the presence of a left-sided varicocele because of metastasis coming from the renal vein. So that is what is going to be an indicator for a patient to be ruled out. I mean, you have to rule out the presence of a kidney cancer in the patients. That's what you need to talk about so far as a kidney cancer is concerned. Of course, there are newer drugs available over here for the treatment of this kind of a cancer, but that is going to be for the PG exam, not for the UR exam. Then making a mention of something that is going to be pertaining to the liver, we are going to be having different types of conditions. Unconjugated bilirubinemia is going to be seen as a feature of hemolytic anemia. We already had a discussion about all of them. Can you just quickly revise for me? What is the investigation of choice for making a diagnosis of PNH? Investigation of choice for making a diagnosis of PNH. I just wanted to answer that randomly. That is going to be something like flow cytometry. I believe that's an easy one for you. If I'm going to be talking about the investigation of choice for making a diagnosis of autoimmune hemolytic anemia, I'm suspecting my patient to be having an autoimmune hemolytic anemia. What kind of investigation would like to do in this session for doing? Yes. So I would like to go in for an investigation which is going to be given the name of Coombs test. Coombs test is an investigation that I would like to carry out. What investigation would you like to carry out in a patient suffering from thalassemia? Confirmatory investigation for thalassemia. That's going to be gene analysis. Gene analysis. How about G6PD deficiency? That's going to be G6PD assay with the help of the card test, gel test, or whatever way. Right? So that is what you need to remember. Then I'm talking about Gilbert syndrome. Gilbert syndrome is typically an adult patient who is going to be having unconjugated bilirubin. There are no clinical symptoms. Just tell this patient he is not supposed to worry because he will be developing jaundice only when he is not eating food, fasting, or he's going to be having some kind of a stress, maybe an infection or something. So that's a time when he's going to be having an issue. Crigler-Najjar syndrome is going to be an example of a condition in which the patients are going to be having a decrease in the activity of an enzyme, UGT enzyme. If the enzyme is just not there, patient cannot survive. If the enzyme is there, you have to boost the activity with the help of a drug that is going to be given the name of phenobarb. So Crigler-Najjar syndrome is a child who's going to be having a neonatal unconjugated hyperbilirubinemia, but the enzyme activity has to be boosted with the help of a drug like phenobarbital. Of course, with phenobarbital, you are already aware about the mechanism action. That can be a pharma question. Phenobarbital का mechanism action क्या होता है? It's an example of a mechanism. मैं क्लास नहीं पूछी, मैंने mechanism पूछा है. Phenobarbital is an example of a drug acting by which mechanism? GABA. Very good. आधा आंसर दिया आपने. GABA का क्या है ये? GABA मिमेटिक है, GABA फैसिलिटेटरी है. गाबा इनिबिशन शानदार. प्यारी बातें मत करो, ये बारबिचुरेट है. अब ये बारबिचुरेट है तो गाबा को क्या करेगी? ये गाबा को क्या करेगी मेरे भाई? गाबा के चैनल को ओपन कराएगी ना. ड्यूरेशन के लिए करेगी, फ्रीक्वेंसी के लिए करेगी. भाई बेंजोडाइजेपिन फिनोबार्बिटोन के अंदर बेसिक बारबिचुरेट के अंदर क्या डिफरेंस होता है? ड्यूरेशन के लिए करेगी ना, बताओगे? ठीक है, ये ड्यूरेशन के लिए करेगी। इट इज एन एग्जांपल ऑफ अ गाबा मेमेटिक और गाबा फैसिलिटेटर। डिफरेंट जगह पे काम करती है ना, गाबा मेमेटिक की तरह काम करती है ना, या गाबा फैसिलिटेटर की तरह काम करती है। आधे फैसिलिटेटर आधे मिमेटिक। अब ये भी मत बताना कि थेरेप्यूटिक इंडेक्स लो होता है, ये भी मत बताना इसके साथ में आपने रीडिस्ट्रीब्यूशन का फिनोमेना पढ़ा थायोपेंटोन के साथ में। फिर कहोगे सर 189 नंबर है, जब मैं कह रहा हूँ 200 प्लस लेके आने। वो टेबल पढ़ाई थी ना सर ने, फैसिलिटेटर और मिमेटिक की टेबल पढ़ाई। आपको पढ़ाया कि एक का ड्यूरेशन ऑफ एक्शन होता है, एक की फ्रीक्वेंसी होती है। आपको पढ़ाया था एक का लो थेरेप्यूटिक इंडेक्स है, एक का हाई है। आपको पढ़ाया एक के साथ रीडिस्ट्रीब्यूशन मिलता है, एक के साथ नहीं मिलता। एक पढ़ाया आपको एंटीडोट अवेलेबल है, एक का एंटीडोट नहीं है। वो टेबल किस दिन के लिए याद करोगे कम वक्तों, पढ़ लो उसे। बुरा मत मान जाना कभी दिल पे लेना कि अरे सर आपने हार्श लैंग्वेज यूज कर दी। भाई स्टिमुलेशन मिलनी चाहिए, पढ़ना चाहिए ना, ये तो आसान सवाल है यार, ये थोड़ा ना गलती करेंगे। ठीक है ना। तो स्कोप ऑफ इम्प्रूवमेंट है भाई, इसमें कोई दिक्कत नहीं है। लेकिन एग्जाम में गलती मत करना, तुम टाइम मत नष्ट कराओ मेरा, इस चक्कर में भी बुलवा दोगे। कॉन्जुगेटेड या डायरेक्ट हाइपरबिलिरुबिनीमिया कैन बी सीन बिकॉज ऑफ गॉल स्टोन्स और कोलेंजियोकार्सिनोमा और बिकॉज ऑफ लिवर फ्लू। एज एंड व्हेन आई एम मेकिंग अ मेंशन ऑफ कोलेंजियोकार्सिनोमा, व्हिच इज एन ऑर्गेनिज्म व्हिच कम्स टू माय माइंड, which organism comes to my mind when I'm talking about something called as cholangiocarcinoma? The organism which is going to be coming to my mind over here is going to be liver fluke. The liver fluke is given the name of Clonorchis sinensis. Clonorchis sinensis, इसी का दूसरा नाम होता है ओपिस्थोरकिस sinensis। एग्जाम में कंफ्यूज मत करना। टू सिंड्रोम्स which are going to be asked in the exam, डुबिन जॉनसन, इसमें डी और जे है। डार्क कलर का लिवर होता है, पिगमेंटेड लिवर, एंड द पेशेंट इज गोइंग टू बी हैविंग द प्रेजेंस ऑफ जॉन्डिस। The moment I'm going to be talking about rotor syndrome, patients are going to be having liver which is going to be having a normal pigmentation, but they are going to be having the presence of a dark, or I would rather say is direct conjugated bilirubinemia. Direct bilirubin is going to be increased in this patient. Direct bilirubin is going to be increased in this patient. Right? Liver is going to be normal, but there is going to be presence of direct hyperbilirubinemia. So for your practice, I just want you to remember about the common causes as this. For your MCQ, I want to remember about the syndromes. Then we are talking about an example of a condition, biliary tract disorders, which is known to you. That's a standard question. Antimitochondrial antibody in case of a middle to elderly aged female. She is going to be having the presence of intrahepatic, extrahepatic duct issue. That is what is going to be seen in case of primarily intrahepatic duct, that she is going to be suffering from primary biliary cholangitis. This is an example of Amma is beautiful. Undoubtedly, कोई doubt ही नहीं है। आइए थोड़े से दिन और पढ़ाई करते हैं मम्मी के लिए। सो दैट इज गोइंग टू बी शॉगरन सिंड्रोम व्हिच इज गोइंग टू बी एसोसिएटेड ओवर हियर, एंड दिस इज गोइंग टू बी एन एग्जांपल ऑफ अ कंडीशन व्हिच इज गोइंग टू बी शोइंग मी द प्रेजेंस ऑफ फ्लोrid duct lesion. Granulomatous inflammation showing a massive damage, florid duct lesion. Right, whenever I'm going to be talking about primary sclerosing cholangitis is an example of an autoimmune condition. It is going to be seen in case of a male individual. This male is going to be having an age of around 30 years or so. उसके बाद तो मेल की कहानी आपको पता ही है, intrahepatic extrahepatic duct. It is going to be having an ulceration with ulcerative colitis. So this male is going to be in love with somebody who's going to be associated with an antibody. That antibody is going to be given the name of Priyanka. Right, and therefore this male is going to be having the presence of periductal fibrosis, which is going to be having an appearance that is going to be given the name of onion skin appearance. Onion skin fibrosis of the periduct. Onion skin fibrosis of the bile duct is a feature of primary sclerosing cholangitis. So I hope none of you is going to be making a mistake with respect to either the age, with respect to the gender, with respect to the microscopic finding, with regards to the antibody that is going to be seen in these two different conditions. Why both of them are important? Ultimately, whether your patient is having this type or the other type of biliary tract disorders, these definitely are associated with a higher risk of development of the cancer in the patient. Then having a quick recap about these conditions, 90% of which you are already aware: alpha-1 antitrypsin deficiency, autosomal recessive condition. Patients are going to be having chromosome 14 involvement, PIMM to PIMZ. There is a presence of lung involvement in the form of pan-acinar emphysema, and there is an involvement of micronodular cirrhosis so far as the liver of this patient is concerned, having the presence of a non-specific finding called as Mallory-Denk body, which is going to be made up of cytokeratin. Mallory-Denk body that is going to be made up of cytokeratin. That is what you need to remember. 8 and 18 is the composition that is seen. Just keep that image in your mind. Presence of PAS positive magenta colored granules. PAS positive magenta colored granules in a patient who's going to be having emphysema and liver cirrhosis is a feature of alpha-1 antitrypsin deficiency. You and me cannot do anything about alpha-1 antitrypsin deficiency, so we just do symptomatic treatment of the patient. Second condition can be hemochromatosis, iron overload condition, seen in case of males who are going to be having a problem at the level of a gene that is given the name of HFE gene, and therefore there is a problem at the level of chromosome 6p. There is a problem at the level of the liver, so the patients are going to be having a level development of liver cirrhosis. Liver cirrhosis is what is going to be seen in the patients, plus the patients are going to be having a high risk of iron-mediated damage to the pancreatic beta cells, that means diabetes mellitus, and the patients are going to be having the high pigmentation or the abnormal pigmentation on the skin. So all of you are aware at this point of time, it's a condition that is given the name of bronze diabetes. You associate in the males development of testicular atrophy over here. There is a development of pseudo-gout in these patients. Because of iron getting deposited and damage to the heart, there is a development of restrictive cardiomyopathy. More iron means more hemosiderin. More hemosiderin means more this kind of a blue color, which can be picked up on the liver biopsy with the help of a reaction that is given the name of Pearl's reaction, also associated with the term the Prussian blue stain. That's useful for confirmation. What will I do for the treatment of this patient? For the medical treatment, I can give him drugs which are going to chelate iron. And for the definitive treatment, I will do something other for this patient. What is a drug which can be given to this patient? Can I just know that? आयरन चिलेटेड ड्रग का नाम बता दीजिए. डेस्पेरियोक्सामाइन, डेफराजिरोक्स दे दोगे आप इस मरीज को. ठीक है. Which is an example of an iron chelator that is going to be given for toxicity caused by doxorubicin. Which drug is going to be given for decreasing the toxicity caused by doxorubicin? यहाँ पे फंस जाते हैं हम सारे. ये पढ़ाई भी थी मैंने आपको, फिर गलती कर देते हो. डेफरीपरॉन नहीं दे रही, डेक्सराजोक्सेन पढ़ाई थी ना, डेक्सराजोक्सेन. ना ना ना. नो रिलैक्सेशन, नो रिलैक्सेशन. दिस इज एग्जाम भाई, एग्जाम इज वॉर में नो रिलैक्सेशन. Wilson's disease. Wilson's disease is going to be an example of a condition which is going to be seen because of ATP7B problem. ATP7B problem means it is an autosomal recessive problem. Patients will be having liver, brain and eye problem. Liver में problem आ रही है because of cirrhosis. Brain की problem है Parkinsonism. Eye problem is eye findings. Eye finding is what is given in the exam. Sunflower cataract and there is a presence of Kayser-Fleischer ring. Kayser-Fleischer ring. Kayser-Fleischer ring is deposition of copper in the Descemet's membrane. Paper 2 question. Kayser-Fleischer ring does not interfere with the vision of the patient. Second question. Third thing that we need to remember here is patients can be having the development of a sunflower cataract. And then these patients can be having a development of a hemolytic anemia. Obviously, with regards to something like Parkinsonism, I can give my patients multiple drugs for Parkinsonism. But suppose my patient is being given a drug like levodopa, carbidopa for the treatment of Parkinsonism. One of the commonest side effects of this drug is they can cause nausea and vomiting, which is an example of a drug which can be responsible for treating this nausea and vomiting. Which drug can be given for treatment of nausea and vomiting caused because of levodopa, carbidopa? ऑनडेनसेट्रॉन दे दो तुम. घर पे आके मारूंगा अब्दुल, ये पढ़ाया था मैंने तुझे. भाई क्यों हो रही है नोजिया वोमिटिंग? नोजिया वोमिटिंग इज टेकिंग प्लेस बिकॉज ऑफ डोपामीन एक्टिंग ऑन द रिसेप्टर ना. सो वी हैव टू ब्लॉक दिस रिसेप्टर. व्हेन वी हैव टू ब्लॉक द रिसेप्टर तो हम कौन सी दवाई देंगे? व्हेन वी हैव टू ब्लॉक द रिसेप्टर तो हम कौन सी दवाई देते हैं? डोमपेरिडोन देंगे, मेटाक्लोप्रोमाइड देंगे? हे भगवान, एंटाकोपॉन दे रहा है एगोन. तो एगोन क्या हो गया भाई? भाई डोपामीन एगोनिस्ट एंटागनिस्ट देनी है ना हमें, तो मेटाक्लोप्रोमाइड देंगे या डोमपेरिडोन देंगे? मैं तो इतनी सी बात कर रहा हूँ. डोमपेरिडोन देंगे यार. मेटाक्लोप्रोमाइड को दे रहे हो, मेटाक्लोप्रोमाइड तो क्रॉस करती है ना ब्लड ब्रेन बैरियर. मैं हूँ डोम, भूल गए तुम सारी बातें. मैं हूँ डोम. नोजिया वोमिटिंग के लिए मैं हूँ ना, नोजिया वोमिटिंग के लिए दवाई दे रहे हैं ना डोमपेरिडोन. मेटाक्लोप्रामाइड तो क्रॉस कर जाती है ना ब्लड ब्रेन बैरियर. अब कह रहे हो हाँ याद आ गया. भाई फोटो ले जाना मेरी घूरते हुए स्केयरिंग एकदम ऐसे लिड को ऊपर उठा के. वो जो वॉर ग्राफी और डेलरिम्पल साइन पढ़ाते हैं ना सर, वैसे वाली फोटो ले जाना. ठीक है. डोमपेरिडोन देनी है मरीज को यार. ऑन्डेनसेट्रॉन तो हम कीमोथेरेपी वाली वोमिटिंग के अंदर देंगे ना. फिर ऐसी बातें क्यों कर देते हो? तीसरी बार पढ़ाने के बाद भी कन्फर्मेशन में हम करते हैं पेशेंट्स के अंदर लिवर बायोप्सी ली, उसके अंदर हमने कॉपर देख लिया. फॉर एक सीइंग कॉपर, व्हाट इज द स्पेशल स्टेन दैट इज गोइंग टू बी यूज्ड? दैट इज रोडानिन स्टेन. अब यहाँ पे छोटी सी कहानी है. रोडानिन और रोडामीन को कंफ्यूज नहीं करना. एम मतलब माइकोबैक्टीरिया, माइकोबैक्टीरिया मतलब टीबी. बेल ट्रीटमेंट देनी है भाई. फोटोग्राफ चाहिए भाई, फोटोग्राफ चाहिए. पापा मम्मी के साथ फोटोग्राफ चाहिए, समझो बात. वो है लाइफ का अंदर स्टिमुलेंट. ठीक है ना, उसके लिए जान लगानी है. रोडानिन के अंदर हमें देखना है कि रेडिश कलर आएगा, रेडिश ब्राउन कलर. रोडानिन रेडिश कलर, रोडानिन रेडिश ब्राउन कलर आएगा. दैट इज बिकॉज ऑफ विल्सन्स. ये चीज़ आ गई हमें याद. वेन एवर वी गोइंग टू बी टॉकिंग अबाउट विल्सन्स डिजीज, विल्सन्स डिजीज के अंदर आपने दवाई देनी है मरीज को, उसका नाम होता है जिंक थेरेपी. और अगर न्यूरोलॉजिकल मैनिफेस्टेशन आती है तो हम उसको दवाई देते हैं, उसका नाम होता है ट्राइंटीन. ठीक है. फिर आ गई हमारी लिवर ट्यूमर की कहानी. इसमें ट्यूमर आ गया हमारा कैवर्नस हेमेंजियोमा, विच इज एन एग्जांपल ऑफ अ मोस्ट कॉमन hepatic tumor that can be seen in the patient because it is a vascular tumor. So biopsy is to be done cautiously or it is to be avoided. सेकेंड वाला हमारा ये आ गया. यहाँ पे हमारी पैथ फार्मा पीएसएम एक साथ आ जाती है बिकॉज दिस इज एन एग्जांपल ऑफ अ ट्यूमर that can be seen in a patient who's going to be having a history of steroid intake. So females who are going to be taking these kind of steroids can be oral contraceptive consumers, right? So she is going to be young female having oral contraceptive consumers. Young लड़कों का तो आपको पता ही है, जिम जाते हैं, बॉडी बनाते हैं. So that is going to be anabolic steroids that is going to be consumed. The third one that we are talking about is a neat question, but then they talk about the presence of a stellate scar. अब क्वेश्चन आपने रिवाइज कर लेना है, मैंने इतनी बार पढ़ाया. स्टेलेट ग्रैनुलोमा इज अ फीचर ऑफ stellate granuloma is a feature of Bartonella hensea infection na cat scratch disease. Stellate scar in the liver is a feature of FNH, focal nodular hyperplasia. Stellate scar is going to be a feature of focal nodular hyperplasia in the liver. That is what you need to talk about. So ये एग्जाम के क्वेश्चन तीनों ठीक कर देंगे आप, उसके बाद आप कॉन्फिडेंस के साथ बढ़ जाएंगे. एग्जाम के बाकी सवाल, एक क्वेश्चन रह गया इसमें, एक क्वेश्चन रह गया इसके अंदर, विच इज गोइंग टू बी अ क्वेश्चन अबाउट हेपाटोसेलुलर कार्सिनोमा. हेपाटोसेलुलर कार्सिनोमा के लिए आप यू नीड टू रिमेंबर द पेशेंट्स आर गोइंग टू बी हैविंग एन इन्फेक्शन कॉज्ड बाय chronic hepatitis B. A second important risk factor for this patient can be aflatoxin because of aspergillus, and the patient can be having a history of chronic alcohol intake or liver cirrhosis as well. In hepatocellular carcinoma, it is going to be an elderly male patient who's going to be having classically this kind of a cancer. It's an aggressive cancer, but is going to be having a poor prognosis. However, there is a variant of hepatocellular carcinoma that is going to be seen in case of a younger patient. And that variant is going to be given the name of fibrolamellar variant. So whenever I'm going to be talking about the fibrolamellar variant, no association with hepatitis B and C, no association with aflatoxin, no association with alcohol. Right? The important thing is this is an example of a cancer which is going to be having relatively better prognosis. Relatively better prognosis. Aflatoxin कौन से फूड मटेरियल के अंदर प्रेजेंट होता है? इन्फेक्टेड पीनट्स, which is an example of a fungus causing a trouble in these patients, that is going to be Aspergillus flavus. Whereas if I'm talking about fungal infection in the ear, that is Aspergillus niger. जो ब्लैक कलर की फंगस होती है, जो एस्पेरजिलस नाइजर, जो ओटोमाइकोसिस करा देती है. और जब उसको ओटोमाइकोसिस हो जाता है तो उसके अंदर हम क्या कराते हैं, कौन सी दवाई से इलाज करते हैं? जिसको ओटोमाइकोसिस हो जाता है, जिसको फंगल इन्फेक्शन हो जाती है, उसका इलाज कैसे करते हो? पेपर 2 का भाई माइटोमाइसिन दे. भाई निस्टैटिन दे दो ना, माइटोमाइसिन काहे दे रहे हो? मेट्रोजिल दे दोगे यार फंगल इन्फेक्शन में, प्यारी बातें कर रहे हो ना यार. निस्टैटिन दे दो ना यार, ईयर ड्रॉप्स दोगे ना उसको, फंगल इन्फेक्शन के लिए दोगे ना दवाई, टॉपिकली दोगे, या क्लोट्राइमेजोल दे दो, कुछ तो दोगे ना जो एंटी फंगल होगी. मतलब मेट्रोनिडाजोल दे रहे हो और माइटोमाइसिन दे रहे हो. माइटोमाइसिन तो कंफ्यूज कर लिया आपने, वो तो एंटी कैंसर दवाई थी ना. माइटोमाइसिन तो आप आंख के अंदर देते थे ना, टेरिजियम वाले मरीज के अंदर भी. क्लोट्राइमेजोल दोगे ना, क्लोट्रामेजोल अजोल ड्रग है ना, 14 अल्फा डी मिथाइलेज याद आ गई. स्टैटिक दवाई है ना, साइडल तो नहीं है. परेशान करते हो यार, नोटी होकर. Endocrinology. Endocrinology में commonest cause of hyperthyroidism is a patient who's going to be suffering from Graves' disease. This is what is going to be associated with a patient who's going to be having the development of features of hyperthyroidism, which may or may not be seen without ocular involvement or the presence of the skin involvement. So skin involvement can be in the form of peritibial myxedema, and there is can be ocular involvement. Patients are going to be having the presence of TSIG, thyroid stimulatory antibody. And of course, these patients are going to be having the presence of the follicular cell hyperplasia, which is going to be seen in them. That is what is going to be associated with the presence of scalloping of colloid. The opposite of this is happening to be Hashimoto's thyroiditis. Hashimoto's thyroiditis is an example of the commonest cause of hypothyroidism, particularly in iodine sufficient areas. HLA DR3, DR5 is what is going to be associated. Cells start attacking the thyroid gland. So cells are being attacked by the body's own immune cells. That is why the thyroid cells feel hurt. That is why there is going to be presence of Hurley cells. So lymphocytic cells are going to infiltrate. They are going to be resulting in the formation of a follicle-like structures, and our thyroid cells feel hurt. So there is Hurley cells. Now, what is going to be seen in this kind of a condition is that in this condition, there is going to be a feature of a patient. Again, the patient is going to be an example of an elderly female. Most of the times, it is an example of an elderly female. And she is going to be having the features of hypothyroidism, which can be including something like menstrual disturbance. It can be including weight gain. It can be alopecia. It can be a change in the voice, right? All those manifestations are going to be seen in the patient. Whenever I'm going to be talking about decurvance thyroiditis, decurvane causes a lot of pain. So my patient is having a history of viral infection, or the patient is having a history of upper respiratory tract infection, and then my patient is going to be having a development of painful thyroid. Commonest cause of painful thyroid is decurvance thyroiditis. Decurvane causes a lot of pain. After almost a viral infection, patient is going to be having a painful thyroid. The good point about this condition is increased ESR is going to be seen during the acute phase, but because viral inflammations are self-limiting in nature, so after a point of time, the patients are going to get better on their own. Patients are going to get better on their own. So any question which is making a mention of these two features, ये दोनों एग्जाम में थ्योरी के क्वेश्चन में भी आते हैं. Lymphoid follicle like appearance of thyroid with Hurley cells. This is a feature of Hashimoto's. This is a feature of Hashimoto's thyroiditis. Follicles तो आपको नॉर्मली lymph node के अंदर देखने को मिलते हैं, बट यहाँ पे आपको थायराइड के अंदर देखने को मिले along with Hurley cells, that is a feature of Hashimoto's. The moment I'm thinking in terms of this kind of an appearance where I'm having the presence of the whitish appearance in case of the thyroid, Whitish appearance in case of thyroid. That is what is going to be seen as a feature of the scalloping of colloid. Scalloping of colloid. This is what is going to be seen in a patient who's going to be suffering from a condition that is going to be given the name of Graves' disease. That is what is seen in a patient suffering from Graves' disease. That is what you need to keep in mind. I hope you are clear with this. Right? Then we are making a mention of thyroid cancers. Of course, the most common type of thyroid cancer, which is the flavor of the season for your exam, happens to be any day papillary thyroid cancer, associated with BRAF gene mutation, associated with the presence of this characteristic appearance, lymphatic spread, young female patient, history of radiation exposure, lymphatic spread, or cervical lymphadenopathy, having the presence of orphan NEI nuclei. Having the presence of orphan NEI nuclei. What she's also going to be having is, because of the deposition of calcium over here, she could be having the presence of what is going to be given the name of Semoma bodies. She could be having the presence of Semoma bodies over here. The good point about this kind of a thyroid cancer, it is very common. It is going to be associated with good prognosis. It's a most common type of thyroid cancer, and it is also associated with good prognosis. I hope you're clear with this. Then we are talking about an example of a thyroid cancer in which there is a deposition of extracellular pink color material, which on specialized staining as well as on polarized microscopy can show me presence of apple green birefringence. So this is going to be a case of medullary thyroid cancer. Medullary thyroid cancer. Now, whenever I'm talking about medullary thyroid cancer, 80% of it is sporadic, 20% of this is going to be because of familial. The gene is in common in both of them. That is given the name of Rett gene. The moment I'm thinking in terms of Rett gene in case of medullary thyroid cancer, what is coming to my mind over here is going to be the presence of a condition that is going to be given the name of Menn syndrome. So I talk about the three types of Menn syndromes that I normally make a mention of 1, 2, and 3. In both these two conditions, 2 and 3, you are going to be having the involvement of the Rett gene. Right? In the first one, you're going to be having the involvement of a gene that is given the name of menin gene. So first one is going to be associated with pre-piece, pituitary parathyroid pancreas, pituitary parathyroid pancreas. Right? PPP, that is what is known to majority of us. Pituitary parathyroid pancreas. Prolactinoma can be seen in these patients. Gastrinomas can be seen in these patients. Zollinger-Ellison syndrome. Parathyroid tumors can be seen in these patients. Wermer syndrome. MEN2 and MEN3, they will be having the presence of medullary thyroid cancer. They are also going to be having the presence of pheochromocytoma. What is going to be seen in case of MEN2? Apart from these two, there are patients are going to be having the presence of parathyroid hyperplasia. Patients are having the presence of parathyroid hyperplasia. Right? When I'm talking about MEN3, apart from these two, patients are going to be having the presence of mucosal neuromas. Patients are going to be having the presence of mucosal neuromas. These patients are tall patients, so they are going to be having the presence of marfanoid habitus. Marfanoid habitus. And the patients can be having the presence of what is going to be given the name of a megacolon. Mucosal neuromas, marfanoid habitus, and the patients can be having the presence of megacolon. So that is what is to be remembered so far as the MEN 1, MEN 2, MEN 3 is concerned. For your exam, 1, 2, 3 is sufficient. Which particular type of thyroid cancer cannot be diagnosed with the help of FNAC? The answer is already known to you. That is follicular cancer. For follicular cancer, we require a biopsy, and that biopsy has to show us presence of capsular invasion. Blood vessels are infected in a patient in the capsule. That is what is going to be given the name of capsular invasion. ठीक है, that is what you need to remember. हाँ जी, इंसुलिनोमा गैस्ट्रिनोमा वाली कहानी. इंसुलिनोमा के साथ में वही आपका ट्रायड आया था, फिर विपल्स वाला हाइपोग्लाइसीमिया, सिम्टम्स एम्लियोरेट हो जाते हैं पेशेंट्स के. राइट, दैट इज व्हाट इज टू बी रिमेंबर्ड. ठीक, सो दिस इज ओनली पिक्चर आई वांट टू रिमेंबर, ऑर्फन एनिया न्यूक्लियर, अकेली पिक्चर. ये वाली सिर्फ समझाने के लिए थी, ये वाली दिखाने के लिए, दिखाने और याद करने के लिए. Then I'm going to be talking about a patient who's going to be suffering from this condition. This is uncontrolled diabetes with nodule formation over here. That is going to be given the name of, that is what is going to be associated with the presence of nodular glomulosclerosis, also given the name of Kimmel-Stein-Wilson lesion. Kimmel-Stein-Wilson lesion. Then I'm talking about a patient who's going to be having some kind of a CNS issue. With respect to CNS issue, these are the common questions asked in the exam. So if I'm making a mention of Alzheimer's disease, it is the commonest cause of memory loss characterized by cortical atrophy. So this is associated with the most important risk factor, that is age, senile dementia. What is affected in these patients is classically there is initial involvement of the temporal lobe. Later, the other lobes are affected, but usually in most of the patients, occipital lobe is not affected. ऑक्सीपिटल लोब जब आप लिखते हो, ऑक्सीपिटल को जीरो लिखते हो ना, तो इसका जीरो इन्वॉल्वमेंट होता है, मिनिमली अफेक्टेड है, लास्ट अफेक्टेड, लीस्ट अफेक्टेड, स्पेयर्ड है. Specific part of the brain which is going to be affected in these patients is going to be nucleus of Meyer net. there is a decrease in the concentration of acetylcholine, right? There is an increased risk for development of age in these patients. The second syndrome that is going to be causing a high risk is Down syndrome. So what you need to remember over here is APO4 lipoprotein increases the risk of Alzheimer's. APO2 lipoprotein decreases the risk of Alzheimer's. That's what you need to talk about over here. As you already made a mention of the fact, the patients are going to be having the presence of the important feature deposition of amyloid beta plaque. Amyloid beta plaques are going to be deposited extracellularly. Amyloid beta plaques are going to be deposited extracellularly. Patients can also be having the presence of एनएफटी. एनएफटी का यहाँ पे मतलब एनएफटी तो दूसरी चीज होती है वैसे, बट यहाँ पे हमारे डॉक्टरों की भाषा के अंदर एनएफटी का मतलब होता है न्यूरोफिब्रिलेट एंगल्स. न्यूरोफिब्रिलेट एंगल्स आर गोइंग टू बी एग्जांपल ऑफ proteins which are going to be made up of tau proteins. Tau proteins. ठीक. And we are using silver stains to see for the presence of these kind of beta plaques. That is what you need to remember. Then an old question, a reddish color inclusion can be seen in the patients that is going to be given the name of Hirano body. Reddish color inclusions that are going to be given the name of Hirano bodies. ठीक है, that is important. बाकी डोनेपेजिल, रिज्वास्टिमीन, टैक्रीन, गैलेंटामीन, मिमेंटीन, इनकी कहानी आपको पता ही है. Talking about the next condition that is given the name of FTD, frontotemporal dementia, also called by the name of Pick's disease. You pick up this disease for the simple reason it is an example of a condition characterized by hexanucleotide repeats. Hexanucleotide repeats. Trinucleotide repeats is what I associate with Friedreich's ataxia, which I associate with something like Fragile X syndrome, or what I associate with myotonic dystrophy. 6 type nucleotide repeats. Hexanucleotide repeats is a feature of FTD. Now, in these patients, what you need to remember is FTD. So, frontal lobe is going to be affected first. Dementia or D is coming late. Frontal lobe is affected first. That means personality changes. Dementia is a late feature. Dementia is late. So, time में dementia late हो रहा है. What is going to be seen in these patients is presence of the special appearance with respect to the gross appearance of the brain that is going to be given the name of knife edge. Knife edge. यहाँ पे लिखा हुआ है ना? Paper thin. Knife like gyre. Knife like gyre. That's what is going to be seen. फ्रजाइल में सीजीजी है. फ्रजाइल में सीजीजी. सीएजी हंटिंगटन्स के अंदर था. ब्रेक ही ब्रेक है यार. कितने रह गए स्लाइड? चलो देख लेते हैं ब्रेक. यार 49 स्लाइड पे चल रहे हैं यार. 3 स्लाइड रह गई. काहे की ब्रेक है? कैसे पता करो? तो ब्रेक देने का मन ही नहीं है. एक ही बारी में सो जाना. पार्किंसोनिज्म दूसरा नेम होता है इसका पैरालिसिस एजिटेंस. दैट इज गोइंग टू बी एसोसिएटेड विद इन्वॉल्वमेंट ऑफ सब्सटेंशिया नाइग्रा. डोपामिन इज लेस एंड इंक्रीज लेवल्स ऑफ एसिटाइलकोलिन. हाँ, 3 स्लाइड बाद ब्रेक. चिंता मत करो, 15 दिन बाद पूरी ब्रेक होगी. जैसे मर्जी एंजॉय करना जिंदगी को. ल्यूई बॉडीज आर गोइंग टू बी सीन. दे आर गोइंग टू बी मेड अप ऑफ अल्फा सिनेप्लिन. अल्फा सिनेप्लिन. ठीक. ये 3-4 दिन तो खुशी या दुख भी रहेगा ना कि 200 नंबर आ गए. जिसके उसकी खुशी रहेगी, जिसके 200 नहीं आया वो दुखी होता रहेगा. 199 रह गए. इसलिए उस खुशी या दुख में अंदर नींद नहीं आएगी ना. हंटिंगटन्स डिजीज. हंटिंगटन्स डिजीज इज द वन विच इज गोइंग टू बी एसोसिएटेड विद सीएजी रिपीट्स. तो वो हंटर वाली कहानी याद है सबको. हंटर ने केज में बंद कर दिया एनिमल को. हंटर डोमिनेंट होता है, ऑटोसोमल डोमिनेंट. देयर इज इन्वॉल्वमेंट ऑफ क्रोमोसोम नंबर 4. हंटर ने हंटिंगटन डिजीज यूज करी, सीएजी रिपीट्स कर लिए. The patients are going to be having the presence of anticipation. With every subsequent generation, the disease is going to become worsen. With every subsequent generation, the disease is going to become worsened. That is what you need to remember regarding Huntington's. ठीक है, तो इन वाली दवाइयों के साथ में ये वाली चीज याद रख लीजिएगा. ठीक है. अल्जाइमर्स के ड्रग ऑफ चॉइस डोनेपेजिल, रिवास्टेजमिन, गैलेंटामिन, टैक्रीन, मिमेंटीन. पिक्स डिजीज के साथ में नहीं करना. पार्किंसोनिज्म की दवाइयां बता दी. हंटिंगटन्स के साथ में दवाई आपको पता ही है. बोल तो दिया, पता है, बता तो दो हंटिंगटन्स की दवाई. हाँ, बस वही चाहते हो, वही सीक्वेंस पूछ लूँ है ना. हंटर, सीएजी, ऑटोसोमल डोमिनेंट, उसके बाद वॉक्सकार वेंट्रिकल्स. हंटिंगटन की दवाई बता दो. पेपर 2 टेट्राबेनाजीन. शाबाश. टेट्राबेनाजीन. खुशी हो गई मुझे. ठीक है. Next example is with respect to something like breast cancer. With respect to breast cancer, this is the current classification that is under consideration. That is molecular classification. This is based upon gene expression profiling. 2 question exam के अंदर आ गए. Then we are going to be talking about 2 important subtypes. One which is going to be given the name of luminal A. इसमें कहानी आपको याद है. आंटी नंबर 1. So she is an elderly female. And number one means that we are talking about the most common breast cancer that is going to be seen in her. Estrogen progesterone receptor is going to be seen in her. And this is the one which is going to be a slow growing cancer. So it is going to be having the best prognosis. Luminal B is the one which is going to be associated with BRCA2 mutation. BRCA is breast cancer. These are example of tumor suppressor genes. The question asked in the exam, their function is DNA repair. So BRCA1 and BRCA2 are there. Both of them are associated with male and female breast cancer. But as studies show and as all of you know, BRCA1 is more strongly associated with female breast cancer. Ladies first. Ladies first. BRCA1. Ladies first. Ladies के साथ में ज़्यादा associated होता है female breast cancer. BRCA2 is what is going to be associated with male breast cancer. So this one is going to be having high mitotic activity. Prognosis is poor. The third one that we talk about over here is HER2 enriched. Too much of HER2 receptor. HER2 receptor is an example of what kind of a receptor? It's an example of a proto-oncogene. पहली चीज, it is a proto-oncogene. What type of proto-oncogene? Growth factor receptor, signal transduction protein, nuclear transcription factor. ये क्वेश्चन आंसर कर दोगे? जिंदा हो, सुन रहे हो? ग्रोथ फैक्टर नहीं है, ये ग्रोथ फैक्टर रिसेप्टर है. सो इट इज प्रेजेंट ऑन द मेम्ब्रेन. सो दिस इज गोइंग टू बी प्रेजेंट इन यंग फीमेल्स एंड दैट इज गोइंग टू बी एसोसिएटेड विद p53 gene mutation. Right? That is what you need to remember. And then we are going to be talking about something which is called as a basal-like cancer. Basal-like cancer means ER is negative, PR is negative, and HER2 is negative. ER negative, PR negative, HER2 negative. So it is also called by the name of triple negative breast cancer. अब जीवन में सब कुछ नेगेटिव होगा तो प्रोग्नोसिस कैसा होगा? खराब होगा ना? So this is going to be having the worst prognosis. And this is going to be having the worst prognosis. Practical is what is understood by you. When there is a presence of estrogen receptor, you can giving drugs, na? Tamoxifen दे सकते हो, anastrozole, letrozole दे सकते हो. When there is a presence of HER2, you can give drugs like pertuzumab or trastuzumab. But when there is no expression of receptor, तो क्या दोगे? फिर तो एंटी कैंसर दवाइयां देनी पड़ेंगी ना. They are very toxic. So aggressive cancer, and you do not have a targeted drug over here, so the prognosis happens to be really poor. This is about the breast cancer thing that we need to have an idea. Then they are asking a question on something in which there is a classical history of a female. She is an elderly female. She is going to be having a complaint that she comes to a clinic because she is having the presence of a bulky breast tissue. And on the examination, you find there is too much of a stroma in the form of leaf-like projections. Stroma, which is seen in the form of leaf-like projection. So leaf-like projection means that we are talking about the presence of a stroma that is going to be given the name of Phyllodes tumor. Phyllodes tumor. So leaf-like projections, that is going to be given the name of Phyllodes tumor. Big bulky breast. Big bulky breast. Now, because their tumor is going to be having a presence in the form of a leaf-like projections, so that is a nightmare for a surgeon in the sense that the surgeon will try to remove this tumor to the best of his capability, his or her capability, but still this tumor can be having a development of a recurrence. This tumor can be having a development of a recurrence. So you need to remember the fact, 50-year-old female, 60-year-old female coming with a complaint of big bulky breast, right? And on the microscope examination, you find there is a presence of a leaf-like projections because of too much of proliferation of stroma. We are dealing with a patient who's going to be suffering from Phyllodes tumor. The next one can be a female who's going to be having the presence of too much of a itching lesion around the nipple. There is a breast mass. This female is going to be having the presence of a breast mass. She is having too much of an itching over here. And because he's going to be doing too much of an itching, there is also a presence of an ulceration on the nipple. So this is what is going to be given the name of Paget's disease of nipple. Paget's disease of nipple. Right? Paget's disease of nipple. So Paget's disease of nipple is again an example of a condition in which the patients are not going to be having a very, very good prognosis for the simple reason that the patients are going to be having the presence of, this is what is going to be associated with the breast mass, and the patients are going to be having a dirty looking VP-like lesions over here. Again, not from the perspective, but these patients are going to be having the presence of Paget cells. They are going to be having the presence of Paget cells. And an easy question, which is the commonest example of a breast tumor with which a young female will come to your clinic because she is having the presence of a breast tumor, freely mobile, periodically increasing in size or not, that is going to be a fibroadenoma. That's going to be an example of a fibroadenoma. Right? That is what you need to remember over here. Okay. Then we are talking about an example of image-based questions pertaining to the topic of genital tract. Even though we have not done it earlier, but I would still like you to have an idea. The first one is what is going to be asked in the exam. This is what is going to be given the name of Ranke crystals. You already had gynae, you already had surgery, I'm told, but at least you can just remember Ranke crystals is going to be seen as a feature of these red-colored rectangular inclusions. Rectangular inclusions are going to be seen as a feature of Ranke crystals. Ranke crystals are going to be seen as a finding of a patient who's going to be suffering from a tumor that is given the name of Leydig cell tumor. It's going to be seen in a patient suffering from Leydig cell tumor. It's going to be seen in a patient suffering from Leydig cell tumor. This is a one which is going to be given the name of. This is going to be given the name of call external body. This one is going to be given the name of call external body. Call external body. Yeah, some technical glitch. Anyways, so call external body is what is going to be seen in a patient suffering from granulosa cell tumor. Granulosa cell tumor. Right? Ranke crystals, which is going to be seen in a patient suffering from Leydig cell tumor. This one is going to be seen in case of granulosa cell tumor. Then this one is going to be bilateral ovarian involvement. And it is having the presence of a signet ring appearance. So this is what is going to be given the name of Krukenberg's tumor. This is what is going to be given the name of Krukenberg's tumor. Krukenberg's tumor. So these are the ultra important images that are to be remembered by you for your exams. ये आनी चाहिए एग्जाम के अंदर लेडिक सेल ट्यूमर के अंदर रेंकी क्रिस्टल्स. You need to remember about call external body granulosa cell tumor, bare minimum for a screening exam. You need to remember about Krukenberg's tumor की bilateral ovarian enlargement है, patient is going to be having a signet ring appearance. If I'm going to be talking about this one, that's a classical image of the most common testicular tumor that is seen in case of a male. So I want you to be aware about an example of a tumor that is going to be given the name of a seminoma. Polyhedral cells which are going to be containing water-like watery cytoplasm. Polyhedral cells with watery cytoplasm because they contain glycogen and there is a presence of lymphocytic infiltration. Clear looking cells लग रहे हैं, clear looking cells लग रहे हैं, whitish glycogen होता है इसके अंदर. That's an example of a commonest testicular tumor, that is seminoma. That is what you need to remember. Then they talk about an example of a cancer in which patients are going to be having the presence of metastasis to the lungs that can be associated with the term cannonball metastasis. So this is what you associate in a patient who's going to be suffering from a cancer that is going to be given the name of choriocarcinoma. Choriocarcinoma, cannonball metastasis. Very, very important picture for your exam. पहले वाले में देगा कि 45-year-old patient या 35-year-old patient comes to you because of a testicular mass. It shows us the presence of a seminoma. सेकंड में दे रहा है आपको cannonball metastasis, choriocarcinoma. Choriocarcinoma का ट्यूमर कौन सा होता है जो आप एसोसिएट करते हो? बीटा एचसीजी इज गोइंग टू बी एलिवेटेड. एंड इसका फार्मा क्वेश्चन तो आसान ही होता है. कोरियोकार्सिनोमा का ट्रीटमेंट करने के लिए कौन सी एंटी ड्रग देते हैं? विच इज एन एग्जांपल ऑफ एंटी कैंसर ड्रग दैट इज बीइंग गिवन methotrexate. Methotrexate का मैकेनिज्म आपको पता ही है, डाइहाइड्रोफोलेट रिडक्टेज इनहिबिटर, सो इट कॉजेज मेगालोब्लास्टिक एनीमिया फॉर विच वी हैव टू गिव ल्यूकोवोरिन और फोलिनिक एसिड. चार क्वेश्चन हो गए. फिर हमारे आते हैं इस वाले ट्यूमर पे जिसका नाम है, सेम कहानी. Then we are going to be talking about an example of a condition in which this is the mass that is being given. This is what is going to be given the name of Schiller-Duval body. Glomerular body. It is also called by the name of Schiller-Duval body. Schiller-Duval body is going to be seen as a feature of a patient suffering from, yes, Ane. Very good, Dr. Krishna. Yolk sac tumor. That is going to be seen in a patient suffering from yolk sac tumor. चैट में तो हमारी मेरे को लग रहा है सिर्फ अरुणा लगी हुई है, मिस्टर अरुणा. मिस्टर अरुणा, सारे आंसर अरुणा दे रही है. ठीक है, योग सैक ट्यूमर. योग सैक ट्यूमर इज गोइंग टू बी एसोसिएटेड विद, नहीं वो लाइव चैट की बात करता हूँ मैं. योग सैक ट्यूमर इज गोइंग टू बी हैविंग द प्रेजेंस ऑफ मार्कर्स लाइक अल्फा 1 एंटीट्रिप्सिन एंड अल्फा फीटोप्रोटीन. और लास्ट वाला तो आपको पता चल गया, रेक्टेंगुलर इओसिनोफिलिस इंक्लूजन्स, दैट इज रिंकिस क्रिस्टल्स, दैट इज गोइंग टू बी सीन इन अ पेशेंट सफरिंग फ्रॉम लेडिक सेल ट्यूमर. राइट, सो दैट इज व्हाट वी जस्ट नीड टू हैव एन आइडिया ओवर हियर. विच जस्ट रिमाइंड्स मी ऑफ अ सिंपल फैक्ट. अगर ये आप 2 या 3 क्वेश्चंस आंसर कर दें, विच इज एन एग्जांपल ऑफ द कॉमनेस्ट ट्यूमर. which is an example of a commonest tumor. Let me say I am talking about a primary tumor. It's a benign tumor and that is seen in case of children. कौन सा brain tumor आंसर करेंगे आप इसमें? Which brain tumor will come to your mind? Primary benign tumor that is seen in a child. Primary benign tumor that is seen in a child. Primary benign brain tumor in a child. भाई इविंग सार्कोमा. अभिषेक मेरे दोस्त, इविंग सार्कोमा हड्डी का ट्यूमर है ना, ब्रेन की बात कर रहे हैं. जी मेडुलोब्लास्टोमा बता रहा है अभी यार. भाई मेडुलोब्लास्टोमा मैलिग्नेंट होता है ना. बच्चों वाला ट्यूमर पीडियाट्रिक एज ग्रुप का ट्यूमर है ना, पाइलोसिटिक एस्ट्रोसाइटोमा. क्यों भूल गए? फिर प्राइमरी ट्यूमर की बात कर रहा हूँ, मलिग्नेंट इन नेचर है, बच्चे में देखने को मिला, तो इसका आंसर करोगे मेडुलोब्लास्टोमा. अभी तो सवाल डिटेल में पूछा ही नहीं यार, ये तो बेसिक फैक्ट पूछ रहा हूँ. प्राइमरी ट्यूमर सीन इन केस ऑफ एन एडल्ट, इट इज बिनाइन इन नेचर. प्राइमरी ट्यूमर दैट इज सीन इन एडल्ट, दैट इज अ बिनाइन ट्यूमर. तो कौन सा ट्यूमर आंसर करेंगे? सबसे कॉमन बिनाइन ट्यूमर एडल्ट के केस में देखने को मिला है, मेनिनजियोमा. And then if I'm talking about an example of a tumor, primary brain tumor that is seen in an adult which is malignant in nature, that is going to be glioblastoma. Now these are the four options given in front of you. Which of them is going to be showing you the presence of butterfly appearance? Which of them is given the name of a butterfly tumor? That's easy, na? Glioblastoma. Which of them is going to be showing you the presence of Homerite rosettes? Homerite rosettes. Homerite rosettes is going to be a finding of a patient suffering from medulloblastoma. Which of them is going to be having the presence of Rosenthal fibers? Rose, Rose, pilocytic astrocytoma. Which one is going to be having the presence of Samoma bodies? Meningioma. ठीक है. सो बेसिक से फैक्ट्स हैं, ये तो हमें याद करने हैं. तो 8 क्वेश्चन तो हमारे एग्जाम के हो ही जाएंगे ना. हिस्टोलॉजिकल फाइंडिंग याद हो गई, प्रेवलेंस याद हो गई और हमें पता चल गया. दैट्स व्हाट यू नीड टू रिमेंबर. Talking about neoplasia, that's what you need to talk about. So pulmonary hematoma, even if I do not explain it to you, you already have an idea. There is a presence of popcorn calcification. There is a presence of popcorn calcification that is going to be seen in the patients. Then I'm talking about dermoid cyst. Dermoid cyst is a second name that is given to a teratoma. Dermoid cyst is a second name that is going to be given to a teratoma. It's an example of a tumor which is going to be having the presence of multiple origins of the tissue material present in it. It is going to be rising from more than one germ cell layer. So you can see the presence of a tooth-like structure. You can see the presence of a glistening mucin. You can see the presence of hair. So hair, mucin, fat, tooth-like structure all can be seen. That is what is given to be given the name of a dermoid cyst. It is an example of a teratoma. What is a teratoma going to be rising from? Teratoma rises from totipotent cells. Teratoma rises from totipotent cells. That's an easy one. That's an example of a Reed-Sternberg cell. Reed-Sternberg cell is going to be seen in a patient suffering from Hodgkin's lymphoma. Right? These are the examples of common important features of neoplasia. And that's the one-liners that you just need to have an idea for your exams. Metastasis is the most reliable feature of malignancy. There are two types of malignant tumors which do not spread. One which is going to be given the name of a glioma. Second one is going to be given the name of basal cell carcinoma. डर्मा हो गया क्या? इसके बाद है. डर्मा इसके बाद है. ठीक है. अगर बेसल सेल कार्सिनोमा के साथ में मेरे मरीज को सीएनएस ट्यूमर है, मेडुलोब्लास्टोमा, तो सिंड्रोम को क्या बोलते हैं? इफ अ पेशेंट इज गोइंग टू बी हैविंग बेसल सेल कार्सिनोमा एंड द पेशेंट इज आल्सो एट हाई रिस्क फॉर डेवलपमेंट ऑफ अ ब्रेन ट्यूमर कॉल्ड एज मेडुलोब्लास्टोमा, व्हाट इज दिस सिंड्रोम कॉल्ड एज? मैं नाम लिख देता हूँ, अगर आप पहली बार सुन रहे हैं तो मेरी रिक्वेस्ट है इसको नोट कर लेना. गॉर्लिन सिंड्रोम. गॉबलिन नहीं भाई, गॉबलिन अलग चीज थी, वहां नहीं जाना है वो एग्जाम के बाद. गॉर्लिन, गॉर्लिन सिंड्रोम. Basal cell carcinoma plus the patient is going to be having a CNS tumor by the name of medulloblastoma. Gorlin syndrome. ठीक, ये याद रखना है हमें. क्यों याद रखना है? बिकॉज ही विल आस्क यू क्वेश्चन है यार. बेसल सेल कार्सिनोमा इज एन एग्जांपल ऑफ अ लोकली इन्फिल्ट्रेटिव कैंसर. सो इट इज आल्सो कॉल्ड बाय द नेम ऑफ अ टीयर कैंसर ना. इट्स आल्सो कॉल्ड बाय द नेम ऑफ अ टीयर कैंसर. रोडेंट अल्सर और टीयर कैंसर इसके नाम होते हैं. It's an example of a cancer which is going to be arising from the inner canthus and it is going to be locally infiltrative. So it will go in this fashion. So locally infiltrative cancer, that is going to be given the name of associated with the term rodent ulcer. पहले नहीं पढ़ाया था, पहले नहीं पढ़ाया था, अभी तो आज पढ़ा रहा हूँ ना. मेरा मन कर रहा है कि इंपॉर्टेंट है सवाल, सुन लो. ठीक है. उसके बाद आपने इंपॉर्टेंट चीज क्या याद रखनी है? दैट फॉर पिकिंग अप द प्रेजेंस ऑफ अ कैंसर व्हाट वी आर हैविंग ओवर हियर इज अ कांसेप्ट ऑफ सेंटिनल lymph node biopsy. So applicable for multiple tumors, but these are the ones which are being given in the exam. Then talking about invasion, that is what is already known to you. Basement membrane is not affected, it is given the name of carcinoma in situ. And when the basement membrane is affected, it is given the name of invasive cancer. So it is applicable for so many cancers. I mean, in context of breast cancer, in case of colon cancer, in case of so many cancers, with or without involvement of basement membrane. If the basement membrane is affected, it is called as invasive cancer. If the basement membrane is not affected, that is going to be given the name of a non-invasive cancer. Then the third one that we talk about over here is given the name of rate of growth. High rate of growth. Now this high rate of growth is dependent upon an effect that is going to be given the name of Warburg effect. Aerobic glycolysis is what I want you to remember. Aerobic glycolysis is what you need to remember. हाँ ये अच्छा है वैसे शाह, गौर से सुन लेना. Aerobic glycolysis, what you need to remember over here, and this is a concept that you are going to be using with respect to PET scan. This is a concept that you will be using with respect to PET scan. Warburg effect, aerobic glycolysis. I hope we are clear with this one also. ठीक है. Then I'm going to be talking about anaplasia, which is an example of an irreversible change. Without a doubt. Anaplasia is an example of an irreversible change. What I want you to remember over here is the concept of that it is going to be associated as a feature of malignant transformation. It's an irreversible change, but that is going to be seen as a hallmark feature of malignant transformation. Of course, when I'm talking about cancers, I can be talking about lots and lots of examples of genes. Proto-oncogenes can be one example. Even if one gene is mutated, there is a risk of cancer. The second one can be tumor suppressor genes. When there are two genes which are going to be affected, they can cause cancer. I can be talking about an example of double hit hypothesis with tumor suppressor genes. And I can be talking about the example of genes which are going to be affecting apoptosis. So I can be talking about the role of P53 gene. I can be talking about the role of BCL2. Right? That is what you need to remember over here. सो डबल हिट के बाद में आपने भी एग्जाम के अंदर डबल सेंचुरी हिट करनी है, याद रख लेना। ये डबल सेंचुरी का मतलब है हमारे मिशन का नाम, यानी कि 200 प्लस। राइट, सो बिफोर आई साइन ऑफ आई जस्ट वांट यू टू अंडरस्टैंड अबाउट दीज इंपॉर्टेंट थिंग्स। क्विज टाइम तो मैंने वैसे लिखा हुआ है। मिसिंग सब्जेक्ट कोशिश करनी है कि हमारे रहे जीरो। यू शुड नॉट बी लीविंग एनी सब्जेक्ट एब्सोल्युटली bare minimum for your exam. Do not miss a subject completely. I just want to spend the last 3 minutes for your discussion. Do not leave any subject absolutely zero. Even if that subject means a small subject, so it can be having 5 questions, it can be having 7 questions, or it can be having 10 questions. Right? So the best thing is, मैं प्रॉब्लम बता रहा हूँ, मैं सॉल्यूशन भी बता रहा हूँ। इफ यू डू नॉट वांट टू लीव एनी सब्जेक्ट, द बेस्ट थिंग वुड बी लास्ट 10 ईयर्स के इसके पीवाईक्यूज कर लेना। लास्ट 10 ईयर के पीवाईक्यूज कर लेना। पॉसिबिलिटी है कि मैं ऐसे बोलता हूँ कि 30% क्वेश्चन आ गए उसमें से, 40 आ गए उसमें से, 30% भी आ गए तो आपका 10 में से 3 नंबर आ जाएंगे। सो एटलीस्ट जीरो नहीं होगा ना यार, प्लीज अंडरस्टैंड, यू गेट सम क्वेश्चन। देखो आप एग्जाम में आप देखो, व्हेन यू वॉच अ क्रिकेट मैच, सो अगर वो शुरू के अंदर हमारे ओपनर जो होते हैं रन बना देते हैं, तो मिडिल ऑर्डर के ऊपर और लास्ट वालों के ऊपर प्रेशर कम होता है ना। तो अगर आपके पेपर वन के अंदर आपने मान लीजिए क्वेश्चन रख लिया, ये 10 में से आपने 3 भी ठीक भी कर दिए। कुछ सब्जेक्ट्स पर्सनल फेवरेट होते हैं ना, मैं किसी का नाम नहीं लूंगा बिकॉज आई मीन, राइट, तो आपको क्वेश्चन मिल जाएगा कि आप बाकी एग्जाम में रिकवरी कर लो। ठीक है, नहीं तो क्या हो जाएगा कि आपका जीरो आ जाएगा। जीरो इज समथिंग विच इज गोइंग टू बी वेरी डेट्रीमेंटल, मतलब आपको मेंटली लगेगा कि स्क्रू अप हो गया एग्जाम। तो फिर क्या होगा कि पेपर वन को आपको हॉन्ट करेगा पेपर टू के अंदर। ठीक है, ये तो एक फंडामेंटल चीज है। पेपर के टाइम पे बिटवीन द ब्रेक्स यू डू नॉट हैव टू डिस्कस द पेपर विद एनीबडी। सो डू नॉट लीव एनी सब्जेक्ट एब्सोल्युटली मिसिंग इन द एग्जाम, ये कंसेप्ट रखना ही नहीं है। Yes, certain subjects carry more weightage with respect to the number of questions being asked or with respect to their integration. So give more importance to them. But that does not mean I say that for the fourth time that you can leave any subject unattended, uncared for. जिसकी बेइज्जती करोगे वो तुम्हारी बेइज्जती करेगा, मैं तुम्हें इतना बता रहा हूँ। जीरो मत करना, किसी की डिसरेस्पेक्ट मत करना, इज्जत दे देना, 10 साल के क्वेश्चन कर लेना। सेकंड इंपॉर्टेंट चीज है जो हम आपको बार बार बोलते हैं, वो होता है स्टूपिड फेथ। हो जाएगा हो जाएगा हो जाएगा, बोल दो अपने आप को ये बात। हो जाएगा, कैसे होगा नहीं पता, बट हो जाएगा। आई विल मैनेज टू क्रैक द एग्जाम, आई विल मैनेज टू पास द एग्जाम विद फ्लाइंग कलर्स। मैं आई विल नॉट बी एबल टू फ्लाई एट 35,000 फीट, मे बी एट 32,000 फीट, मे बी 30,000 फीट, बट आई विल फ्लाई, बट आई विल फ्लाई फॉर श्योर। सो स्टूपिड फेथ, हैव कीप रिमाइंडिंग योर सेल्फ दिस। मतलब इफ आई बी वेरी ऑनेस्ट, फॉर अबाउट 30% द पीपल हु आर प्रेजेंट ओवर हेयर, डिड यू एवर एक्चुअली बिलीव एट वन पॉइंट ऑफ टाइम दैट यू विल बी एबल टू वियर द लैब कोट? वाइट कोट पहनोगे ऐसा था? नहीं था ना यार, सच की बात है। मतलब मैं तो उसी पे जा रहा हूँ जो आप इंस्टाग्राम पे रील बनाते हो। राइट, कि दुनिया ने ऐसा कहा, दुनिया ने वैसा कहा, फिर भी तेरे भाई ने वाइट कोट पहन लिया तो पहन लिया, तो अब करेंगे ना यार। तो ये फेथ रखना अपने आप में, मतलब मेहनत करिए, कहीं तो पहुंचेंगे ना यार। मैं लॉजिकली बात कर रहा हूँ ना। हमने कुछ कोशिश करी है तो हम कुछ तो अच्छा करेंगे ना जीवन में। और अगर हमें गारंटी नहीं है तो अपनी तरफ से तो बेस्ट एफर्ट करें। तो ये वाला फेथ आपको रखना है अपने आप को, बार बार ये रिमाइंड कराना है। ठीक है, जब भी इस फेथ के अंदर आपको डाउट हो, तो आपने एक सिंपल चीज याद करनी है, आपने याद करना है सिर्फ और सिर्फ अपने पेरेंट्स को। सिर्फ और सिर्फ पेरेंट्स को। वो आपके साथ हर सुख दुख में खड़े हैं। उनके बियॉन्ड यूजुअली हम बोलते हैं कोई खड़ा नहीं होता, बट आपके टीचर्स खड़े हैं। राइट, सो द इंपॉर्टेंट थिंग दैट वी टॉक अबाउट ओवर हियर इज दैट यू हैव टू जस्ट गिव योर सेल्फ अ मोटिवेशन। अब यू जस्ट हैव टू विजुअलाइज वन थिंग, वंस आई एम एबल टू क्लियर दैट एग्जाम, आई जस्ट हैव वन इंपॉर्टेंट एम, आई हैव टू स्माइल इन द मोस्ट ब्यूटिफुल वे। है ना, स्माइल प्लीज मतलब चीज ना। सो यू हैव टू स्माइल, दिस इज यू, अ कॉन्फिडेंट यू, एंड दिस इज विद योर ब्लेसिंग्स ऑफ योर पेरेंट्स। यहाँ पापा है, यहाँ मम्मी है, यहाँ बीच में तुम हो। ये विजुलाइज कर लेना फोटोग्राफ, तुमने ये फोटोग्राफ मेरे साथ शेयर करनी है। दिस इज द ओनली थिंग दैट यू हैव टू डू। ठीक है, ऑल जोक्स अपार्ट, आई डोंट नीड एनी ऑफ योर बॉक्सेस ऑफ स्वीट्स, गिफ्ट्स, एनीथिंग। गॉड हैज बीन वेरी काइंड टू मी, तुम मुझे ये कर देना, इतना इतना बहुत है। बाकी जो करना होगा हम सेरिबेल हम में देख लेंगे। ठीक है, तो मैं फिर से बोल रहा हूँ, सब्जेक्ट कोई भी नहीं छोड़ना भाई। ठीक है, दूसरा, हमें अपने बार बार विश्वास करना है, बार बार वी हैव टू रिमाइंड आवरसेल्व्स वी विल क्लियर द एग्जाम। एंड द सेकंड थिंग इज यू जस्ट हैव टू विजुअलाइज योरसेल्फ इन द सेंटर, राइट, लेफ्ट, पेरेंट्स, guardians, siblings, it could be anybody who's taking care of you as of now, and just share this photograph once you crack that exam with me. So go with that attitude that I want to send that photograph, मेरे को सर को फोटो शेयर करनी ही करनी है। ठीक है, डर लग रहा है, बिल्कुल नॉर्मल है। मैंने 50 बार बोली है सेम चीज, जो बिल्कुल टॉपर होते हैं तो उनको डर नहीं लगता, या जिन्होंने बिल्कुल पढ़ाई नहीं करी होती उनको डर नहीं लगता। अगर आपको डर लग रहा है, इट्स अ गुड साइन, इट्स अ गुड प्रोग्नोस्टिक फैक्टर, राइट। बट उस डर पे काम कर लीजिए। मतलब अगर हमने चीजें सुनी हुई थी, हमें याद नहीं आई, इसका मतलब है रैक ऑफ रिवीजन है। अगर हमने बिल्कुल ही नहीं सुन रखी, इफ आई वॉज नॉट एबल टू रिकॉल एनीथिंग विच वॉज बीइंग टेल्ड, आईकोटेक नहीं आती, प्रॉब्लम नहीं है यार, कुछ तो मेरे को भी मुझे लेने देने का हक दोगे ना। लेकिन लिस्पुरास्पार्ट नहीं आ रही, ग्लार्जीन और डिग्लूटेक याद नहीं आ रही, तो मुझे कष्ट होगा। हाँ हाँ, बच्चे के साथ भी भेज सकते हो, कैसी बातें कर दी, मोस्ट वेलकम यार। फैमिली के साथ भेजनी है, मतलब फैमिली को, मतलब यार ये जो फोटोग्राफ है ना, तुम्हारी लाइफ टाइम अचीवमेंट है। एक तुम्हें डिग्री मिली जीवन के अंदर, वो तुम्हारा लाइफ टाइम अचीवमेंट है, जिसको तुम मेडल बना के पहन लेना। राइट, और एक ये वाली फोटोग्राफ होगी, तुम रियलाइज करोगे, अभी रियलाइज नहीं करोगे, ट्रस्ट मी। आप में से बहुत सारे लोग यू रियलाइज दिस 10 years और 20 years डाउन द लाइन। दिस फोटोग्राफ इज गोइंग टू बिकम अ प्राइसलेस मेमोरी ऑलवेज इन योर लाइफ। ठीक है, सो जस्ट गो विद दिस पर्टिकुलर थिंग एट द वेरी मिनिमल, एट अ सिचुएशन वेर आई कैन टेक योर लीस्ट टाइम एज दिस पॉइंट ऑफ टाइम, दैट इज ऑल आई कैन टेल यू। ठीक है, एंड ऑफ कोर्स माई बेस्ट विशेज शेल ऑलवेज बी देयर फॉर योर बेस्ट परफॉर्मेंस इन द एग्जाम। So do take very, very good care of your health. Go for your best shot in the exam and perform to the best of your capability. All of you actually are genuinely very, very special for me, irrespective of whatever marks that you score. Don't give me one exam. मुझे उससे भी परेशानी होगी इफ यू टेल मी कि मेरे 210 आए लेकिन मैंने मेहनत नहीं करी। ऐसा होता नहीं है वैसे। बट ऑल आई वॉन्ट इज यू शुड बी कॉन्फिडेंटली फेसिंग योर ओन सेल्फ, यू शुड बी प्राउड ऑफ योर सेल्फ दैट आई गिव माई बेस्ट शॉट। That is all I want from you, right? And I can assure you that things are going to get far, far better than wherever you are as of now. ठीक है, चलो, डू टेक वेरी गुड केयर ऑफ योर सेल्फ यार। कन्वे माई बेस्ट रिगार्ड्स टू पीपल बैक होम, बैक इन द फैमिली। इट कुड बी योर फादर, इट कुड बी योर मदर, इट कुड बी बोथ ऑफ देम, इट कुड बी योर सिबलिंग। जेन्युइनली बोल रहा हूँ, उनको बहुत थैंक यू बोलना, उन्होंने बहुत मेहनत करी आपको यहाँ तक लाने के लिए। आगे भी वो आपके साथ खड़े रहेंगे। एंड जस्ट लाइक देम वी एक्सपेक्ट दैट वी ऑल्सो आर एबल टू शेयर योर हैप्पी मेमोरीज एट द अर्लीस्ट, राइट? So do convey my best regards to them. And of course, your in-laws as well, ma'am. Without a doubt, your kid as well, ma'am. Your sir, जो भी मतलब, I don't know. मतलब आपके nicknames है मुझे नहीं पता चल रहा है. But the point is that a lot of people are having their eyes on you. A lot of people have their expectations from you. So do absolutely, absolutely all the efforts for making each one of them proud. It could be your teachers, it could be your parents, it could be your sibling, it could be your kid, anybody. हाँ जी, बैटमैन बिल्कुल। तो उनको बहुत धन्यवाद बोलना भाई, तुम पढ़ पा रहे हो यहाँ पे शांति से 3 घंटे, 4 घंटे, 8 घंटे, जो भी कर पा रहे हो, इट इज ऑल थैंक्स टू देयर सेक्रीफाइसेस। लेट अस नॉट डी वैल्यू देयर सेक्रीफाइसेस, लेट अस वैल्यू देम एंड लेट अस ट्राई टू क्रिएट अ बेटर ह्यूमन आउट ऑफ आवर ओन सेल्व्स। मुझे किसी से कंपटीशन करना ही नहीं है, आई जस्ट हैव टू मेक अ बेटर वर्जन आउट ऑफ माई सेल्फ। आई होप दैट इज क्लियर टू ऑल। Thank you so much. Take adequate rest. Take tea, coffee, water break, whatever you wish to before you start off with the next session. And all the best again from my side. Thank you so much. Convey my deepest regards. Bye bye. I hope to see you soon at Cerebellum. Bye.